topic for discussion is not only restricted to our obstetric specialty, but relevant to the general society too. Rudyard Kipling has famously quoted that female of the species is definitely deadlier than a male, and the ability of female to reproduce is one significant reason why he says so. Motherhood is one of the most strong and basic instinct of the female, which brings joy and color in her life. Recurrent pregnancy loss causes not only the physiological issues, but also a cause of psychological, emotional, and social trauma to any family. A woman suffering from recurrent pregnancy loss is known to have issues of anxiety, sleep-related issues, depression, lower self-esteem, and so on. Statistics says 15% women suffer from pregnancy loss and 1 to 2% of women suffer from recurrent pregnancy loss. The statistic information is probably enough to stress our enormity and magnitude of this condition. On this backdrop, I am sure every one of us can gauge the significance of today's CME. Thank you. Over to you, Supriya and Nisha.
Thank you, Archana. Now we are starting with our first session, Back to Basics. I would like to invite our chairperson for the same, Dr. Vijay Pawar sir and Dr. Nanda Magai ma'am. Dr. Nanda Magai ma'am is MBBS DGO FICOG. She is a consultant obstetrician and gynecologist since 26 years, currently practicing in her private clinic. She is specialist in laser cosmetic gynecology. Madam was President Solapur Obstetric Gynec Society 2019-20. She is recipient of National Foxy Best President Trophy and made all of us proud.
Welcome, sir. Dr. Vijay Pawar, sir. He is MD, DNB, DGO, DFP, FCPS, MNA, MS, FMAS. He is consultant at SIMS Fertility Center. Presently, he is Associate Professor at VM Medical College, Solapur, and Unit in charge. He is ex-clinical associated regenesis at Center for Art, Endoscopy and Fetal Medicine in 2007. He did the fellowship in ART and follow of minimal access surgery, India. Thank you, sir. Over to you, sir, ma'am.
Good morning, everybody. Welcome to this wonderful CME. At the outset, I would like to thank Dr. Anjali and her team for giving us an opportunity to...
Especially if you feel that time is running out. Yes, miscarriage definitely causes untold pain to the affected families. 1 in 4 pregnancies end in miscarriage. Let's discuss how and why miscarriages occur. Basically, we see 10% of the miscarriages in early pregnancy, but 30% occur prior to even implantation and 30% following implantation. So, miscarriages is a frequent natural event occurring in approximately 20 to 30% of the pregnancies. Almost 22 of the pregnancies are lost before clinically recognized. In nearly 80% of the pregnancy loss occur in the first trimester. Unfortunately, spontaneous miscarriages rates are higher in the Indian population compared to the Western ones. Age, maternal obesity, excessive caffeine, alcohol intake are known risk factors to the miscarriage. Some basic definition. Threatened miscarriage. Actually, it has a threat to miscarry. The vaginal bleeding has already started, but there is no cervical dilatation before 20 weeks. So we have scope to save this pregnancy. Septic miscarriage, spontaneous miscarriage complicated by intrauterine infection, inevitable. Dilated cervical os, but the product of conception have not been expelled. Recurrent miscarriages. There are many school of thoughts, but 3 or more consecutive pregnancy losses is termed as recurrent pregnancy loss. Miscarriage. Fetus dies in utero, but no uterine activity to expel the product of conception. So according to the UK, 3 or more consecutive losses should be termed as a recurrent pregnancy loss. But according to the American Society of History, we have to do the investigation after 2 or more consecutive pregnancy losses. According to the WHO, loss of fetus weighing less than or equal to 500 grams at 20 to 22 weeks of gestation. So 10 to 15% of pregnancy result in spontaneous miscarriage. It is one of the events for that woman. But if it happens recurrently, then it counts for 0.5 to 2% of the pregnant women. So it is again primary, secondary and tertiary. Primary in multiple losses in a woman with no previous viable infant. Multiple losses in a woman who has already has a pregnancy beyond 20 weeks of gestation, we term it as a secondary. When there is a multiple pregnancy losses between the two normal pregnancies, then we term it as a tertiary. There are many causes for the possible causes for the miscarriages. It can be infection, hormonal, metabolic, nutritional, genetic, maternal age, paternal factor, lifestyle and environmental factor. If you work out these females, 50% of the RPL cases can be explained by such factors. So what it means? That 50% of RPL have no workup, negative workup, and we have to label them as unexplained or idiopathic. So unexplained for us also and for the patient also. Maternal age and number of previous miscarriages are two independent risk factors for further miscarriage. Advancing maternal age is associated with decline in both number and quality of the remaining oocyte. This is the study conducted in United Kingdom. 12 to 19 years of the maternal age group, the loss is only 13%. But you can see with the increasing age, the group between 45 years, it is almost 93%. So, advanced paternal age also has been identified as a risk factor. So, the couple, the mother who is 35 years of the age, the father who is 40 years of the age, is highest among the cases of RPL. So, we have to sensitively inform that the risk of pregnancy loss is lowest when the woman is aged between 20 to 35 years, and on the other hand, we have to sensitively inform them that loss rapidly increases after the age of 40. If we find the male partner, then it is suggested to assess lifestyle factors, smoking, alcohol consumption, exercise pattern, and body weight. Assessing sperm DNA fragmentation in couple with RPL can be considered for exploratory purpose only. The second most common cause is antiphospholipid syndrome. Antiphospholipid syndrome refers to association between antiphospholipid antibodies, lupus anticoagulant, anticardiolipin antibodies, anti-beta to glycoprotein 1 antibodies. So what is the Sarovar's criteria to diagnose antiphospholipid syndrome? If there is a 3 or more consecutive miscarriages before 10 weeks of gestation, or 1 or more morphologically normal fetus, but we lost the pregnancy after the 10th week of gestation, or 1 or more preterm birth, the 34 weeks of gestation due to the placental disease. So the mechanism probably the inhibition of trophoelastic function, differentiation, activation of complement pathway, or in later part of the pregnancy it can be thrombosis of the uteroplacental vasculature. So antiphospholipid antibodies are present in 15% of women with recurrent miscarriage. In women with recurrent miscarriage associated with antiphospholipid antibodies, the live birth rate with no pharmacological treatment is reported as low as 10%. And when we give pharmacological treatment, it is about 54%. So we have to evaluate every woman with RPL after 2 losses for the anticardiolipin antibodies and lupus anticoagulant. Genetic factor plays a major role. 2 to 5% of the couple with recurrent miscarriages, one of the partner carries a balanced structural chromosomal anomaly. It can be a balanced reciprocal or Robertson translocation, aneuploidy chromosomal imbalance as a result of parental Harbor translocation, deletion or duplication of genetic information, and single gene mutation. The finding of an abnormal parental karyotype. What we have to do, we have to prompt referral this patient to the clinical geneticist. So, all couple with the result of an abnormal fetal or parental karyotype should receive the genetic counseling. All couple with the result of an abnormal fetal or parental karyotype may be informed about the possible treatment option, including their advantages and disadvantages. This is the same one. So we have to do parental karyotyping, but not routinely. And if we find, we have to refer them to the geneticist. Anatomical causes, there can be congenital or acquired, septate, intrauterine adhesions, bicornuate uterus, unicornuate uterus, didelphic, T-shaped, submucous fibroids, large endometrial polyps. Congenital uterine malformation accounts for 1.8 to 37.6%. It is more common in second trimester.
But the metroplasty or uterine septum resection, the ISHRI doesn't support it, but we have to evaluate the individual patient. Cervical weakness. Cervical weakness is recognized cause of second trimester miscarriage, but the true incidence is unknown. The diagnosis is usually based on history of second trimester miscarriage, preceded by spontaneous rupture of membrane or painless cervical dilatation. So all women with RPL should assist the uterine anatomy. We have to do 3D ultrasound. Sonosalpingohistography is also one of the role. MRI is not recommended routinely. So what are the endocrine causes of the RPL? Almost 8 to 12% of the recurrent pregnancy losses, endocrine factors are attributed. Luteal phase deficiency, antithyroid antibodies, diabetes mellitus, high HB1AC leads to first trimester miscarriage and even fetal malformation. The PCOS also attributed to the RPL, but the exact mechanism remains unclear. We have to think about the insulin resistance, hyperinsulinemia, or hyperandrogenemia. Even some endocrinological aspect of endometriosis is also one of the cause. So we have to do thyroid screening, abnormal thyroid antibodies, but assessment for PCOS is not routinely recommended. Immune factor. There is no clear evidence to support the hypothesis of human leukocyte antigen incompatibility between the couples. The absence of maternal leukocytotoxic antibody or the absence of maternal blocking antibodies. Hence, they should not be offered routinely in the investigation in couple with recurrent miscarriage. So, testing anti-HLA antibodies in women with RPL is not recommended. What is the role of infective agent? Actually, any severe infection that leads to bacteremia or viremia can cause sporadic miscarriage. So, it is most of the time one of the event. So, the role of infection in recurrent miscarriage is unclear. So, torch screening should not be done. So, major important factor, lifestyle issue and environmental toxin. Tobacco, alcohol, obesity and caffeine. These increases the risk of miscarriages about 1.5 to 2 folds. Ideally though, like nowadays, because of pandemic and all the things, obesity is also pandemic. And thanks to Zomato and Swiggy, they are providing doorstep services to us. But it's our responsibility that striving for a healthy normal BMI is advised. Couple with RPL should inform that excessive alcohol consumption is possible risk factor for pregnancy loss, and they should have for the health style modification. What are the inherited thrombophilia defect? Both inherited and acquired thrombophilias, including activated protein C resistance, deficiency of protein C, S, antithrombin 3, hyperhomocystinemia, prothrombin gene mutation. These are the established causes of systemic thrombosis. So, do we really need any woman to do all the investigation with the RPL for hereditary thrombophilia? No, the evidence doesn't support it. So, these are the possible suggested diagnostic evaluation of recurrent pregnancy loss. If we found the genetic, we have to do parental karyotype. For anatomical causes, HCG and office hysteroscopy. Endocrine, we have to do TSH, prolactin. Infectious, no role. Autoimmune, anticardiolipin antibodies and lupus anticoagulant. And non-phospholipid antibody syndrome if we are suspecting. Then we can go ahead with homocysteine, factor V Leiden, prothrombin promoter mutation, and protein C resistance. So what it means? One bad chapter doesn't mean that story is over. No. So we have to treat these patients with tender love and care in dedicated pregnancy care unit. It is the best medicine to help these women. Thank you.
Thank you, Dr. Archana, for your excellent talk. Any questions for the speaker? I think she has covered everything, so either everybody has understood everything or nobody has understood. So it's an excellent talk. What is important in this is that around half of your patients will not have a diagnosis within the idiopathic. So you can say that the condition of the patient is pathetic and the doctor is an idiot. So he still doesn't know 50% of the causes within idiopathic. So now coming to the next talk, it will be given by Dr. Monica Ummanan. We all know about her. She'll be the, I think in next 10 years we should see her as a Foxy president. Looking the way she's working and working in so I'm sure we'll have another Foxy president in the next years.
Is this statement legally allowed?
No. I am better in Solapur.
We'll be talking about approach to diagnosis of recurrent pregnancy loss.
At the first instance, I would like to thank Dr. Anjali Jamma Madam for giving me an opportunity to speak on this forum. And I also would like to thank Archana for doing my job a little easier, because this will be only a summary of what she has already spoken. Approach to diagnosis in recurrent pregnancy loss. What your brain does not know is your eyes cannot see. So when we take a history for a patient who is having a recurrent pregnancy loss, the first and the foremost thing is history taking. We should know what is the gestational age of the loss and what could be the possible etiological factors from her history. So first is a maternal age, because increasing maternal age is an independent risk factor for aneuploidy. Then the number of previous miscarriages, which is also increasing number of miscarriages, would be a direct factor for the future miscarriage. A patient with diminished ovarian reserve undergoing an IVF will have a higher chance of having abnormal oocytes and hence an increased risk of aneuploidy. Plus, she would also have factors like luteal phase defect, so there will be an increased chance of miscarriage. Increased maternal age related to poor placentation as well as implantation failure, so higher chances of having a missed abortion. Secondly, from the history we should be able to find out whether it is a primary etiology or a secondary etiology for recurrent pregnancy loss, whether it is a more of innate immunological factors like the autoantibodies, the ANA and the SLE, or whether it is secondary to the adaptive immunological process of the body, which is the increased protein C resistance and others. Secondly, infertility also contributes to the advanced maternal age and recurrent pregnancy loss. The last menstrual period of the patient and the gestational age has to be calculated. Paternal age is also an independent risk factor, because increase in the age may lead to DNA fragmentation and cause aneuploidy. Maternal cigarette smoking, caffeine, alcohol consumption and environment toxin exposure history has to be elicited. Maternal BMI has to be calculated. The routine test should include TSH and HbA1c at the booking visit. Now, this is the most important fact that I wanted to highlight in my talk, is because we are very reluctant in sending the fetus for karyotyping or the POCs for karyotyping. There has been a paradigm shift. Initially, there would be torch infections that were screening. Then we had other immunological factors which came up for screening. And then we come to the paternal karyotype. But nowadays, the evidence has shifted that if she is having 2 or more losses, we should not wait for the third one and send the fetus for karyotyping or the product of conceptions or karyotyping, and accordingly we decide what has to be done later. Initially, the karyotyping of PSC was considered as difficult and unreliable because it was associated with risk of maternal cell contamination, failed culture, and risk of false negative results. However, due to availability of single nucleotide polymorphism microarrays, comparative genomic hybridization, which is now available, these results are now reliable and reproducible. So if there is 2 or more losses, we do fetal POC karyotype. If the karyotype is euploid, then the further workup for recurrent pregnancy loss, which would include other immunological factors, thrombophilias and others, have to be done. If the baby is aneuploid, then no further evaluation would be required on the metabolic front for this patient. Unbalanced translocation or inversion, if found in the fetus, then parental karyotyping, SOS, pre-implantation genetic diagnosis could be offered to this couple in the next pregnancy. This is what I wanted to highlight, because this is what has been now practiced. What would be the pre-pregnancy workup? This is the general physical examination, body mass index, blood pressure, complete blood count, blood group and RH typing. Very important, because we miss out on RH negative mothers, and anti-D is not often given in first trimester and second trimester losses. Viral markers and rubella antibodies.
Other hematological investigations would include lupus anticoagulant, anti-cardiolipin antibody, anti-beta-2 glycoprotein 1 antibodies, anti-thyroid antibodies if they are indicated. Screening of infective agents like torch panel is now limited because these infective agents which can cause placental barrier are the only ones which need to be screened. However, bacterial vaginosis is an independent risk factor for preterm. That is why screening for bacterial vaginosis is recommended in patients with first trimester losses. Screening for inherited thrombophilia defects like factor V Leiden deficiency, protein S deficiency, activated protein C resistance, the methyl tetrahydrofolate mutation, but it is not recommended routinely. If lupus screen test is found positive, then it has to be repeated after 12 weeks. Use of lupus anticoagulant, dilated Russell Viper venom with platelet neutralization is more sensitive as compared to activated partial thromboplastin time or covalent clotting time. A routine ultrasound in the first trimester would help us to assess the gestational age, the number of fetuses, the chorionicity and viability in case of multiple gestation, placentation, presence of cardiac activity. Reassurance scans reduces significant stress on the would-be parents, and this is very, very important. Just showing them that the cardiac activity is present is also very important to reduce the stress that this couple is going through. Transvaginal ultrasound in the prenatal phase will help us to identify arcuate, septate or bicornuate uterus, well as giving us an opportunity to manage the same in the pre-pregnancy period. A routine ultrasound beyond 14 weeks would help us to assess the cervical length and see the internal os condition, thus allowing us to decide upon the cervical encerclage for this patient. It will also help us to diagnose any intramural fibroid size and the effect on the pregnancy. This is a table in short where the investigations would be targeted depending upon what etiological factor we are considering. For the uterine factor, we have a 3D ultrasound, hysterosonography, hysterosalpingography, and MRI. For antiphospholipid syndrome, we have anti-cardiolipin antibodies, the anti-beta glycoprotein 1, the lupus anticoagulant, thyroid, prolactin, fasting glucose, HbA1c, and karyotype. Genetic factors including karyotyping of the products of conception and SOS if required parental karyotype. Environmental factors would be screening for smoking, drug use, excessive alcohol and caffeine intake. Psychological unexplained causes like luteal phase deficiency would be mid-luteal progesterone support and endometrial biopsy in the pre-pregnancy phase. For chronic endometritis, endometrial biopsy would be recommended. Other infection cultures would be recommended. And for the male factor, DNA fragmentation test on the sperm. Now, these are the genetic evaluations which we generally recommend for the POC. That is fish. If the patient is not very affording, then fish for only 7 chromosomes, that is 13, 18, 21, XY, 16, and 22. A complete genomic hybridization microarray is a preferred test as it identifies small defects like microdeletions, single gene defects, and point mutations. The next generation sequencing would be preferred to pick up smaller genetic defects involving a few base pairs like single mutation, but this is a little more costlier. If the POC shows a genetic abnormality, then both parents have to be tested for balanced translocation. If this message is clear, the purpose of this lecture is solved. Last but not the least, tender loving care and reassurance to the couple goes a long way in treating these couples. Thank you so much.
As usual, you have told us where we were before and what are the work to be done now. Thank you so much.
Thank you, our chairpersons, Nanda Uday ma'am, Dr. Vijay Pawar sir. I request you to felicitate our speakers. Nanda ma'am, please felicitate Dr. Archana Khare. Dr. Vijay Pawar sir, please felicitate Dr. Monica.
I request Anjali ma'am to please felicitate our chairperson. Now we move on to the inauguration function. एकत्र येणे ही सुरुवात, सोबत राहणे ही प्रगती आणि सोबत काम करणे म्हणजेच यश. यशोगाथा खूप आहेत, पण आज आपण येथे जमलो आहोत असं काही बोलायला आणि ऐकायला तो एक रहस्यमय विषय आहे. Recurrent pregnancy loss. For this, I request and welcome our President, Dr. Anjali Jamma Madam, to escort our guest speakers for the inauguration of this ceremony on the stage. Dr. Chaitanya Datar sir, Dr. Ajit Patil sir, I welcome the gems of SOGS and our very own Dr. Rajiv Dabre sir, Dr. Manik Guram sir and Dr. Sudesh Doshi sir to join on the dais. Lastly, I welcome our dashing secretary, Dr. Archana Khare, to join them on the dais. I request Dr. Pratibha Baldava and Manisha Patil ma'am to please join on the dais. Welcome all the dignitaries. Dr. Mala Arora ma'am will be joining us online on Zoom. I request our President, Dr. Anjali Jamma ma'am, to give her presidential address.
I take this privilege to welcome our esteemed speakers, chairpersons, teachers, seniors, and my dear friends. As per our theme, this year basics and nuances, we have decided to cover all the topics which we come across day in and day out. All of us are well aware of the importance of recurrent pregnancy loss in many spheres in our practice. Nearly 15% of women are affected with RPL. Young or old, expert or new, no obstetrician has gone untouched with this, but still every patient of RPL comes with a new set of challenges and which spins us around. It is essential to update ourselves with newer developments so to save the pregnancy and elevate the couple. The beauty of motherhood is not in reproduction, but in inclusion. To experience another life as a part of yourself and losing a part of yourself repeatedly is unbearable. To help such patients in a better way, we are here. When planning CME, it is imperative to gain participation of experts in the field. And so here I would like to thank our outstanding speakers, Dr. Chaitanya Datta, Dr. Ajit Patil, Dr. Mala Arora, Dr. Suchita, and our proud SOGSian speakers. Thank you, chairpersons, and all of you for attending in large number. I know it will be a long day, but I'm sure that at the end of this CME, whatever may be the cause of RPL, whether metabolic, genetic, hormonal, anatomical, or immunological, we will be able to tackle it more efficiently. Thank you once again.
Thank you, Jama ma'am. A lamp emits such a light that makes the paths bright, dispels the darkness around, and lamp illuminates every side. Those who go off the path, the lamp shows the right path. To fulfill its aim, the lamp serves us all with its might. I hope this Diya today enlighten us all and show the right path to help all the women with recurrent pregnancy losses. I request all the dignitaries on the dais to please come forward for the lamp lighting ceremony. Thank you all the dignitaries on the dais. I declare the inauguration ceremony and call on all the dignitaries to take their seats off the stage.
Yes. Okay, sir. Thank you.
Thank you, everyone. This year, we are going to witness a never-before event in our society, the Clinical Pearl, for which I call upon Dr. Jama Madam to introduce Clinical Pearl. Over to you, ma'am.
Friends, as promised, we will release 2-minute video every month, Clinical Pearls in just 2 minutes by experts. It gives me great pleasure to begin this activity with video by none other than our beloved teacher, Dr. Suman Sardesai ma'am. She is a great academician and very popular teacher, teaching since last 32 years. She is a winner of 2 Foxy Korean Awards and she is an inspiration to all of us. Clinical Pearls will be answers to all your queries in one click. Do's and don'ts of important topics will be covered in 2 minutes. We will be more than happy to incorporate your ideas and welcome your active participation. I request Dr. Monica to escort Dr. for inauguration of clinical. Slide.
Modified Shirodkas and Satya. Cervical insufficiency is one of the causes of recurrent pregnancy loss in the second trimester. The diagnosis of cervical incontinence is done by transvaginal sonography, which is the gold standard. While doing routine examination for anomaly scan, we may come across a cervical os showing funneling of the internal os with a Y or V-shaped membranes bulging. In such situations, there is indication for doing cervical encerclage. Commonly, technique which is employed is McDonald's encerclage, but this technique is likely to fail because there is a very short functioning cervix below the membranes, and that is why I strongly recommend that we should adopt modified Shirodkar's encerclage. For the technique of modified Shirodkar encerclage is the cervix under anesthesia. The cervix is held, both the lips are held. Saline adrenal infiltration is done on the anterior lip of cervix and the vagina. Transverse incision is taken and vagina is retracted upwards and held with anterior vaginal wall retractor. A stitch on a curved needle, plaxel, is taken and passed anteroposteriorly through the substance of the cervix as high as possible and passed from left on one side from 10 o'clock and it comes out at 7 o'clock posteriorly. Similar step is repeated on the other side where the needle passes from 2 o'clock and comes out at 5 o'clock and then the knot is tied posteriorly. This procedure is the height of the cervix. This is called cervical height, where the distance between the stitch and the internal os is significantly shorter than McDonald's stitch, and that is why this has the advantage of Shirodkar stitch being as close to the internal os and it has the simplicity of McDonald's procedure. I strongly recommend my colleagues to adopt this procedure in patients where the cervix is very short with bulging membrane of V and Y shape. Thank you.
Thank you so much, ma'am. I request Dr. Sadhya ma'am to speak a few words for this innovative idea of the clinical pearl and give her blessing for the same.
Dr. Anjali Jamma, President, Solapur OBGYN Society, and her team members, and my colleagues over here. Actually, I was wondering as to what am I going to speak after I have already said about this subject. But they say that you say something so the others will also participate in this clinical course. They want the people to come forward and give their experiences during of their clinical practice, which is called clinical pearls. Now, about this subject, which I have given them as modified Shirodkar encerclage. Now, I am not going to talk about the procedure as such, how it came to me, or why I chose this topic was that it was in 1990, Caspian et al. Published this work on modified Shirodkar encerclage. How I came across this was while doing in one of our journal club meeting in medical college. One of my student doctors, Shweta Mittal, who is at Gangaram Hospital, read this article and in American, this was published in American Journal of OBGYN. And I was really surprised that in American Journal coming this article as modified Shirodkar encerclage was something very exciting for me. I went through that article, I did that and I found that subject technique very quite simple. And we did many cases. I had a series of it, we did a thesis on it, then published, this has been published, this work has been published in Foxy Journal, all that. But till then, I was looking at this procedure just as an alternative to McDonald's, that there is McDonald's and this is it. But recently, I realized that this is just not an alternative to McDonald's stitch, but this is much more than McDonald's stitch. Why? Because now we know, we all screen the patients at the time of anomaly scan, the cervical status is seen, and if we find that if there is V-shaped or Y-shaped membranes, where the membranes are funneling at the internal os, that is an indication for doing an encerclage. Doing McDonald's cerclage, the stitch is going to be, because the cervix is very short, functioning service, what is called, is very short, and if we take McDonald's Street, it is very likely to fail. And that is why I realized that this procedure is going to be of great help, where we have to push the anterior vaginal wall retractor and dissect the anterior vaginal wall and then take a stitch as high as possible. So this method, which is simple. Another thing that up till now, even now, anything you do by McDonald's, even I was of the opinion that it should be done. And we used to do under short general anesthesia. Now my concept has changed. We need not be in a hurry. We can do under regional anesthesia and dissect the anterior vaginal wall and take the stitch properly as high as possible. Now this stitch is going to be at a higher level than, much higher level than McDonald's stitch. Technically it is very simple, and the chances that it will succeed is much more, and that is why I thought of talking about this. And also that we all have been, at least as I have worked with Dr. B.B. Kulkarni, Shirodkar name has been so close to me. Then we had the Shirodkar sling, etc. So that when I read this article in American Journal, modified Shirodkar encerclage, so the due respect or due consideration should be given to this technique, where, and the theme is going back to basics, and basic is put your stitch as close to the internal os as possible, and this can be achieved by modified Shirodkar stitch. So let us, and technically it is very easy, and again I say, don't do under short GA, do under regional anesthesia, so you can very easily do nice infiltration and stitch will be put, and the success rate will be much more. I don't want to go much more than that. And another thing, I wish Dr. Anjali Jamma and her team all success in coming year, and she wants me to say that all my senior colleagues, as I have felt about this technique, you all must be having something in your mind which you think others have not been following, but you strongly feel that this should be, this is recommended, or this should be followed, or this should be, more and more people should know about it, should come forward for these clinical perks. Thank you.
Thank you so much, ma'am. Thank you for being that stitch which holds everything together.
So, madam, I first of all congratulate you for coming ahead and sharing this with us. I have a very little doubt to ask. Thank you very much, madam, at the outset. We start with the stitch. What is the suture material that you use for this one?
Black silk. I won't go into detail. Pratibha, there is going to be a lecture on cervical insufficiency, and the person who has done it and will be talking on it. You can ask them.
Now we are going a very interesting session, that is inherent causes of RPL. We would like to invite our chairpersons, Dr. Bahubali Doshi sir and Dr. Kiran Sada madam. Welcome sir. Welcome sir.
Dr. Bahubali Doshi sir is an MD OBGYN from VJMC, practicing gynecologist and obstetrician since 41 years. So that's not even the age of many of you people here. ART consultant since 20 years and owner of Kasturi Nursing Home and director of Navjeevan IVF Center. I just want to add a small note here, as Henry Ford once said, anyone who stops learning is old, whether it happened at 20 or 80. Anyone who keeps learning not only remains young, but becomes constantly more valuable, regardless of physical capacity. So I welcome one of the most youngest and most valuable member of Solapur Society. Welcome, sir.
Dr. Kiran Sada madam. She is a senior obstetrician and gynecologist practicing since last 28 years in Solapur. She is the past president of Solapur Society in 2020. Past joint treasurer of Amox Conference 2003, head at Solapur. past Secretary of IMA, Solapur. At present, President of Inner Wheel Club of Solapur and Director of Hedgewar Blood Bank. Welcome, ma'am. Over to you.
Thank you.
I accept the compliments. I knew it, but it is good to listen to it again. The topic of next presentation is metabolic and immunological causes of recurrent pregnancy loss. See, the immunological causes we are of late we are investigating them routinely, and the metabolic causes also. It forms a big chunk of the cause of RPL, and I'm very happy to chair this session because Dr. Mala Arora, she has written published a beautiful book with a CD, and this topic I personally attended one of her lecture on a presentation in Pune 2005, and it was very great to really know the topic of RPL from her, and thereafter probably I honestly started treating those cases. Otherwise, I was always thinking that it should go to my neighbor, this RPL case. I request the co-chairperson to introduce Dr. Mala Arora.
Thank you, sir. It's my privilege to introduce Dr. Mala Arora. She is Chief Editor, Recurrent Pregnancy Laws 2003, 7 and 18. Chief Editor, World Clinics in Obstetrics and Gynecology, Volume 1 to 10. She is DC Datta Awardee for the year of Obstetrics and Gynecology 2018 and 19. Ma'am, you are Chief Editor for the first trimester of the pregnancy. Hyperhomocystinemia. Associate Editor, International Journal of Infertility and Fetal Medicine. Peer Reviewer of British Journal of OBGYN. Journal of Human Reproductive Sciences. It's a great pleasure to introduce ma'am, and let us listen her. Thank you.
Thank you so much. Good morning, everyone. And at the outset, may I thank the chairpersons for this very kind introduction and the Solapur Obstetrics and Gynecology Society for inviting me to this very prestigious annual conference dedicated on recurrent pregnancy loss. You had some very good deliberations in the morning, and I will bring you greetings from the Indian College of Obs and Gynae and Noble Hospital, Faridabad. The topic I have been given today is demands deliberation, because although we have three good published guidelines by the RCOG, the ACOG, and ESHRE, they are all now quite outdated, and we lack robust evidence for management of many of the disorders that we see in recurrent pregnancy loss. Gray is the predominant color of RPL management strategies, both immunological and endocrine, because our guidelines are very old and the recent published evidence is mostly of poor quality. And hence, we are often at a loss and we keep thinking, are we doing the right thing or the wrong thing? So let us one by one look at two important causes. The first one is the metabolic cause. There are many endocrinal disorders that we will diagnose in patients with RPL, and the most important of them is hypothyroidism. The question is, should we treat biochemical hypothyroidism or not? Then again, diabetes mellitus. Does well-controlled diabetes contribute to RPL? PCOS. Does hyperandrogenemia and insulin resistance play a role in RPL? Addison's disease. It's an infrequent cause but often missed in pregnancy, and it does cause pregnancy loss. Hyperprolactinemia. Should we screen for prolactin levels or not? Lutein phase deficiency. Does it exist as a cause of RPL? And ovarian insufficiency, where the low AMH levels will result in RPL. First of all, the burning question is biochemical hypothyroidism. We are all aware that it is mandatory to screen for thyroid function test in a patient with RPL. And the guidelines by the American Thyroid Association, which was mainly for non-pregnant patients, said biochemical hypothyroidism need not be treated but should only be kept under surveillance. However, you and me know from clinical experience that when a patient is trying to become pregnant, her biochemical hypothyroidism needs to be treated. Her TSH levels, if they are marginally raised or even upper limit of normal, we need to investigate her with anti-thyroid antibodies and try to maintain her TSH level in the mid-range or lower than the mid-range. So the first important message I want to give you is that doing thyroid function test on its own is not enough. You need to couple it with anti-thyroid antibodies if you find that the TSH levels are marginally high. And patients with high anti-thyroid antibodies are prone to recurrent miscarriages. This is a meta-analysis published in 2020 in which they looked at 22 studies, and in these they looked at patients who had positive anti-thyroid antibodies and recurrent miscarriage. And they found that if the TPO antibody level was higher, the miscarriage rate was definitely higher, with a significant odds ratio of 2.36. The other way around, women who had recurrent miscarriage and had positive TPO antibodies had a higher TSH value almost always, with a very significant p-value. And live birth rates were improved when thyroxine supplementation was started. So the message from this meta-analysis is loud and clear. Please screen your patients for both, first for thyroid function test. If her TSH level is marginally high, please do anti-thyroid antibodies and treat her with a low dose of thyroxine, either 25 or 50 microgram, in order to help her conceive. We next come to diabetes mellitus. It is a well-known fact that well-controlled diabetes is not the cause of RPL. Yet, because we are the diabetic capital of the world, we will come across the occasional as yet undiagnosed diabetic, and we do not want to miss her. So the clinical pearl that I follow is, if a patient has a positive family history of diabetes, I will definitely check her HbA1c levels once. If her A1c levels are less than 6, you're in a safe zone. But if they are between 6 and 7, you need to keep an eye on her blood sugar levels, see if she needs any treatment with metformin. If you have no diabetic patient, and sometimes they may have poor diabetic control and end up with miscarriage, So please make sure that your HbA1c levels are definitely less than 7, preferably between 6 to 6.5 before she plans a pregnancy. You also know that starting a pregnancy in euglycemic state definitely improves both maternal and neonatal outcomes. The large population of PCOS that we see and treat for infertility, we know that they have a higher incidence of miscarriage once they conceive. But when we break up the PCOS into different categories, we have realized that PCOS with high androgen levels and severe insulin resistance are the ones that have miscarriage. A small word of caution: we have a lot of literature on secondary PCOS, of which the most important cause is late onset congenital adrenal hyperplasia. This we often miss, and the one test you can do to pick that up is to do the 17-hydroxyprogesterone levels. And if they are high, she will definitely need to lower the testosterone level before she conceives. So there is mounting literature now that combination of high androgen levels and insulin resistance is associated with recurrent miscarriage. And high levels of androgen will alter the expression of the endometrial proteins that are related to endometrial maturation and embryo incarnation. There are very subtle defects of mitochondrial dysfunction and aberrant reactive oxygen species. And these two studies in 2018 and 19 pointed to the fact that it is important to optimize these levels before the patient gets pregnant. And the best way to optimize is by doing or emphasizing on fitness for fertility. So we know that exercise is the best way to reduce insulin resistance, and high androgen levels should be treated with anti-androgens prior to starting a pregnancy. Addison's disease. I have put this here because this is an important message I want to give you today. It is a rare disorder, but the 3 symptoms that the patient will complain to you are the ones you often dismiss as part of pregnancy. She will complain of having a low blood pressure, fatigue, and hyperpigmentation. And all these 3 are seen in pregnancy and could also be attributed to psychosomatic factors. But autoimmune polyglandular syndrome may be a common cause of Addison's disease, and it will lead to a miscarriage for sure if we do not diagnose it. But once we start glucocorticoid and mineralocorticoid replacement therapy, it is a very satisfying pregnancy outcome for these patients. Another important message I want to tell you is that Addison's disease is often associated with fetal growth restriction. And so if you have a patient who has hyperpigmentation, fatigue, growth restriction, low BP, please check the cortisol levels in the morning. And if they are low, you can correct it simply by cortisol replacement, and you will correct the growth restriction as well. There is a big controversy on hyperprolactinemia. Now, being an infertility specialist, all my patients will have their prolactin levels checked. But many obstetricians and even the SOGS-Date guidelines does not recommend testing prolactin levels in patients with RPL. Because practically most women with high prolactin will have infertility rather than RPL. However, this is a very simple test, and many of our patients who are very high strung and have increased stress levels, I would recommend to check their prolactin and to give her both tender loving care and prolactin lowering drugs, as the outcome will be much better. Something we see more and more recently is poor ovarian reserve or low AMH levels. Low AMH levels in young patients is not associated with RPL, but low AMH levels in patients with age 35 and above definitely is associated with increased miscarriage, because at this age there is a high rate of aneuploidy of the embryo, and these patients are best managed by fast tracking them to IVF with or without PGS for good outcomes. So when she is 35 and above, recently married, has 2 miscarriages, I think we are justified in taking a very firm stand to take her to definitive treatment rather than just delaying pregnancy, because soon she crosses 40 and the chances of her pregnancy become much lower. So you've had meetings after meetings on luteal phase defect and use of progesterone. Let me tell you, diagnosing luteal phase defect is not easy, because serum progesterone levels that we check on day 21, if they're low, may still diagnose luteal phase defect, but if they're normal, it may still not be confirmatory of no luteal phase defect, because progesterone secretion is pulsatile and you may have it normal on one day and low on the other. We have all stopped doing endometrial biopsy, which was the earlier gold standard for diagnosing luteal phase defect. It's not recommended because it's invasive, does not give a good diagnosis, and we are relying on ultrasound markers of endometrial maturity, which are fairly good if you have a good triple N endometrium that undergoes secretory change and becomes echogenic. But we all know that there is widespread use of empirical progesterone, not just for luteal phase support, but as an immune modulator. And there has been evidence that has come up after the PROMISE trial. You know, the PROMISE trial in 2015. And it said that supplementing patients of recurrent miscarriage with natural micronized progesterone did not lower the miscarriage rates. However, subsequent to this trial, there have been meta-analyses that proved that use of diploprogesterone was associated with a decrease in miscarriage rates. However, natural micronized progesterone is not effective for this indication. So, like it or not, most of us are using progesterone, and we are using the oral form in patients with recurrent miscarriage for at least the first 8 to 9 weeks of pregnancy. So with that, we come to the end of our discussion on metabolic causes, and I would be more than happy to answer your queries if you post them on the chat box, or if you want me to stop now for question and answer, I would ask the chairperson's permission as to how they want to proceed.
Can we ask the questions at the end of total presentation?
At the end of the presentation?
Right. Or you want it just now?
I'm happy with both. It is your call. I'm happy continuing on to immunological causes while people post their questions on the chat box. That may be better than stopping and using more time. Right? So, let us now discuss the immunological causes. So I'm not going to focus much on Aplar syndrome because this August audience already knows that this is one of the most mandatory tests that we do for autoimmunity in a patient of recurrent miscarriage. And if she is Aplar positive, we need to treat her with a combination of low-dose aspirin, which is 75 to 150 milligram, and low molecular weight heparin, which is 1 microgram per kilogram body weight. This dosage is very important because if you prescribe a standard 40 units dose, 40 milligram dose for all patients, then your patients who are 90 kg and above may still miscarry because this dose is not enough for them. So 1 microgram per kilogram body weight is the dose you need to prescribe. And we know that the success of treating Apla's syndrome is over 85 to 90%. It is one of the very satisfying causes, and if your patient is Apla positive, you almost breathe a sigh of relief because you know now that you know what to do with my case. But there is an important thing that I want to bring to your notice. How is low molecular weight so effective in Apla syndrome? Not because it is an anticoagulant, but because it has a very potent complement inhibiting action. And this complement inhibition is both by low molecular weight heparin and unfractionated heparin. So you can use either. If you have a patient who cannot afford the cost of a 300 rupee injection every day of low molecular weight heparin, I must point out that unfractionated heparin, which comes at a fraction of that price, you get a vial of 10,000 units of unfractionated heparin for 70 to 80 rupees, and you can use it 5,000 unit PD for 5 days, I think, through one vial, which not in 5 days, 10 days, which is a very low cost for your patient. So we use either low molecular weight and unfractionated heparin because they have a very potent complement inhibiting action. If we use a pure anticoagulant like fondaparinum, which is used in thrombophilia sometimes, or we use iridium, it does not prevent pregnancy loss because they have no complement inhibiting action. So it is important to know that autoimmunity, whether it is Apla syndrome or it is another kind of autoimmunity, needs to be addressed by inhibiting the cascade of autoimmunity or blocking the complement activation. It is important for me to point out that all autoimmune disorders, whether it be autoimmune alopecia areata, uveitis, vitiligo, chest conditions, or any other rheumatoid arthritis, SLE, they will all be associated with increased miscarriage rates because they are altering the female reproductive physiology. Now we know that the fetus is a natural allograft, and the mother has to make compensation to accept this fetus by altering her immune cell function. So this is how the mother in a normal pregnancy situation will lower the cytokine production, will inhibit the CD16 cells, will make sure that she has low natural killer cells in the uterine endometrium so that the embryo can implant. But if her innate immunity is disturbed, as in autoimmunity, just look at what happens. She secretes increased TNF alpha and beta. She has a very high cytokine production. She has a very high count of uterine natural killer cells. And the predominant CD16 is replaced by CD56. And so the uterine environment is now very hostile for the embryo to implant. So you may think that her vitiligo has got nothing to do with the uterine implantation, but it is important that you keep in your mind that celiac disease, uveitis, rheumatoid arthritis are all associated with increased miscarriage. And this is a meta-analysis published in 2016, which said that miscarriage rate was 28% in autoimmune positive group versus 14% in the control. And this is highly significant. And they took the cutoff of AMA Keaton of more than 1 in 160 as positive. So there is a battery of autoimmune tests. You can do anti-nuclear antibody, which is the most famous, most favored test to do. But you can also do anti-double strand DNA, anti-microsomal antibody, anti-smooth muscle antibody, anti-parietal cell antibody. And if any of these antibodies are positive, you need to treat this patient for the autoimmune. Here is another meta-analysis published in 2020 August by Chen et al. They looked at 21 studies in which there were 5,000 patients. Roughly half, 2,600, had recurrent miscarriage and the other half were controls. And they found that if the patient had a positive ANA titer of more than 1 in 160, she had a recurrent miscarriage rate of 22%, whereas the controls had a miscarriage rate of 8.3%. Again, very significant. So this is a new test that I want you to add to the battery of tests that you do in your patients of recurrent miscarriage, because if she's ANA positive, you will be able to treat her successfully. This is another meta-analysis, a slightly smaller one, again published in 2020, and they looked at 7 studies with 1,400 patients of RPL and 1,000 controls. Remember, these are very big numbers when we look at RPL studies. And again, they found the same thing, another group coming with exactly the same conclusion that ANA positive had a 20% miscarriage rate and controls at 0.7%. This is a new study published out of Japan in 2021, and they looked at all patients of unexplained miscarriage. And in these unexplained miscarriages, they looked at self-antibody titer positive. And they found that those patients that had either antiphospholipid syndrome or they had unexplained miscarriage had a higher rate of positive self-antibodies. So, I think we have come to the conclusion that neoantibodies or autoantibodies are positive in unexplained miscarriage, and so we need to separate this group by doing the ANA test. Sorry. And I will just come to the fact as to how do we treat. So what are your treatment options once you have seen positive ANA? The first thing I want to emphasize on, and has been widely proved, that autoimmunity is linked to our diet. So there are 5 which highly antigenic foods that we consume, which are eggs, meat, soya, peanuts, and dairy. Dairy means milk, paneer, dahi, or all things made out of it. Now, in somebody who has an autoimmune disorder, if they consult a functional medicine specialist, the first thing they tell them is, please become a vegan. Give up eating eggs, meat, soya, peanut, dairy. How is this food linked to autoimmunity? Because all these are foods that are very rich in protein. And if your gut is not functioning well, if your enzymes to digest the protein are somehow not being secreted properly by the pancreas, then you have large undigested protein molecules in the gut that get absorbed. And these are foreign protein molecules, and your body starts to make antibodies against it. And these very antibodies get displaced to self-antigens also in due course of time. So that is the basis of being a vegan, and you can emphasize for your patient that eliminating these foods will be helpful. So I just explained that the gut has a big role to play in autoimmunity. It invokes an antigen-antibody response to large undigested protein molecules. So what is the autoimmune diet? Reduce the inflammatory response from the gut during fertility treatments. You can give them, avoid potential allergens like gluten, soya, egg whites, nuts, and give them probiotics and gut healing nutraceuticals like L-glutamine, acetylglucosamine. Folic acid is also beneficial and N-acetylglutathione. This is when you probiotic kind of molecule will also be helpful. So once you give them adequate probiotics, their gut slowly starts to heal and they have a better response. Probiotics are also used if there is a clinical suspicion of endometritis because once you improve the gut microbiota, the endometritis also will get better. And it is important to use the probiotics in a high enough dose, which is more than 1 billion colony forming units. The other very simple thing to do is to correct the vitamin D3 levels. Because it has been shown that vitamin D3 deficiency is 2.5-fold higher in thyroid autoimmune. And vitamin D3 can downregulate TNF alpha levels and so will correcting vitamin D deficiency prior to pregnancy or even during early pregnancy will be most beneficial. And that reminds me that we as doctors are also not taking care of our vitamin D3 levels. We have all very low levels and please check your levels and take adequate supplementation because I think nearly the whole population needs vitamin D3. Now, how about IVIG? So IVIG is something that we use in autoimmunity to reduce the harm done by cytokines. So its dose is 0.4 grams per kilogram body weight, and it is given every 3 weeks intravenously. It neutralizes the pathogenic autoantibodies, and if there is any indication to use IVIG, it is not for unexplained miscarriage, but for those that have a high ANA titer. So it is indicated in APS syndrome if you have a patient who miscarries, as a miscarriage, even while being on aspirin and heparin, then you go back to using a combination of aspirin, heparin and IVIG. And it is also indicated in autoimmune disorders. And there is a very nice randomized control study on the use of IVIG published in 2019 by Christensen et al., which showed that if the patient has autoimmunity, IVIG will help. And the same group also showed that it is not recommended in simple unexplained RPL, but only recommended in autoimmune RPL. And they did a single center double-blind randomized control study in Denmark on 82 women who had more than 4 miscarriages. And they gave them IVIG versus just plain albumin infusion from positive pregnancy test up to 15 weeks. And they found that IVIG live birth rates was 54% in the IVIG group and 50% of the placebo group for unexplained RPL. So please carefully choose your patients who need IVIG because it is an expensive drug, it can cause severe reactions, and you only need to give it if she has a positive autoimmune test. What about infralipid? Many people ask this question because this is much cheaper than IVIG and much safer. It is more cost effective, no adverse reaction. It is given once in 3 weeks, but it is not useful if the patient has an autoimmune disorder because its potency as an immune modulator is much less than IVIG. People use it medically, but that is okay. But if you have autoimmune positivity, the 2 drugs you need to look at are steroid and IVIG. So what about steroids? We have never used it in Apla syndrome because they don't help. And we know that high dose of steroids can cause a cleft palate in the baby, also hypertension, PDM in the mother. So it is something you have to use with extreme caution. However, there are papers to say that if you have done a luteal phase endometrial biopsy and it shows very high natural killer cells, then in these cases, a short dose of steroids given preconceptionally and continued till 6 weeks post-conception will have benefits for proper implantation. So again, it's a very limited indication for a very short time and you can only use it with great discretion. Another drug that people commonly use is granulocyte colony stimulating factor. And this was used a lot in unexplained miscarriages, but there is a very recent randomized control trial that came out in 2017, which says that it does not improve the pregnancy rate in unexplained miscarriage. It is only useful in patients that have a poor quality endometrium, where you want to build up the endometrium for implantation. You can give it either intrauterine or subcutaneously in a very small dose of 1 microgram per kilogram per day. But it is not indicated in autoimmunity nor in patients of unexplained RPL. And this is the article that I was talking about, which said that live birth rate was 59% if you use GCSF and 64.9% if you use just placebo. So what you have to do is really give more and more of tender loving care. And lastly, in autoimmunity, like the patient who has severe rheumatoid arthritis, you have these TNF alpha blockers, and one of them is Recurrent, and this can be used to lower the TNF alpha levels. And earlier we thought that this would cause fetal teratogenicity, but over 500 exposed pregnancies in women shows that there is no teratogenicity. Another drug that we use is adalimumab, and this you can only use in consultation with a rheumatologist in a patient who has very severe autoimmune disorders, and these TNF alpha blockers are extremely expensive, costing roughly 1 lakh per month, and they need to be started roughly a month before initiating treatment to downregulate the TNF alpha. So this is a study published in 2008 where they looked at 75 pregnancies where the first group received only heparin and they had a 19% success rate. Second group had heparin and IVIG and the success rate was 54%. And the third group had heparin plus IVIG plus etanercept plus adalimumab, and there the success rate went higher. But these are very small numbers and they are patients with very high autoimmunity, autoimmune diseases. And so you need to treat them in consultation with a rheumatologist. So summarizing for you the treatment options you have in autoimmunity. Well, progesterone most of us use as a natural immunomodulator. Low molecular weight and heparin we use in patients who are antiphospholipid positive. Steroids we use if there is a high natural killer cell count in the endometrium. Vitamin D3 we use for nearly everybody, especially if it is low. Probiotics, 1 billion colony units a day. If you have high autoimmune disorders, and IVIG in very select cases of autoimmunity, intralipids not very useful but still used in implantation failure, and then etanercept. And with that, we come to the last part of my talk, what is new in management of RPL. And there are newer molecules. One of them you are totally aware of is stem cells and platelet-rich plasma, which is injected into the endometrial cavity. It is prepared from the patient's own blood. It helps to regenerate the endometrium, and there is poor quality evidence for it so far. But there is this study from UK in 2017 which says that there is loss of endometrial plasticity in RPL, and giving them stem cells and PRP combination will improve it. But lo and behold, there is a new molecule that is being researched, and that is the anti-diabetic drug called sitagliptin. And sitagliptin is shown to improve the endometrial mesenchymal stem cell progenitor colony counts. And in a small randomized controlled trial, it was beneficial in patients with RPL. And another study I came across was that of lipid-lowering drugs, atorvastatin, which is also being studied for RPL. So what is the evidence of all these treatment molecules I have presented to you? One more time, summarizing it for you. Psychological support tops the list of treatment options for all patients of recurrent miscarriages. So see them more frequently in your clinic. Perform early reassurance scans to show them the fetal heartbeat, because that puts their mind to rest. Give them aspirin and progesterone if you feel that immune modulation is important. Use low molecular weight heparin for APLA. HCG, there is no evidence that HCG support prevents miscarriage, and there is a Cochrane review that justifies that. Steroids have a limited role in known connective tissue disorders, immunoglobulin in autoimmunity and secondary miscarriage, and intravenous intralipid solution, no benefit seen in autoimmunity. Lastly, there are patients with very severe autoimmune disorders that you may have to refer for surrogacy, because their own body will not support the immune modulation that you want them to. So with this, I come to the end of my talk. Thank you very much for this opportunity, and I will be.
Thank you, madam.
Yes.
You have literally converted a biology class into a mathematics class. We could not have, we cannot think of anyone better than what was presented to us. We have already, I think, posted few queries.
Yes.
Kindly address them one by one.
So, hello. Yes.
Really, you have a very wonderful presentation. It is said that teacher is one who explains the difficult topic easily, and professor is one who complicates the topic. So you are really a very good teacher for this wonderful class. You made such a simply explained all these queries and doubts to our mind, but there are some few questions which are there in chat box. Please. Okay.
So, shall I read out the question? So the first question is, what is view on the use of natural micronized progesterone? And there have been randomized controlled trials. The most important, the PROMISE study, I would urge you all to read it. And the PROMISE study says that natural micronized progesterone does not make a change in the miscarriage rate. So personally, I am not using natural micronized progesterone, and I do not like to insert vaginal tablets for a long period, because that itself can alter the vaginal microbiome and make her more predisposed to mild endometritis. However, there is evidence that dydrogesterone given orally is a more potent immune modulator. So that is the answer to your first question. The second question is, if TSH is high, EPO antibody should be done, and what is the treatment of increased EPO antibodies? And a very valid question. So we give thyroxine replacement that will slowly lower the EPO antibodies. And when they are more than 1,000, I usually ask my patients to wait for 3 months, not to plan pregnancy till the antibody levels show a downward trend. So the only thing you can give them is thyroxine replacement. If the levels are extremely high and she has got pregnant, then a short course of steroids may also be recommended. But remember, these steroids have to be used for a very short course in a very small dose of the milligram daily. If the treatment is only thyroxine, why investigate for TPO antibodies? Because the TPO antibodies hold the key for whether she will miscarry or not. So if her TSH is mildly high and the TPO antibodies are normal, you prescribe her the thyroxine and tell her she can try from next month onwards, and she will be fine. However, if the TPO antibodies are high, you have to first give it time to settle down after thyroxine therapy and then try for pregnancy. The next question, is TORCH test recommended? And the answer is absolutely not. Because most of the TORCH infections will only cause one miscarriage. So if she miscarries and she has a CMV infection in early pregnancy, she will miscarry. The CMV antibodies will become high, and next time around she will not have a miscarriage due to CMV or toxoplasmosis. So the only thing is toxoplasmosis, which is quite rare in our country, but that can persist as an infection and needs treatment by spiramycin. If you have somebody who has pets at home and you think she could have toxoplasmosis, you can just do the toxoplasma titer, IgM, rather than doing the TORCH test, because all others are not of relevance. So, what is the role of aspirin? So, aspirin is used in a dose of 75 microgram in the pre-pregnancy clinic in all ACLA positive patients. But we increase it to 150 milligram and after the anti-scan or even earlier, because that is the dose that prevents preeclampsia. So the dose for prevention of preeclampsia of aspirin is 150 milligram, not 75, and we need to step up the dose once the patient is pregnant. We don't give her 150 right from the start because she may develop gastritis, sometimes she vomits blood, has some blood in her stool. So we try to give it the minimum dose, and actually the minimum dose is more effective for platelet aggregation than 150 milligram. What is the investigation panel for after 2 pregnancy losses? Oh, I didn't put that slide. Sorry about that. But you need to first of all check for APLA syndrome. Secondly, check for thyroid function test and TPO antibodies. Do an HbA1c level. Do a 3D ultrasound for uterine anomalies and a septum. Look for the infection. So if she has a vaginal discharge, you need to do not just a vaginal swab, but you also need to look at a vaginal smear for bacterial vaginosis and treat it with appropriate antibiotics and probiotics. And sometimes in patients who have infrequent periods or a poor corpus luteum, you need to do FSH, LH, AMH levels and prolactin levels. What is the dose of steroids and the routes? We give oral steroid 10 milligram twice a day or twice alone, and we don't give injectable steroids. And we continue it as soon as you get positive fetal heartbeat, because by that time all the immune modulation to accept the PD-allogram has been done. What is the dose of vitamin D3 in pregnancy? Oh, I usually use a mega dose because the compliance of 60,000 units once a week is very poor. So I give them an injectable 6 lakh units injection of Paratitol, because that makes sure that the vitamin D will stay okay. One shot covers the whole pregnancy. But if the vitamin D levels are very low, then you can give her the shot first and then supplement 60,000 units weekly, which many preparations are available. So, next question is, do you believe in treating patients preconceptionally with aspirin if they are APLA positive? Oh yes, definitely. As soon as the APLA test goes positive, she goes on 75 milligram of aspirin and then tries for a pregnancy. As soon as the pregnancy test is positive, she should be on low molecular weight heparin. Sometimes, if she's coming through for follicular study, I would start the low molecular weight heparin in the luteal phase. Because there are studies to say that the earlier you start, the better the effect with its immune modulation. So you need the aspirin working when the embryo is trying to implant. Okay, thanks Rohini for your comments. I think I have answered most of the questions. Is there anything else that the chairpersons can see?
Just one question. Hello. Just last question.
Yes.
Is there a role for heparin if the apply is negative?
Yes. So this question is always asked, and the answer is no.
Thank you.
If they are treating with autoimmunity, the treatment route is different. IVIG and steroids are more effective, and APLA negative have the same miscarriage rate if we give them heparin or we don't give them heparin. So please, this clear message that don't use aspirin, low molecular weight heparin if the APLA is negative.
Ma'am, one more last question. When you will advise to do APLA and NITs before pregnancy or after miscarriage?
So, if your patient comes to you in early pregnancy and has a previous history of miscarriage, you have to do it straight away during pregnancy, and then you do the IgM antibodies during pregnancy. The short answer to that, as soon as possible. So if she has come to you with a previous miscarriage, is not yet pregnant, you will do the APLA screening then and put her on low dose aspirin and let her try for the pregnancy. If she comes during pregnancy, do it immediately as soon as you see her. And the sooner you start the low molecular weight heparin, the better the pregnancy outcome will be.
Thank you very much.
Madam, on behalf of Solapur OBGY Society, I present you this memento virtual presentation present, and we thank you for your we need to give her a standing ovation.
Thank you very much, ma'am. Thank you very much.
I request our President, Dr. Anjali Jama, to felicitate our chairpersons.
That also can be done virtually.
Behind every mishap, there is always a cause. And in this session, we are going to discuss a very important topic, the causes of RPL, genetic causes of RPL. We'd like to invite our chairpersons, Dr. Kumtekar sir and Dr. Madhuri Dabde madam. Welcome sir.
स्वतः सुरू करायचं.
Dr. Girish Kuntekar sir is the best obstetrician of our society, a lawyer, teacher, and great academician. Sir manages high-risk pregnancy very smoothly and dynamically. Welcome you, sir.
Dr. Madhuri Dabde madam. She is a gynecologist practicing in Solapur since 30 years. She is a past president of Solapur OBGYN Society. Received many awards, like Best Society Awards at national and state level during her tenure of presidency. Received awards for the work done in the society and medical field. Received Sri Ratna Puraskar, Lions Club Agrani Puraskar, and Sharad Pratichan Puraskar. Welcome, madam.
Hello. Good morning, everybody. Dr. Chaitanya Dada is so familiar to us. At the drop of call, he is there in Solapur to guide us. At the drop of call, he is there to guide in Pune for us, our patients. And he has been always a friend and philosopher and guide to our society. So he needs not tell the introductions in front of you. Instead of listening to all the introduction letters, we are eager to hear his deliberation. Please go ahead, sir.
Long introduction. And a very good morning to everybody. At the outset, let me thank the Solapur OBGYN Society, Dr. Jamma, Dr. Monica, for this kind invitation. And greetings to everybody, all seniors and respected members here. So the topic that is given to me is tracing the chromosomal causes in RPL, the recurrent pregnancy losses. So I'll try to keep it as simple as possible, and in case there are any queries, I'll definitely consider it. So always the first question that I would ask is, do these 46 chromosomes really constitute our genetics? So the answer is yes, the answer is no also. Because if you see these 46 chromosomes and you open this up, there are almost about 25,000 genes or 3 billion base pairs, and a change of a single base pair is sufficient to give rise to a genetic disorder. 3 billion base pairs. So if you open up this chromosome, it's going to be a long thread of of DNA, which is coiled and supercoiled to form the compact structure. So if you have the abnormality at the chromosome level, we call them as chromosomal abnormality like Down syndrome, Patau, Edward, etc. Diagnosis is by karyotype. If a segment of that thread is deleted, we are evaluating a contiguous gene syndromes, which are diagnosable by microarray. And if you are going to the single rung of the ladder, it is what is a single gene disorder, which we are diagnosing by nowadays by exomes more so. So we have a lot of old generation tests, the karyotype, FISH, etc. Are they obsolete? Not really, as you will get to know in the future in some time. But we have these array of new tests. So NGS, the next gen sequencing, or you have the microarray, you have the PGT or the NIPS, which is available. So all these tests are available, but you have to use them very, very judiciously. So where to use each of the tests is what I'll try to cover in the talk. So I first give an example that if you're doing a karyotype, I'm having 46 books on a bookshelf. So when I'm looking at every book from outside and keeping it back, I'm doing a karyotype. When I'm opening the chapter of each book and looking at it, that is when I'm doing a microarray. And when I'm opening the page and reading that page letter by letter is when I'm doing an exome-based study. So a bookshelf, the books would be karyotype, chapters would be a microarray, and when I'm going to the page level, it is going to be the exome. So which test do we really choose? Especially in the context of RPL, so when we are discussing 2, 3 or more consecutive losses of proven pregnancies with post-implantation failure of conception. But here I would like to divide it into two parts. It's a miscarriage if the termination is happening before 20 or 24 weeks or less than 500 grammar before it is capable of an extrauterine survival, or it can be called as an intrauterine death if it is more than 24 weeks. Why do we classify this? Is essentially if it's a miscarriage, we are dealing with more of chromosomal problems. If it is an IUD, you can think of single gene causes over here. So the RPL incidence is roughly about 2 to 5% of all pregnancies, and what we see as actual pregnancy is only tip of the iceberg. Most of the pregnancies are lost much before that, and majority of this is because of chromosomal abnormalities. And these are accidental aneuploidies which can happen in any pregnancy, which lead to subclinical losses. So most of these pregnancies, which even before the lady recognizes she is pregnant, she has already miscarried, and these are mostly chromosomal in nature. So if you look at the RPL through all the trimesters, the genetics constitutes a small proportion, about 5%. There is a lot of unexplained part which was there, 40 to 50%. And we believe that some of this part, as madam just described, it could be because of the APLA or the autoimmune factors. It could also be because of genetic factors, because we are reaching more and more conclusive diagnosis in many of the cases. But if you look at the first trimester RPL, almost about 50 to 60% are chromosomal etiology. So if I divide the things as per as the embryo is growing, at conception, so if you have an infertility, poor quality embryos, a large chunk is because of the chromosomal factor and less because of the endometrial and hormonal factors. Now as you see a GSAC but no heart sounds, about 50% roughly you can say is because of a chromosomal factor, but here it's almost equal would be endocrine, the hormonal and the other metabolic factors. Once the FHS comes in, the genetic factor further comes down. It's almost about 25%. Rest of the things could be APLA syndrome and other metabolic factors. Beyond 12 weeks, if you look at it, it is more of non-genetic factors which are more likely to have caused the disorder, especially the APA and non-APA thrombophilias or placental causes. But here you see there's a change in color. Okay, it's essentially these losses which are happening beyond 12 weeks are more because of single gene causes, not chromosomal problems. So these IUDs usually would occur because of single gene conditions. So when to start investigating a patient? So preferably, as we have all heard, it's usually after 2 losses that it should start. But nowadays couples are so anxious that sometimes you can give them the option to consider investigating the products even after 1 loss if they want to. But generally after 2 losses, it's usually indicated to consider this. Now essentially because of late pregnancies, depleted ovarian reserves and better treatment options are available. So rather than waiting for 3 losses, generally the POC should ideally be tested at the 2nd loss. Now 2 kinds of factors that we are going to look at. Something what is called chromosomal factor, which is responsible for the recurrent pregnancy losses early in gestation, and a single gene factor which causes late onset IUDs. Now in chromosomal factor, you have something called numerical abnormalities. What in numerical abnormality? You have 46 chromosomes. So any chromosome number which is more than 46, that is what is called numerical abnormality. So for example, there are trisomies, monosomies, but there could be structural abnormalities wherein there is the chromosome number generally remains the same, but there is an exchange of material which is happening. So essentially chromosomal factor should be for the early pregnancy losses. Now in this particular case, 2 early miscarriages. The 2nd pregnancy had a trisomy 16. You can see 3 chromosome 16 over here. That's a trisomy 16. Both were natural conception. So how do we proceed? So what we know essentially is trisomy 16. Now, so this is a normal gametogenesis, how it happens. So each parent, the cell divides into 2 equal gametes of 23, 2 sperms of 23, 2 ovum of 23. 23 from both are going to fuse to form the embryo, which gives rise to an entire organism. But what happens in an aneuploidy? This gamete has divided normally. This gamete has divided as 24 and 22. So instead of 1 chromosome coming here, it's gone here. Both these fuse to form a cell with 47. Here you have 1 extra. If these 2 unite, it will form a cell with 45. So this is what is aneuploidy. So if you look at the parents, they are normal, but there is an extra or missing chromosomes which can come in any pregnancy. So any chromosomal issues which there are extra chromosomes, missing chromosomes, a very high likelihood that it is going to be a sporadic problem, the outcomes are likely to be good. So in such cases, so these are what is called aneuploidies, wherein the chromosome number is not a multiple of 46, like trisomy 16 or monosomy X. So usually if it's a sporadic trisomy monosomy and couple karyotype is normal, you can expect very good outcomes. Chromosomal factor is not likely to be responsible for the RPL. So less than 1% recurrence risk, you can counsel them to allay the anxiety, and so usually since the risks are very low, no invasive testing may be really indicated for these couples in the next pregnancy. Sometimes you come up with POC showing polyploidy. Polyploidy is an entire set of chromosomes coming extra. So instead of 46, there could be 69, which is triploidy, and 92, which is tetraploidy. So this is very much feasible. Here there is a case of triploidy, wherein all chromosomes are coming in, one copy is extra here. Now these are usually accidental issues. It's generally because of fusion of one egg with two sperms, it's called dispermy, or sometimes there is an abnormal meiotic division at the egg, and as a result the egg comes to have 46, and once a sperm with 23 fuses, it gives rise to a cell with 69. So most of these polyploidies and the tetraploidies, these are sporadic events. In these cases you need not consider couple karyotype also. These are purely accidental event. Outcomes are going to be very good. Now we'll make things a little more complicated as we go ahead. Here what is done is this: there was one conception after a period of infertility, and there was trisomy 21 on fish. Okay, now what fish does, it's just going to show us 3 signals, so that there were 3 copies of 21 over here. Okay, now how do we proceed if this was the case? Now what we should know is sometimes the trisomy can be a free trisomy, wherein you can see 3 different chromosome 21s. If this is a situation, it's an accidental problem. But sometimes you see only 2 21s, the third one is sitting here. This is what is called translocation Down syndrome. So if this is the case, the risk of recurrence is less than 1%, but if this is the case, the risk of recurrence is higher, because one of the parent may be a carrier of that translocation. Okay, so here what we see is she has only 45 chromosomes, there's only 121, the second one is sitting here. Okay, so the fetus has this entire chromosome along with 2 separate 21s. So essentially in these cases, the risk of recurrence for Down syndrome is going to be much higher. So almost about 10 to 15% risk of Down syndrome over only 1% if it was a free trisomy. So fish cannot really differentiate between whether it's a free trisomy or it is a type of a translocated trisomy. So why does that happen? I just explain this with a simple figure. Here we have, the husband has 2 14s and 2 21s, so he's going to pass on 1 14 and 1 21 to the fetus. The wife has 1 14, 1 21 and 1 14 plus 21, right? So if both pass 1 14 and 1 21 each, it's going to be normal. Husband has passed it normally, the wife passes only this 14 and 21. So she has 2 14, 2 21s, again it will go normally. Here what will happen, there is 14 21. This lady has passed on this along with this. So here you have 3 21s. So there's an extra 21 which leads to Down syndrome. Similarly, here you have extra 14. Here you can have a missing 14, a missing 21, and all these conditions will give rise to a miscarriage. So out of, there could be almost about 16 combinations which are possible in various ways. Only 2 combinations, if the couple is, one partner of the couple is a carrier of a translocation, out of these 16, only these 2 will give rise to normal outcomes. Rest 14 out of 16 will lead to either a miscarriage or infertility like presentation or fetus with anomalies. So what should be the counseling? If one of the partners is found to have a translocation, translocation is usually a cause for recurrent miscarriages. Guarded outcomes are likely. The possibility of a successful conception is still less than about 20%. You can give them the option of a natural pregnancy if the couple is young. You know, we have had at least about 20 cases which we counseled last year. At least 3 or 4 couples came with their own natural pregnancy and things went through very, very well. So it's not an unusual thing to happen, but the odds are a little on the other side. They can be given the option of the PGT-SR, that I'll come to that in some time, or the donor gametes. So now from this, we have come to a conclusion that we did 2 types of testing. One on the products of conception and second on the parental samples. So on the products of conception, the ideal test to be considered is microarray.
I will discuss the mode of collection because that's a very, very crucial thing, and it usually can be done after the second miscarriage generally, or if after the first miscarriage if the couple is wanting to do it. What about the blood sample? Karyotyping should be considered in all RPL cases, irrespective of whatever the findings are. I'll show you some examples. Karyotype is a gold standard. Never do a microarray in couples because that is not going to pick up balanced translocations. Microarray on the couple has to be done in really exceptional cases. When the POC is showing some abnormality, only in those cases we do for a microarray, and it should be done in a non-pregnant state. So what tests to be considered on the POC sample? So one is karyotype and FISH. But what are the fallacies here? FISH gives us information only about 5 chromosomes. It's not going to tell us about all the other ones. Karyotype, what happens is, though it gives us a structural review of all the chromosomes, it is difficult to do because almost 70 to 80% culture failure rate is there. Because karyotype requires growing of these cells in culture, and because of the bacterial contamination, most of those cultures get contaminated, and the result is, you're not obtaining a karyotype. So, and also, why microarray scores? Because it gives 15-20% more information than a karyotype. So it doesn't require a culture. So here what is happening, it's not requiring a culture, you can do it on direct cells, and here you're opening not only the books but also the chapters, and it's giving 15-20% more information to us than this thing. It can be done on stored DNA also. So suppose the patient is not willing to do the test right now, you can always have the DNA stored, you can come back anytime and consider a microarray on that sample. So that can be stored, and it doesn't require a cell culture, and all other things except for balanced translocations can be picked up on the microarray. So therefore microarray scores big, and right from 2011 we are having a lot of evidence building in this regard, wherein the success rate is very good, turnaround time is excellent for this. Except for balanced translocations, all these other conditions can be looked at. Uniparental disomy. Sometimes what happens, RPL happens because both chromosomes coming from the same parent. Say for example 14, one has to come from the father, the other comes from the mother. Sometimes both come from the same parent, which can lead to a problem which is called uniparental disomy, which can also be picked up on the microarray. So how should the sample be collected? Because that's one of the common questions that is asked. So usually you can collect it in any sterile container. It can be a urine sterile culture bottle. Take some saline, a sterile saline, puts a few drops of gentamicin, and you can put the tissue in that. What tissues are good? You can use the chorionic villi. Not to use the decidua, the villus portion should be picked up. You can use the great toe piece, or you can use skin clips. Either the abdominal or underarm skin clips are also good samples by which you can really get good quality DNA. Now some more cases. Now here you have a 25-year-old, she has had 3 miscarriages, and the products of conception have shown a trisomy 14 on the microarray. So how do we proceed? Earlier we saw that trisomy 16 was there. Since parental karyotype was normal, we are expecting good outcomes. But in this case what you see, she has already had 3 miscarriages, and when we did the parental studies, what we found, the mother was normal and the father carried a translocation between 13 and 14. So abnormal POC microarray, always follow it up with a parental karyotype, okay, because karyotype is going to pick up this. If you do a microarray in this individual, it's going to be normal, okay, because it's a balanced translocation. There's no loss or gain of matter. So if there is loss or gain, it will be picked up on a microarray. Otherwise, karyotype is the test of choice. Secondly, if you get multiple gains and losses on the microarray report, now you must be used to reading some microarray results, so wherein you have a gain and loss. So when you find multiple chromosomes with gains or losses, it will always hint that this is possibly there's a translocation which is there in one of the parent which is causing the recurrent miscarriages. So 3 early miscarriages, and there were multiple gains and loss, and the mother was found to be a translocation, having a translocation between 4 and 11. Now a few other cases wherein a few things would reflect that this patient has had primary infertility, 2 IUI pregnancies, early miscarriage, then came with a secondary infertility, very low semen count, poor motility, high DFI, and what we find is that the husband is a carrier of translocation between 3 and 22. So semen is a very, very good reflector of the chromosome. So when you're doing a sperm analysis, you find that the sperm count is low, DFI is very high. Check the chromosomes, because invariably you may find that there is a translocation, especially in males. Here there were 6 IUI attempts, 3 IVF attempts. That's the reason why we say that why an investigation of karyotype can be done earlier. So long period of infertility, poor semen quality, and a lot of IVF failures. 2 embryos transferred, they again miscarried. And at the end, they found that there was a translocation in this individual. So if it was found earlier, we could have given them the other options to consider in this case. So there was a translocation between 1 and 2. So always karyotype is indicated for all cases. But sometimes there is a notion that if there is one child who is normal, why should we do a karyotype in the either do a POC workup, or why should we do the karyotype in the couple? They have a normal child. So here you have one healthy female who is normal, 2 miscarriages. The 4th pregnancy, she came with low PAPA and an increased risk for trisomy 21, and we found a pathogenic mutation, a deletion which was noted here. MTP was done, we did the autopsy also, but to our surprise, when we did the karyotype, because there was an 11q deletion which was noted, when we did the karyotype, the husband was found to have a complex karyotype with a translocation between 5 and 13, and there was an insertion between 11 and 12. So it is a very, very complex karyotype, and they were really lucky enough in the first case, they just went through and the daughter is quite well. So the outcomes here are still more guarded because he has 2 places or around almost 4 chromosomes which are involved in this particular issue. So what are the effects of translocation? They will cause frequent miscarriages. Second, they will cause fertility concerns, especially in males. If the balanced translocation carrier is a male, it will lead to infertility. If the balanced translocation is female, it will lead to miscarriage. The reason for infertility is because balanced translocation causes arrest of spermatogenesis. There are no phenotypic abnormalities in carriers. Carriers are absolutely normal individuals. Rarely you will come up with fetuses with abnormalities, and very, very rarely children are born with syndromic presentations. Now, sometimes you get bad obstetric history or recurrent pregnancy losses with some odd phenotypes. Here you have the male who is normal, and he has one extra marker chromosome over here. So that marker could not be identified on microarray also. So there was something called as a spectral karyotype which was done, and that identified to be a part of chromosome 15. So there is a 15 part, there was a tetrasomy of this particular part, but since it was balanced, it was not picked up on a microarray. But here, this you can always utilize a PGT, otherwise you can use a donor semen for these couples. Then sometimes you'll have Turner syndrome variants. Now this lady, otherwise she has normal menses, normal secondary sexual characters, normal reproductive organs. She presented with 2 miscarriages, and what we found is that there was a ring chromosome X over here. So because of the ring formation, the features were not very, very prominent. But what is important to know here is the ovarian function will decline very, very rapidly in these ladies. So if you miss that small period of that window, they will become the fertility will be a big concern. Now, when the there is a micro deletion, when small portions, that is out of these books, what we saw just now is large parts of books, that is entire book was extra or missing. Here what is happening is, in the POC, we found one chapter of book number 15 gone missing. So when such micro deletions are noted, these are something very small portions of chromosomes which get deleted. So this is a whole chromosome, and a very small portion of that chromosome gets deleted, and which is called micro deletion. So whenever you find micro deletions, it should be the microarray should be done in the parents. So essentially, when you do a microarray in this particular parent, and if it is normal, you can reassure that it was an accidental problem and the risk of recurrence is going to be less than 1%. But sometimes you have some odd phenotypes coming in. This lady landed up with 2 babies having a cardiac defect, and it was almost similar, so a Malaline VSD, DORV. In the second case, again, there was a large VSD, LVOT abnormality, etc. And it turned out to be what is called DeGeorge syndrome. So DeGeorge, what we know is a 22q microdeletion, which is an accidental abnormality generally. But when we did the parental testing, we found the father to carry that same microdeletion. He was relatively normal, slight intellectual, there was, I would say, a borderline intellectual function, a little bit of facial dysmorphism, and an asymptomatic cardiac disease. But in some cases, you may find the parent to be a carrier of these microdeletions. In this case, the risk jumps up to 50%. In the earlier case, microdeletion with normal parents, risk was 1%. Here, the risk jumps up to almost 50%. Now, these are not causes of recurrent pregnancy losses. One is inversions. Inversion 9, most of the times they come for counseling, whether inversion 9, we have inversion Y. Nowadays, some other inversions, inversion 2, 7, etc. are coming up, but these are usually not causative of RPL because very few studies and most of them call it as a normal polymorphic variant. So unlikely. Similar with heterochromatin. So you have this YQH plus, YQH minus. So it's very common with 1, 9, 16 and Y. So it's very common with these 4 chromosomes. So essentially it is postulated to play a role in immune response in early embryonic development. But about this, whether it causes a really higher risk of miscarriage is still to be investigated. So for all practical purposes, its significance is not yet proven and it can be called to be a normal polymorphic variant with no major significance. So what should be the management of cases wherein you have such recurrent pregnancy losses with a structural abnormality? So what we saw just now is there was a structural abnormality in the chromosomes, and how should these couples go ahead? So one of the techniques which has come up is a IVF with PGT. Okay, so PGT is pre-implantation genetic testing, and here specifically you're looking at PGT-SR. It's called PGT for structural rearrangements. Okay, so essentially what is done, one cell is removed out from the blastocyst stage and that is tested for this particular rearrangement. And what is important here is we have to consider something called a pre-PGT workup in these cases, because the exact regions which are in the affected individuals must be known. They have to be tested on dummy embryos, and only then can it be tried on the actual patient embryos. So there is a pre-PGT workup wherein appropriate primers are designed as per the requirement of each, because these are going to be private mutations and private aberrations. So each probe has to be designed separately for the patient. So this pre-PGT workup is critical. The other options can be a donor gamete. So wherever if the partner who has that kind of a translocation or can be considered for as you can exchange it with the donor. Natural conception is absolutely feasible in selected cases. So if it's a young couple, normal semen analysis, good AMH levels, we can always give them guidance as they can plan a natural pregnancy. But a word of caution, any pregnancy which goes beyond 16 weeks should be subjected to an invasive testing. You should not be missing, small subtle micro deletions which can sometimes go, they will not show up on the sonography, and then later on it may land up with a child with neurodisability. So any pregnancy, so usually it's a tendency of these couples now, once they are conceived and that pregnancy has gone beyond 12 weeks and the scan is looking normal, they are elated. But even then you have to explain it to them that we should not be landing up with issues, pertaining to microdeletions and sometimes even uniparental disomy. Uniparental disomy, as I mentioned, both the chromosomes come in from the same parent to compensate for the loss from the other parent. So that's called uniparental disomy, which is again missed on the karyotype. So karyotype and microarray should ideally be considered at 12 weeks in these patients. So the RCOG level 3 evidence suggests it gives us an informed prognosis about the outcomes of the future pregnancies. If there's an aneuploidy, that is, we mentioned that there is an extra or missing chromosome, the outcomes are generally good in these couples. The risk of miscarriage, if it has happened because of say trisomy 16 and the couple karyotype is normal, we can always discuss the outcomes are going to be good. And if there's a family history of recurrent miscarriages, it is an indication to consider POC testing as well as a couple karyotype. Karyotype in both parents, it should be ideally be done in both parents, because sometimes we see KT done in one parent only. It should be done in both parents. So it should be tested essentially if the POC is abnormal. Second, if there are 2, 3 or more pregnancy losses, or if the POC testing has not been possible, still you should go ahead and do the karyotype. Now we'll switch to the next part of the talk, which is the genetics of late pregnancy losses or IUDs. So far what we saw is chromosomal issues are restricted to the chapter or subchapter level. So wherein a small portion of the chromosome is deleted. But when we have issues pertaining to late trimester losses or IUDs, the problem is more at that letter level. So there's a small change of that letter which leads to these issues. So here in these cases, if there is an unexplained IUD, we always go through this fetal examination process. So it's not equivalent to dissection, but also along with autopsy, a proper sample storage can help us in many cases. So we first would do sampling, we would do the examination, we can plan the appropriate genetic testing and then come to a conclusive diagnosis before counseling the couples. But what is crucial is all such cases always store the DNA. So what are the indications of a fetal autopsy? One, if there are major anomalies. Two, if there's an unexplained intrauterine death. If there's any hydrops-like presentation, especially non-immune hydrops. Recurrent abnormalities like recurrent NTDs. Sometimes one neural tube defect you can ignore, it could be because of the metabolic factor, but recurrent NTDs if they occur, and if there are some common anomalies with odd presentations, consanguinity in the couples or previously unexplained miscarriages, IUDs or children with intellectual impairment, you can always go for the fetal autopsy. Here there's something called clinical autopsy wherein you actually send the fetus for examination. Second is visual autopsy, wherein you take good quality photographs, and that sometimes helps us in evaluating the exact clinical condition. And imaging autopsy, wherein we are doing the actual X-rays and the other things. Now, for example, in this case, it was an IUD at around 16 weeks, wherein this fetus had come with cystic hygroma, encephalocele, a non-immune hydrops-like presentation. There was an odd encephalocele which was also noted. This turned out to be a Turner syndrome. So Turner syndrome we know is an accidental problem. Recurrence risk is going to be low. But now you see this. There is a central cleft lip, cleft palate with a cystic hygroma, with a cardiac disease, with a polydactyly. So very much looking like a trisomy 13. So in such cases, the fish was done which was normal, but this turned out to be a problem at the level of the gene. This is something called a Majewski syndrome, which has high recurrence risk in the next pregnancy. So if you ignore this, you may land up with a recurrence in the further pregnancies. Or sometimes you have some very, very obvious things like this, wherein this fetus had shown poor mineralization, poor ossification of the spine, deviation of the cardiac axis, and lot many abnormalities, and had an IUD at around 20 weeks. Now, when an autopsy was considered, we could do the X-rays. Now, X-rays give us a very good idea about what skeletal dysplasia we are dealing with. So, when we found, and we could correlate that with the condition which was achondrogenesis. Okay, so it is essentially again a recurrent condition, so we need to have early diagnosis so that we can guide the couple appropriately in the next pregnancy. Now, sometimes things happen really unexplained, and in these cases, how we should go about. Now, this is a non-consanguineous couple, no major history as such. NT scan was normal, but at 19-20 weeks, there was a sudden IUD with hydropic changes which were noted. So, they opted to consider, we did a microarray which was normal, placental histopathology was normal, Dopplers were normal. So, what was the cause? So, they sent the fetus for an autopsy. Now, do you find that there is dysmorphism in the fetus? So, just look at the fetus and we find that there are some changes which are not really looking very normal. You can see the head size is quite large. So, when we did the testing and we reached a conclusive that this was something called multiple congenital anomalies and neurodevelopmental syndrome. So, it is an X-linked condition for which the mother is a carrier, father was normal. So now this has very important implications because the next male child will have a 50% risk of being affected, 50% being normal. So we can offer them early prenatal diagnosis if they desire. So here when we do an autopsy, we always match it feature by feature and try to say macrocephaly, a large forehead, there is significant retrognathia, you can see the rocker bottom foot. So all these features which are not evident on the scan are evident on autopsy. So this was an unexplained IUD and it turned out to be an X-linked condition with high recurrence risk. So we have to be more careful when we are dealing with these cases. So sometimes it can just be a miscellaneous, very hypercoiled cord leading to an IUD in this case. Now going a little ahead in gestation, this fetus had presented with arthrogryposis like presentation. So how do we approach these cases? So naturally she had come at 24 weeks, so it was not much that we could do at that time. So we said that they can continue with the pregnancy, but there was an IUD and she delivered at around 28 weeks. And at that time we took the photographs and collected some sample. Now why is that important? Because she already had one baby who had passed away similarly. So if we don't have a diagnosis now, again, we may risk them at a recurrence in the next pregnancy. So this turned out to be something called a Pina-Choquer syndrome, which is a single gene abnormality. So similarly, in these cases, wherein a bad obstetric history is known, the first baby had a clear torch-like presentation. So this baby at 34 weeks had oligoamnios, there was ventriculomegaly, intracranial calcifications, cardiomegaly, and the baby was born, had hazy cornea, corneal ulcers, viral keratitis, etc. Very, very classical torch-like picture, but torch was normal in the mother and the fetus. So they planned the next pregnancy. It was explained that they can go ahead. The second pregnancy also showed similar issues, and there was an IUD later. So TORCH, as we understood from the previous discussion, that it is not recurrent condition. So when there is a recurrence, then we have to think that there could be something else that we are dealing with. Again, this fetus had normal chromosomes, everything was good, and it turned out to be a condition called pseudotoxoplasmosis, Aicardi-Gouttière syndrome, which is called pseudotoxoplasmosis, which is a genetic condition. So here again the risks are going to be high. So any odd condition or odd presentation, you have to be very, very alert. Now sometimes this happens on the table, the baby is stillborn. Okay, still in this case, I was called to the NICU to have a look at the baby because it was not looking normal. You can see the posture, you can see the position. So this was not looking very normal. Later the parent came for counseling, and he also had significant dysmorphism. So this was something what is called Freeman-Sheldon syndrome. Had a very high risk of recurrence in the next pregnancy, almost 50% risk of recurrence. So here you can advise them, they want to go for donor or they want to go for a PGT, because the risk of recurrence is 50% in these cases. Now again, something which the obstetrician read, that this baby did not cry at birth. So they had two babies who did not cry at birth. The second baby was almost born like a limp baby. And here what happened is, they did the MRI of the baby and it showed classical HIE changes, hypoxic ischemic changes in the second case. Now, is it likely that two babies born of cesarean section of good birth weight would have an HIE? It's very, very unlikely. So the samples of the second baby were collected. It turned out to be hyperhomocysteinemia. So the homocysteine levels in the fetus were high in the in utero period, which caused placental, the brain vessel thrombosis, and the antenatal brain damage had occurred. So these cases, again, the risk of recurrence is high, and in cases with unexplained perinatal deaths, I would say at least about 30% cases, we are reaching conclusive genetic diagnosis. So these cases must be investigated properly. If the parents may not be in the state of mind to do investigations at that point, but here at least store some DNA sample which can be helpful, even in this case. Similar issues, the fetus is two babies born limp. It turned out to be something what is called as cutis laxa syndromes. So we have to be very careful when we are approaching these cases. So proper fetal sample preservation, one for genetic evaluation and secondly for the actual fetus for autopsy or the placenta, should be considered appropriately. So the take home messages would be, POC testing may be considered after the second unexplained miscarriage. Proper sample collection is very critical. Microarray is a test of choice on products of conception, which should be followed up with a coupled karyotype. A proper sample for fetal losses, unexplained IUDs, a proper autopsy and molecular workup helps in reaching conclusive diagnosis, so that we really can offer some good pre and post test genetic counseling is essential in some of these cases to guide them properly, so that they are not at a loss to have the recurrence of these issues in the next pregnancy. Thank you so much.
Thank you, Dr. Balaji, for the wonderful presentation. So when I started the practice, the ultrasound was new, and we had to consult patient for getting ultrasound done. Later on, patients used to ask why it is not done. But I think the era has come where patients are asking why genetic testing is not done. And that's why I think that we should learn more and more about genetics. And Dr. Dakar wonderfully made this difficult subject very easy. Thank you, Dr. Dakar. Thank you very much.
Thank you, sir, for the wonderful lecture.
Okay. Just friends, particularly the senior obstetricians here and who are very busy with obstetrics, they tend to overlook the IUDs, sudden IUDs, and just dispose of or handle the baby as early as possible. But the take-home message from your lecture is that every unexplained death should be investigated thoroughly so that the future progeny is proper counseling can be done. So these things are very important. And secondly, the genes or genetic coding, as you say, is a biological program, they say. And people like you are trying to decipher it is a good thing for all of us. Thank you.
So, medically, the implications for IUD is also very, very crucial. Yes. Thank you so much.
Any questions?
Yes.
would you suggest that, when there is a IUD or late trimester losses, storing the DNA? So how long do you store and how do you retrieve and how do you go on it? Because that's a very practical thing that would.
The storage is essentially you can take a small sterile container. Even sterile container also is good enough. You can put a small piece of cord, as we mentioned, a 4 to 5 centimeter cord, grapefruit tissue, some skin clips, and the same this thing. You add cyanide and some gentamicin. That remains quite stable. So you send it to the lab for DNA storage. Generally, the DNA remains well for many years. But labs usually would store it for 3 years, 5 years or so, and it's usually not discarded unless really it remains for years. It's a very sorry.
Even if it is a macerated.
Yeah, even if it's a macerated type of fetus, you can take a more number of samples. You can take some cord pieces and all, and you try to add gentamicin and send it to the lab as early as possible, even if it is a little macerated. So you can attempt to do it.
Any more questions? As we said about the sampling, so will you recommend the whole fetus to be sent or just the sample to be sent?
No, if it's a big fetus, sometimes disposal is a problem. So in these cases, only the sample may be sent. You can document some photographs of the fetus always. Keep it handy.
So one more question I would like to ask. In a case of more than 2 first trimester losses, if everything is evaluated, like there is no other cause applies negative, what nutritional supplements preconceptionally you would advise?
So preconceptionally, as Madam said, B12 is one very important supplement because we advise folic acid but never we don't give B12. B12 deficiency is the commonest cause and it leads to hyperhomocysteine. So this hyperhomocysteine in turn causes early miscarriages. So a correctable thing, B12 is one thing and homocysteine which we would check. B12 supplementation, folic acid and vitamin D is the common supplements that we would give for expansion.
Thank you.
Any more questions? You said something about balanced translocations. Can you just explain?
Sorry?
Balanced translocations.
Balanced translocation is what I showed. There is we give an example of the books. So when there is an exchange of chapters in between 2 books, there is no loss or gain. That is balanced translocation.
Dr. Datta, hello. You shown in that case where microarray was normal. So whether we should stop there or we should go ahead for exon sequencing?
It's a very valid question. See, if microarray is normal and it was an unexplained early miscarriage, so whether fetus did not have any anomalies, everything was normal and it was just an unexplained very early loss, you may stop at this thing. Usually, if anything is happening beyond 12 weeks, when the fetus has shown a raised NT followed by an IUD, so any soft marker, anomalies, or unexplained IUDs beyond 12 weeks, they should be investigated deeper and go to the exome level if necessary. If it's a very early loss, like generally 6-7 weeks, POC is 7%, then the possibility of finding a genetic cause is quite no, it's not unknown, but it is very low. So sometimes you can stop at the POC, but it's a very early loss.
I request our chairperson to felicitate Dr. Chaitanya Datta. I request Dr. Anjali Jamma Madam to felicitate our chairpersons. Tabda Madam, Dr. Kumtekar sir. I think everyone is eagerly waiting for this session. That is the uterine factors of RPL. I invite our chairpersons for these sessions, Dr. Rohini Deshpande Madam and Dr. Sharmila Guru Madam. Rohini. Dr. Rohini Deshmande Madam is esteemed member of our society. She is a great academician, loved person, and very enthusiastic. Always ready to help the junior. That is her specialty. We are proud that she is a society SOGS. Welcome, ma'am. Welcome, Dr. Sharmila Gura, ma'am. Ma'am is consultant at Ankur Nursing Home, past SOGS president. And in her tenure, we won the trophy for the best presidency and best society. Over to you, ma'am.
Hello. I'm very happy to introduce our great member of our society, Dr. Rajesh Dubey. He is very well known for his specialty in ART. He is also a very popular teacher as a LC in Ashwini Rural Medical College. He has presented one of research papers. He has also worked on the Shirota sleep and done research work in diagnostic laparoscopy and evaluation of abdominal tuberculosis. He has presented many papers in various state level and national and international conferences. And he's a person who is versatile, I would say. Like, he likes clinical obstetrics, he likes ART, he likes to teach. So, what can we have more than you, Dr. Rajesh? Always been a very enthusiastic in clinical obstetrics and gynecology as a whole. Thank you very much for being with us, and we would be very happy to look forward to the presentation. Thank you.
Thank you, madam, for those kind words. I thank the chairpersons, the officers of the society for giving the opportunity to present this cervical practice in RPM. One request I want to make to the chairpersons that you may instruct the organizers not to ban the bail if I exceed my time, because my next speaker, Dr. Ajit Patil, and Dr. Sandesh Kadaya agreed upon to cut short their speech if I extend on my time. When I started preparing my talk on this cervical fracture in infertility, the first word that came to my mind is cervical incompetence. But then, as Dr. Girish Kumthekar always tries to inculcate some social habits in me, he said if you go to the United States and if you see somebody who is not mentally very strong, and if you say that he is a mentally retarded guy, he would say they will throw you in the jail there. So better say that this person is mentally challenged, not mentally retarded. And that's why the whole medical science has changed its terminology from cervical incompetence to cervical insufficiency. The pathophysiology lies in that the cervical woman with cervical insufficiency, it contains higher proportion of smooth muscle cells compared with the cervix of a pregnant woman without cervical incompetence. So to say, the cervix should have more component of the collagen and elastin and less component of muscle tissue. What leads to this cervical insufficiency is the deficiency of cervical collagen, elastin, or other mechanical components of connective tissue. And one of the first descriptions of cervical incompetence, that's the word the then used, now changed to insufficiency, has been attributed to Cole, Klippel, and Rowan in 1658. And interestingly, 300 years after that, the surgical treatment was developed, first by Dr. Shirodkar and subsequently by Dr. MacDonald. It was Dr. V.N. Shirodkar in 1955 who told the world, or who demonstrated to the world, that a stitch on the cervix can salvage the pregnancies and give good outcomes. So we all as Indians should really be proud of Dr. Shirodkar. And I know our society has a lot of respect for this doctor from India. And then I started searching who is MacDonald, and I could really get this picture of MacDonald Alexander who devised that MacDonald stitch. Now coming to the diagnosis of cervical incompetence, to insufficiency rather, as to how do we diagnose this cervical insufficiency so that we could offer the surgical treatment for these patients. And there is a lot of confusion about the diagnosis. I'm sorry, not a gender discrimination. I have shown a lady with a lot of confusion, but all men are also equally confused about coming to the diagnosis of cervical insufficiency. Because some patients who have been diagnosed as cervical insufficiency, somebody gives them progesterone injections or progesterone tablets and they do well in the pregnancy. Why does this happen? That happens because pregnancy is associated with increased water content and marked decline in the collagen. Now, if the marked decline in the collagen explains why a woman in pregnancy has a pregnancy consistent with cervical insufficiency in one pregnancy, in the subsequent pregnancy, there is a reduced decline in this collagen, and that explains why without treatment, there is a subsequent term birth, and hence the confusion about diagnosis. We have been traditionally taught that Hagas dilator test in non-gravid state would mean that if you are able to pass in number 8 Hagas dilator without a snip, probably this cervix is not competent enough to sustain the pregnancy. But there are some objections to this. The first objection is that you are doing this test in a non-gravid state, and maybe the cervix would behave differently in a gravid state. Next comes the traction test. That is, we use a pediatric Foley's catheter, insert it beyond the internal os, fill it up with only 1 ml of normal saline and give a traction. If it comes out easily, one can say that there is a cervical insufficiency in this patient. And then, of course, HSG would show us this cone rather than typical closed internal os. So we can see this funnel-shaped cervix on histosalpingogram. But then our teachers would always say that digital examination is very important, because digital examination will tell you whether the cervix is getting shortened or not. But remember, this shortening starts happening at the internal os first rather than the external os. So maybe digital examination would not really give us a solid information about the cervical insufficiency, and then came ultrasound. Because I am fond of putting the pictures, I read in the books, and I also listened to Madam Sardesai's talk on Dr. V.B. Kulkarni oration which she gave on AMOGS, and she said ultrasound is the gold standard. Now I confused as to how do I put this, what picture should I be putting for this gold standard. Then I went to PNG and I told him that show me the best of the gold necklaces. So the manager was very happy. He called me in the cabin, gave me a glass of cold water, then he ordered cold drink for me, and then he gave this ornament. I said, I don't want the ornament, I just want the picture. So I took that picture and have presented this. So ultrasound is the gold standard in coming to the evaluation of cervix. Amongst the ultrasound, not the transabdominal, not the transperineal, the transvaginal is the gold standard. Okay, and now here, how do we conclude that whether this is a really cervical insufficiency is there or not? Well, not only we do the transvaginal ultrasound and have a look at the good cervical length and be satisfied with it, we give little fundal pressure, and as you can see, the picture on your right side shows that after fundal pressure, the cervical length has reduced. So mere assessment of the cervix just by putting the probe and measuring the cervical length is no good. If you are doing it for the cervical insufficiency, we have to give a little bit of fundal pressure not to cause discomfort to the patient, and you will see that there is a change in the cervical length if the cervix is pliable. More cervical length can even bring about this type of picture on ultrasound. Transabdominally is not advisable because, as you can see on your right side, whenever there is a over-distended maternal bladder, the cervical length appears to be elongated, and when the urinary bladder is optimally filled, maybe you get a true cervical length. So instead of waiting for that optimally filled or over-distended or under-distended bladder, the transvaginal approach is the best. But transvaginal ultrasound also has its own limitations in the sense that grand multiparas have wide open cervices without insufficiency. So that becomes the limitation of transvaginal sonography. Transperineal, all thanks to Dr. Kinare from Pune, who had come here to Solapur for one of the ultrasound workshops, and he demonstrated as to how transperineal ultrasound can help us look at the cervix. For that, we need a little bladder, very little bladder, and that gives a good demonstration of the transperineal. Though it is not as good as the transvaginal, but it gives you fairly good idea about the cervical status, and especially those patients in whom we are suspecting to be having cervical insufficiency. It's not a good idea to put the probe directly into the vagina, because you may have surprised that already the cervix may be dilated and the membranes may be bulging. And putting the probe in the vagina can really cause more damage. To maybe you land into rupturing the membrane. So transperineal gets rid of all these problems. If transperineal ultrasound tells you that already there is enough dilatation of the cervix, we need not proceed with the transvaginal ultrasound. Now, there are clear-cut guidelines about the cervical length education and review given by ESOG. Because we all have been listening to NT scan and the proper plane form measuring the nuchal translucency, and there is a good flexed attitude of the baby, but there should be a pocket of liquor between the at the neck, and the baby should be in dorsal position. All these criteria need to be fulfilled before we take the patient for NT scan. Similarly, more simpler things have been put for cervical assessment by the ESOG, and it says that it has to be a transvaginal approach, the bladder has to be totally empty, and the anterior cervical lip should have the same thickness as the posterior cervical lip. The internal should be well visualized. The cervical canal should be seen in entirety, and the image should occupy, the cervix should occupy 75% of the screen. And when you measure, the shortest of the 3 dimensions should be taken into consideration, giving the final cervical length. Now question comes as to, this is the cervix has a curvature there, and how do we measure that? If we measure from the external os to internal os, is it okay? It's not okay, because if you take these 2 dimensions here, you take from the external os to the midpoint, and from midpoint to the internal os, this would make the true cervical assessment, because trace method has not been actually found in all the ultrasound machines and has not been universally accepted to measure the comment about the length of the cervix. So instead of trace method, we measure, we take these 2 measurements. But if the disparity between the straight dimension and the dimensions taken these together is less than 8 millimeter, even a single dimension is to be considered as a good dimension or a good measure of cervical length. What is coming up in the ultrasound technology is this elastography. Elastography is just nothing but an extension of what our teachers did. They assessed the patient's cervix by digital examination, and they commented that this is a soft cervix and this patient is very highly likely to have cervical insufficiency. So you have to be careful, assess the patient more frequently, and if you find that the patient is dilating, then we may put a stitch on that. But now the consistency of the cervical tissue can be assessed by this elastographic technique, so that advanced technology can be employed to know whether this cervix is really competent enough or is not having insufficiency. And this is a pretty old teaching, that you look at the internal os and look at the membranes at the internal os, and they have these different types of shapes. There's a T-shaped cervix which you can see here. Then you can have Y-shaped, the V-shaped, and the U-shaped. Y, V, or U-shaped would mean that probably our patient is heading towards cervical insufficiency, and the patient may land into second trimester abortion or preterm labor. These letters tell me that T, Y, U, and V is trust your vaginal ultrasound. Okay, so trust your vaginal ultrasound and measure that. Risk factors for cervical insufficiency, we all know there are some congenital risk factors and acquired. Congenital will, like inherent weakness of the cervix, that is as seen in patients with collagen disorders or patients with uterine anomalies, have a tendency to efface their cervix earlier. And then we have also been reading about DES exposures. The generation today need not worry about this DES exposure. Diethylstilbestrol was once upon a time used in patients with recurrent pregnancy loss or recurrent preterm deliveries so as to have good outcomes, but this was pretty old. I mean, its use started in 1938 and stopped in 1971. So we now are not likely to get a patient with who has had a DES exposure and has become pregnant today. Amongst the acquired causes, If there is a rapid dilatation of the cervix in suction evacuation or dilatation of the and curettage, you may damage the smooth muscle fibers or the collagen at the internal os and lead to cervical insufficiency. Cervical tears due to precipitate labor or instrumental delivery can predispose to this. Fothergill repair, where we amputate the cervix, can predispose, and not only amputation, it is excessive dilatation of the internal os because we want to put the Sturm-Rupp suture so as to cover the amputated cervix. And then lip excision of the cervix for either disparity between the colposcopy and the cytology findings, or the cytology is threatening, then we may go ahead with lip procedure or conization. All these can lead to cervical insufficiency. But cervical insufficiency does not lead to first trimester loss. Why does this happen? Because in the early trimester, that is before 14 weeks of pregnancy, there is something what is called as choriodecidal space. This space does not get obliterated before 14 weeks, and it is only after 14 weeks that the growing uterus, the growing fetus with its fluid around and the membranes would exert pressure on the internal os, and then the internal os would open, and that's why cervical insufficiency is never a cause of first trimester loss. Chairpersons, pardon me if I sound too basic, because I have some postgraduates here, and that's why I have added these few slides. Now coming to indications of this cerclage, we can go ahead with the cerclage if there is history, or if the ultrasound proves that this patient has cervical insufficiency, or then sometimes we have to proceed with the rescue cerclage. History indicated cerclage is one where patient gives you history of previous 2 or more mid-trimester abortions or preterm deliveries. Ultrasound indicated cerclage, as I told you, we assess the patient. It is ideal to subject all the pregnant patients at 12 to 14 weeks for NT scan, and it is at that time we must insist that we also get the cervical length reporting mentioned in that NT scan report, because then next ultrasound, if everything is normal, we will subject the patient for anomaly scan at around 18-20 weeks, and at anomaly scan also the cervical length must be asked for, and if you find that the cervical length done at 18 to 20 weeks is less than the one which was done at NT scan, this patient has a threat of cervical insufficiency. As my friend Dr. Ajit Patil, in his when he made his videos, educational videos for the patients by his pristine hospital, he told the public that तुम्हाला जेव्हा पहिली सोनोग्राफी होते तेव्हा तुम्ही विचारलं पाहिजे डॉक्टरांना की माझ्या सर्व्हिसची लांबी किती आहे, आणि ज्यावेळी गर्भामध्ये काही दोष असेल तर त्यावेळी सुद्धा तुम्ही विचारलं पाहिजे की ती लांबी तेवढीच आहे, कमी झाली का जास्त झाली. सो दॅट्स गुड दॅट यू हॅव एज्युकेटेड द पेशंट, सो दॅट हॅज ॲडेड अ बर्डन ऑन अस, ऑफकोर्स फॉर द बेटर आउटकम ऑफ आवर पेशंट्स. अँड the different types of cerclage we all are well aware: McDonald's, Schroeder curves, abdominal, worm stitch, and lash and lash. Just few words about the worm stitch. It is just the transverse sutures at the external os. We just obliterate the os. How does that help? It is the occlusion of the external os by placement of the continuous non-absorbable suture. Here the theory behind is that the potential benefit of occlusion of the cerclage is retention of the cervical mucus plug. That mucus plug is a good barrier to prevent the ascending infection, and it is the ascending infection that brings about the weakness of the membranes, and then the membranes give up, and patient lands into PPRM, and invariably they land into second trimester loss or the preterm deliveries. And of course we have now pessaries coming up. They can be placed so as to obliterate the cervical canal. We all know how a McDonald's stitch is performed, and we also know how Schroeder cerclage is performed. In Schroeder cerclage, anteriorly the bladder is dissected, and now, as Madam has told in her pearls of wisdom, that we should all be thinking of going ahead with modified Schroeder cerclage if we have a case with bad cervical trauma or recurrent abortions in spite of McDonald's stitch. Here anteriorly we have to dissect the bladder up, and then we put the stitch, which I'll be showing in few next slides, and that's the stitch put for worms procedure. And my friend Dr. Sandesh Kade, he has rescued many pregnancies. Many pregnancies have gone beyond 34 weeks when he put this laparoscopic cerclage for patients with previous failed vaginal operations. Because see, the McDonald is at a lower level, Schroeder is at a higher level, and abdominal cerclage is still at a higher level. That increases the height of the cerclage. The higher the height, the closer you are to the internal os, the less chances of losing the pregnancies. But this transabdominal cerclage is less said than done, less easily said than done rather. Okay, we really need to have an expertise, and when the comparison of abdominal with the vaginal was done, the final conclusion was that the abdominal approach is likely to be beneficial to women with previous failed vaginal cerclage. But there are problems with abdominal cerclage, because suppose you have put a stitch and maybe in the previous pregnancy the stitch was put and you need not remove the stitch, because anyway you are going to subject the patient for elective cesarean section, and we keep the stitch so that it will be beneficial for the patient for her next pregnancy also. And in next pregnancy she unfortunately has a first trimester loss. Okay, first trimester loss, then we have to proceed with suction evacuation or the medical method of abortion. And in that case, this abdominal cerclage, even if it is kept in situ, does not come in the way. One can very easily go ahead with the evacuation of the uterine cavity. But if next time, if the patient lands into preterm delivery, or next time there is a intrauterine fetal death for a second or third trimester, then we'll have to, I'm sure this was an accidental okay. So in that case, we have to cut the stitch, okay, and then the stitch can be cut by different ways, but the newest method that has come is we can put the hysteroscope in the Douglas's pouch, and through hysteroscope, because we also have operative hysteroscopes and we have good scissors for the septal resection and all that, the same scissor can be used to cut the stitch in the posterior fornix. Most difficult is this situation where you have the membranes bulging. The bulging membranes, we put a stitch, and that we call as an emergency cerclage, and because it has rescued us and the patient, we also label that as a rescue cerclage. And then the question is, to be or not to be. Should we really intervene these patients with bulging membranes? Because bulging membranes is one very difficult situation. We can rupture the membranes while putting the stitch, and patients can blame we putting the stitch for that outcome. So we have to be very careful, because the membranes are bulging. Bulging membranes are exposed to the vaginal flora. They are already infected, and all infected membranes are very prone for rupture, and that's why we have to be very careful. So preoperative evaluation, people earlier thought that whenever there is a bulging membrane, don't make a hurry, wait, take the cervical swab, send the CBC or CRP, make sure that there is no infection, and then go ahead. But then, whether we wait for these 24 hours and then put the stitch, or we give the advantage to the patient that putting an early stitch and rescuing her. Today, the consensus is that we send the cervical swab, we send the CBC, we send the CRP. Cervical swab, depending on the culture, you can change the antibiotics, but go ahead with this encerclage as early as possible if you are seeing the bulging membranes. Now, how do we reduce these bulging membranes? We can use sponge holders. Of course, they must be moist, and just gently apply the sponge holders to the cervix and pull the cervix towards you, and you may find that the membranes have got reduced. Or we can take a pediatric Foley's catheter, of course cut the tip so that, and then put this, so as, because that the inflated bulb of the Foley's catheter works just like a balloon, and we have to straighten that Foley's catheter with a stellate inside and push the membranes, and when you put the stitch, then you can deflate the bulb and remove the Foley's catheter. Or we can have a wet sponge on holder to reduce the membranes, or one can do amniocentesis to reduce the amount of liquor, so the membranes would reduce. Or we can over-distend the bladder. Over-distension of the bladder would push the membranes up, and the problem of bulging membranes can be reduced. This is the picture which demonstrates that the Foley's catheter can be used. Here we have cut the tip, and this Foley's catheter, now tip of this Foley's catheter is just like a balloon, and it has been, this Foley's catheter has been straightened up by putting a stellate inside. We push the membranes, put the stitch, and then deflate this balloon, and we can easily remove the Foley's catheter. And this picture shows that how over full bladder can reduce the membranes. This is not a true cervical length. True cervical length is probably only so much, and we can put the stitch. But technically, it may be difficult for us to put a stitch when the bladder is filled to this extent. For that, we really have to use long sponge holders with the needles with a small curvature. And we have been doing it in few of the cases and have succeeded in continuing the pregnancies beyond 34 weeks. This is the picture I have put of tracheal. We can have patients of failed McDonald. Now, I strongly remember this is a story 32 years back when I was a resident, and we had a nursing staff who had failed previous 3 pregnancies, and 4 times she had undergone McDonald stitch, and 4 times also her luck was not good, she still aborted. And then Madam Sardese was heading our unit. When she examined, she found that the McDonald stitch, as we all know, is little closer to the external os rather than the internal os. And we found that this patient had in her previous pregnancies the cervical tear. So she used to get aborted through that rent which was above the stitch. Okay. So what was done is then patient was subjected for tracheolography. This entire edges of the cervix were freshened up and sutured, and then the McDonald, because till then Shirodkar or modified Shirodkar was not in place, and she went to term, and of course we did not give her a chance of vaginal delivery because cervix was already repaired, and we did not know as to whether the cervix would dilate nicely or not, whether there would be excessive fibrosis at the site where tracheolography was done, and she was subjected to elective cesarean section, and she had a nice healthy baby. So patient was happy, and our whole unit was also very happy about it. We have certain contraindications to this cervical cerclage, like patient in active preterm labor, chorioamnionitis, vaginal bleeding, premature rupture of membranes, fetal compromise, if the baby has lethal defects, or there is an intrauterine death. By looking at this list of contraindications, I always think, would a sane person really put a stitch if these things are there? Okay. I mean, would a sane person go to Ukraine for a sightseeing in today's era? When there is a war going on, nobody would do that. So nobody would put a stitch whenever there is a situation of these situations like where we should be labeling this as contraindications. For my postgraduates, I would still say that you should still remember these contraindications, because you have to write so many things on a white paper, make it blue, and fill up the pages, and go out of this institute as early as possible. What anesthesia should be chosen? Because it's a short procedure, our anesthesiologists, they will give general anesthesia. But sometimes when we give general anesthesia, now gone are the eras when we used to use pentothal sodium. Okay, now everybody has shifted to propofol. But when pentothal sodium was being used to induce anesthesia, patient would cough or have a laryngospasm and have cough. That patient, if she is coughing, then she is going to increase her intra-abdominal pressure, she is going to increase the intrauterine pressure, and your membranes are going to rupture. So anesthesia-induced rupture of membranes can be a new entity in that case. To get rid of that, saddle block or regional anesthesia should be the anesthesia of choice. Now when you ask somebody, or say anesthesiologist particularly, that you give this type of anesthesia, they may not like this, that why are you telling me what I should be doing? So you just say, make sure that my patient does not cough, whatever the anesthesia you want to give. Okay. Now, which technique and which material should be used? It's today no universal agreement on that. It's at the discretion of the surgeon. Trials are currently in progress to inform the use of suture material. Many people are fond of black silk, and many people are very comfortable using mercilin tape. Mercilin tape not only costly, it's very difficult to pull through the vaginal mucosa. So you have to really be technically sound. Make sure when we are pulling the mercilin tape through the vaginal mucosa, we may tear the vaginal mucosa. So we have to make sure that without causing extension of the tear in the vaginal mucosa, you can pull the mercilin tape. So if those cares are taken, mercilin tape today can be considered as an ideal suture material for cervical cerclage. But yes, cheaper than that and still better is an umbilical tape, which we have used in some cases and are very comfortable with the umbilical tape. Now, question is single stitch or double stitch. There is no current evidence to support the placement of two purchasing sutures one above the other. You are going in the rain, and if you have two umbrellas one above the other, if the rain is coming from this side, no amount of umbrellas will protect you from being wet, or no amount of condoms being used can prevent the pregnancy if at all it has to occur. Encerclage for twins, it's no, and big no. Big no for twin pregnancies, because twin pregnancies you can have a cervical assessment on ultrasound, use all the clear guidelines, and you will find that the cervix is opening up. Putting the stitch not only does not help the patients with twin pregnancy, but does more harm to these patients. More harm, I mean, putting the stitch can induce the vaginal infection, can induce cervicitis, and can rupture the membranes earlier. If this patient was not going to rupture her membranes earlier, we may be responsible for that. So it's an iatrogenic failure. So for cerclage for twin pregnancy is big no. These are the common questions asked by the patients. Sexual intercourse, they need not really keep abstinence, because somebody thought that the semen contains prostaglandins and then that would induce labor. If that was the case, I would have advised all my patients to be taken for induction of labor, to have relations a day prior and come to the labor room the next day, so that the prostaglandins from the semen would induce the contraction. That does not happen. And so the only thing they have to remember, that there should be no nipple stimulation. Now, among the investigations, preoperative investigations, when we talked about CBC and CRP and cervical swab, some people earlier thought of doing fetal fibronectin testing. Fetal FFP, what is this? This is a molecule. These are the proteins coming from this is actually, it acts as a glue. Fetal fibronectin acts as a glue because it keeps the membranes attached to the decidia. Okay. And there is no fetal fibronectin in the cervical mucus. If you send the cervical mucus and if you find that it is positive for FFN, it means probably inside the membranes have started separating from the decidia. Once the membrane starts separating from the decidia is bound to release prostaglandins, and patient is having high threat of landing into second trimester abortions or preterm labor. But it has, rather than positive, it has more high negative predictive value. If FFP is absent, we should be more comfortable, but its presence really is not useful. Should women receive supplement progesterone following cerclage? Progesterone with cerclage has a better outcome compared with progesterone alone. For previous patients with abortions, if you start using progesterone and also put a stitch, it is better. But if you have put a stitch, and to help the stitch, if you are using progesterone, that doesn't help. So progesterone with cerclage helps, but cerclage with progesterone does not help. You conclude the way whatever you want to. Question is which progesterone? Natural micronized progesterone, or natural micronized sustained release oral preparations, or dihydrogesterone, or hydroxyprogesterone caprate. Natural micronized progesterone, all progesterones have their immunological effect. Okay, I beg to differ with what Madam Mala Arora said, that she would place dihydrogesterone superior to vaginal progesterone micronized. But all progesterone, for that matter, on this earth work the same way. They have the immunomodulation property. So whether it's dihydrogesterone or micronized vaginal progesterone. Now the question is, should you use vaginal progesterone or not? The only problem with using vaginal progesterone is going to be useful if the tablet is placed deep in the fornix. When placed deep in the fornix, these tablets will increase the progesterone levels in the decidia and the myometrium, and that helps. But many of our patients are scared of putting these tablets deep in the vagina for the fear that putting their finger in the vagina may disturb their pregnancy. Okay, and that's why I have really seen many of my patients submitted for IVF also. Initially they used to, when we used to tell them, you put this tablet in the vagina, and when they come for follow-up, I have found the tablets just kept on the labia. Okay, so now, then our progesterone is never going to work. So better give it orally. Progesterone, micronized progesterone given orally, 40% of it gets degraded in the liver. So we have to use the progesterone which is not likely to get degraded in the liver and have its effective action, and that's where dihydrogesterone comes. But hydroxyprogesterone caprate is the captain of all these teams as far as considering the patients with recurrent pregnancy loss in the second or third trimester is concerned. Not only this injectable drug has a lucrative effect, which is more effective than any of the progesterones used. When should the cerclage be removed? Of course, at 37 compared weeks, or earlier if there is onset of labor pains or premature rupture of membranes, or when we are taking the patient for elective cesarean section. During elective cesarean section, we must remove the stitch, because keeping the stitch inside
I'm talking about the vaginal stitches that have been put, okay, can retain a lot of blood inside the uterus and can cause problems to the patient. So whenever we have done elective cesarean sections, we better remove these vaginal stitches. And all patients with abdominal sarclage, they invariably require LSCS, but as I said earlier, the stitch can be kept in situ to be useful for the subsequent conception. This is the concept of cervical height. As you can see here, McDonald stitch is more close to the external os, higher is pseudochondral sarclage, and transabdominal sarclage is closest to the internal os. Higher the stitch, better the results. Indications for transabdominal, I'm not encroaching upon Dr. Kade's talk because he's going to talk a lot about the abdominal sarclage, but just to complete my list, the indications for abdominal sarclage are previous failed vaginal sarclage, or patient has deep cervical lacerations or very short cervices or short cervix following amputation. And this abdominal sarclage can be placed either by laparoscopy if we have a trained or a well-experienced person like Dr. Kade, or can be placed by laparotomy. We all can be, should be able to put that stitch by laparotomy. This technique, as I said, is simple in concept but difficult to implement, simpler and less complicated in non-gravity state, and it's safe to be put when it is put between 12 to 16 weeks. Of course, if it's an established case of cervical insufficiency, this laparoscopic cerclage stitch can also be put in a non-gravid state. This is the question many times, what is normal cervical length actually? The average cervical length is 4 to 5 centimeters, and it is expected to shorten as one gets further along the pregnancy. One study found that at 24 weeks of gestation, the average cervical length was 3.5 centimeters, and when it falls below 2.2 centimeters, the probability of preterm delivery is 20%. And this graph shows us that as the cervical length falls, the chance of preterm delivery would increase. And this tells us the normal cervical length, and you'll find here that as the gestational age would increase, the normalcy parameter will also decrease. I mean, at term, at 36 weeks, if we have 1.5 centimeter cervix, it's also good cervix at that gestational age. But the risk of premature delivery increases with the shortening of the cervical length. What is the optimal time of placement of the cervical? When the cervix is closed, before the cervix dilates, before the vaginal bacteria ascend, and before the release of cytokines and prostaglandins is the ideal time that we should be putting the stitch. The newer developments in screening for preterm birth or preventing strategies is the biomarkers. Functional biomarkers are the unique in their expression at first trimester in women who deliver spontaneously before 34 weeks of gestation. So in the future, these factors might allow stratification of patients at risk of preterm birth and identify women who might benefit from preventive strategies. It was in 1990, as I said, Caspi et al. Introduced modified Schroeder cerclage. Schroeder technique has the advantage of reaching up to 3 centimeters higher than the McDonald technique. And this is the diagrammatic representation of what is done in Schroeder cerclage. And here, anteriorly, the vaginal mucosa is cut and the bladder is pushed up as we do for any vaginal hysterectomy. How much do we go high up? You can appreciate here, this is the cervix, and then the gravid upper segment starts taking place, and there is change in the curvature. The place where the curvature changes is the upper limit that we should be reaching. Then only we can say that we have gone good high enough, and our stitch will be as close to the internal os as possible. These are the pictorial representations. This is the anterior vaginal mucosa that is cut, and with the fingers we dissect the bladder up, and we use black silk for this, and you can see the needle coming out here. So that was from 10 to 11 o'clock to 7 to 8 o'clock on the right side of the patient. Similarly, we take it on the left side of the patient, and you can appreciate here that if I would have put a McDonald stitch, it would have been at this level. Now I am so much higher, and our modified Schroeder stitch is really at a higher level than the McDonald stitch. Can you? Yeah, these are few small videos. Yeah. And you can see here that these bladder pillars need to be cut before we can smoothly dissect the bladder up. and this is my finger. So 2 distal phalanges of my finger makes 4 centimeters. So I am 4 centimeters above the, little above the external os actually. Next slide, please. No, the next one. The next one. Okay. Yeah, now. Okay. Yes. And we go through the substance of the cervix with a sharp needle. Pseudocrus cerclage, ideal pseudocrus cerclage, he uses the pseudocrus needle which goes in a tunnel between the uterine arteries and the lateral part of the cervix. So this is done on both the sides and the knot is placed posteriorly. This is a very simple procedure to implement, and as madam has already told in her clinical pulse, more and more obstetricians can go ahead with putting this modified pseudocrus cerclage, because every time Dr. Kade will not be available to us to put the laparoscopic encerclage at the level of the internal os. So this is the final picture. We can see that the knot has been placed pretty high, and our patients have high success rate. These are few of the complications. Membrane rupture or chorioamnionitis, increased cesarean section rates after cerclage, because the stitch can get buried, or stitch itself when removed can form a fibrous ring, and if accidentally our patients lands into preterm labor can lead to bucket handle tear. Now this was a study taken up by Saradesai madam. I am only presenting that here is the modified pseudocrus method of cerclage, and the aim of the study was to know the efficacy of modified pseudocrus method in patients with short cervix and to compare its efficacy with McDonald's method. 30 cases with short cervices underwent modified pseudocrus method of encerclage and carried pregnancy. 80% of them carried pregnancy to beyond 37 weeks. So as you can see in this picture that the cervical length at the time of encerclage in modified was 2.6 and McDonald's was also around 2.6, and at the time of delivery the modified pseudocrus, the mean gestational age of delivery was 36 weeks plus and McDonald's was 35 weeks plus, and the average neonatal weight in modified was 2.4 kg and McDonald's was 2.3 kg. This study proved the better efficacy of modified pseudocrus method as compared to McDonald method. Although the difference in 2 groups was not statistically significant, modified pseudocrus would be ideal procedure in patients with short cervices or previous McDonald's. The pseudocrus technique has the advantage of reaching up to 3 centimeters higher than the McDonald technique. So it's recommended that modified pseudocrus should be performed whenever cervical anatomy is unfavorable, like short cervix or presence of cervical lacerations. Also, it should be procedure of choice in patients with previous McDonald failure. I thank you all. This is not the picture that I am seeing here. I see a better picture in the audience at the end of my talk. And if you have any questions, Madam Saradesai is there in the hall to answer your queries. Thank you very much for patient hearing. Thank you.
I think it has been very comprehensive. Yes.
Just one comment. But the next speakers have allowed me to take 1 second of this thing also.
1 second.
Yeah. There was one slide, cerclage with progesterone and progesterone with cerclage. Yes. Only thing I remembered one story. शिष्य विचारतो गुरुजीला की मी देवाची प्रार्थना करताना सिगरेट पिऊ शकतो, तर ते म्हणले अजिबात नाही, पण तू सिगरेट पिताना देवाची प्रार्थना करू शकतो.
Thank you, Dr. Dabbe. If there are any questions, I think you can ask them in lunchtime, please. We are going to have it.
Tracheolaraphy to be done in non-pregnant state or pregnant state.
Sorry, sir?
Tracheolaraphy to be done in pregnant state or
non-pregnant.
Non-pregnant. Thank you.
I think all other questions will be answered in lunchtime. Sorry about that. Very comprehensive. Thank you. Thank you very much, Dr.
Ultrasound with Dr. Suresh, Chennai. The certified sonographer FMF at UK. His areas of interest in international fetal medicine. He holds a lifetime record and he loves films, fiction and journals. Over to you, Ajit.
नमस्कार. तर सर्वप्रथम मला इथे बोलायल्याबद्दल मी सोलापूर विजयवान सोसायटी प्रेसिडेंट डॉक्टर अंजली जमा यांचे आभारी आहे. सोलापूर आणि परवा काल साजरे केले आणि माझ्या शैक्षणिक कारकिर्दीमध्ये ह्या दोन शहरांचं कॉन्ट्रिब्युशन खूप मोठं आहे. कारण माझी 12वी-पर्यंतचं शिक्षण सातारा सिटी स्कूलला झालं. तिथे पण दुर्दैवाने मी माझी तब्येत गाठवली आणि सोलापूरला आल्याने परत माझ्या डॉक्टरवरती डॉक्टर. सो जे नामदेवाचं कच्चं मडकं होतं ते मडकं थापणारे दोन लोक इथं आहेत, सर देसाई मॅडम आणि गंडे सर. तर त्यांच्यासाठी मला इथं बोलायला आपल्या खूप आभारी आहे. Actually, I'm going to talk a bit on septic uterus. It's not about diagnosis of septic uterus, but I'm just trying to think through about diagnostic challenges in making a diagnosis of septic uterus. I'm not going to discuss the entire spectrum of uterine anomalies. I'm not at all going to discuss the surgical aspects of septal resection, that is Dr. Sandesh. आणि संदेशाने माझा नाता एक वेगळा आहे. सहसा मी मॅडमचा स्टुडंट नवस्थानचा स्टुडंट तसा माझा काहीसा हातभार संदेशसाठी लागला होता. सो ही एक चेन चांगली तयार झालेली आहे. Septum, we understand this, though it is called a vertical fusion defect, it is not fibroelastic tissue, but it is vascular in almost 70%.
And the incidence of septum will vary from women to women, from about 5.5% in general population to about 24.5% in infertility patients. And why septum diagnosis is very important? Because the accurate assessment is essential to propose a right surgical treatment for these patients. The moment we detect a septum, it's an urge inbuilt as a surgeon to resect that septum. But we should understand, by doing a septal resection, are we going to cause any harm to the patient? That is very important. There are so many modalities of diagnosing septum: HSG, 2D ultrasound plus saline histography, 3D, power mode Doppler, MRI, and so many confusing guidelines coming from history, ISG, ASRM, and CUME, that is Carinatal Uterine Malformation Expert Group. The problem is, how do we understand? What is the landmark separating reproductive hysteroscopic surgery of a true septate uterus and cosmetology of a normal condition. So it's very important to understand which septum are really going to be benefited by doing an hysteroscopic resection. Today we know a 2D ultrasound is very important picking up diagnosis, and the first diagnostic modality will be your 2D ultrasound. A good transverse plane of the uterus. So when you're doing your transverse scan, put the probe in the posterior fornix, take a transverse section. If you can see two uterine cavities which are widely separated, then we know we are looking at a uterine anomaly. But today we know 3D has replaced 2D, and it is the coronal plane in 2D dimension, 3D ultrasound that helps you in coming up making a complete diagnosis of septate uterus. So when it's ultrasound, we should remember two planes. When you're using a 2D ultrasound, it's a transverse plane. When you're using 3D, it's in coronal plane. The problem is, how are we going to differentiate whether this is a septate uterus or whether it's an arcuate uterus? Because the problem is whether we are going to treat this patient or whether we should not be treating this patient. Before the current classifications, we knew HSG was our gold standard, and it tells us about the uterine anomalies and the extent of uterine anomalies, but it doesn't give you really an idea where we should be operating upon. Is hysteroscopy is better as a primary diagnostic tool? The answer is no, because it is not able to measure the uterine wall thickness, and it cannot be used alone as a diagnostic tool. Hysteroscopy has no instruments for exact measurement of septum, and it is a subjective diagnosis by a hysteroscopic view, which has got a very poor agreement between the international experts. And there is always a fear of overcorrection by using a hysteroscopy, what is called as a hysteroscopic cosmetology. So why we need to classify septum? The answer is we need to objectively have an objectively definable criteria for septum. These criteria should be reproducible, and these should be very well correlated to your septal surgery. So we look at only two things. What is the external indentation? What is the internal indentation depth wall thickness? The internal indentation depth wall thickness, and what is the internal indentation angle. So three classifications here. The ISHRAE ESG classification, the CUME classification, and ASRM classification. All these three classifications are discussing but only two things. What is the internal indentation length and what is happening to this angle. But do ISHRAE and ESG, ASRM overdiagnose or underdiagnose? And the answer is yes. Most of these arcuaturae today will be labeled as septaturae if you strictly apply only the ISHRAE criteria. And whom to believe? And that's a big problem. Suppose you are using any classification into current practice. We look at the ISHRAE internal indentation of more than 50%, external indentation of less than 50%. ASRM internal depth of more than 1.5 centimeters, but internal indentation angle of less than 90 degrees. ASRM MAC, this criteria has been changed now, and ASRM has accepted that internal depth of more than 1 centimeter again contributes to septum. But this the CUME classification is very useful. It's the internal indentation of more than 1 centimeter is a more reliable way of defining septum. If you are going to stick to only ISHRAE classification, probably ISHRAE promotes more of septal dissections for a benign condition. And look at this paper, and this is a very nice paper. 100 women were 100 women with suspected fundal internal indentation were annotated and provided to 3 groups. The CUME classification could pick up 18 septaturae and 82 were labeled as normal uteri. ISHRAE, the exactly vice versa numbers, 80 septaturae versus 20 normal or arcuaturae, and ASRM 5 septate, 13 uteri could not be classified. So which classification we should stick to if we are diagnosing a septate uterus? The answer is very clear. It is a very simple classification proposed by the CUME group of people that internal indentation of more than 1 centimeter is a simple diagnosis of a septate uterus. Why we should spend some time in diagnosing a septate uterus? Because the impact of overdiagnosis of the septate uterus is very bad. It means more surgeries, it means more cost to the women. At a preventive hysteroscopy, somebody may come up with a recommendation that preventive hysteroscopic metroplasty before pregnancy may be useful. And the benefits of metroplasty are difficult to find. Why? Because the reproductive outcomes, including ART results in women with internal indentation of less than 1 centimeter and obtuse angles are the same as those without internal fundal indentations. It brings the question back to our mind, should we move back to our classification of arcuaturatus? Because the Hippocratic Oath tells us first do no harm. Probably by sticking to ISHRAE classification, most healthy women are being labeled, most healthy women with arcuaturae are being labeled as cases with septate uteri and will be subjected more for surgeries. The CUME classification offers a cutoff for all currently used measurements to make diagnosis accurately, reproducible, and in agreement with multiple expert groups. The another confusion that is always we have in mind is how do we diagnose a T-shaped uterus? And today 3D provides you 2 good measurements here. One is what is this depth ratio, this is the ratio, and these 2 ratios, and what is happening to this lateral angle. In these 2 tissues we can pick up the T-shaped uteri. If the lateral angle is less than 140 degrees, this lateral angle is more than less than 140 degrees. And this width, this is the fundal width versus this width. If it is more than 5.9, then we know we are looking at a T-shaped uterus, and this uterus will benefit by doing a lateral metroplasty. But nature is never going to give us mathematical models of uteri. Look at this uteri over here, 24 years old, 2 missed abortions at 7 weeks. And how do we classify this uterus? This internal indentation is only about 5 millimeters. The angle is 113 degrees and this lateral angle is 130 degrees. It's very difficult to classify such type of uteri and what exactly surgery we should be providing to these uteri. Look at uterus here again, a 32-year-old married for 5 years, first missed abortion at 7 weeks, then said 2 years back, shifting jobs, so there was no good follow-up. Now has come to the center and we have put in all measurements over here. The internal indentation is 8 millimeters. The angle here is 101 degrees centigrade. So this uterus does not fit into neither the CUME classification nor the ASRM classification, and we are left in dark as to how do we classify this uterus and what we should be doing to this small septum sitting over here, whether we should leave this patient or whether we should do corrective surgery. The problem here, see again few uteri, how do we classify and correlate to hysteroscopy, what treatments to offer, whether we should be offering some preventive treatments, if the patient is suffering from infertility, whether this septum should be resected, if patient has got only one miscarriage, and again whether we should offer a septal resection to these women or not. And again few examples where the nature stumps us. Again, this is the uterus where the internal indentation is more than 1 centimeter. The indentation angle, this is the indentation angle which is 125. This uterus will not be classified as septic uterus if you took to ASRM classification. But the CME classification will pick it up because this internal indentation is more than 1 centimeter. Then we know this is a septic uterus. So it's very important which classification we are picking up, which we are using for diagnosing a septic uterus. And one practical tip is getting your ultrasound machine into operation theatres for doing an ultrasound guided septal resection. I don't mean USG guided putting hysteroscopic scissors, but it is just looking at the completion of septum by deflating the uterus, doing your scan again and again trying to do the hysteroscopy again. The reason here is with the distension of the uterus, and when you are cutting the septum, because the uterus is getting distended with the fluid, the septum will tear. And it will cause a iatrogenic septal resection or a more septal resection. And we really do not know how much fundus we are going to keep it back. How we can decide that is to calculate a ratio. The mean of this, the anterior wall thickness plus the posterior wall thickness will give you how much fundus you should keep behind. So it should not land up you are doing a septal resection and you create a weak fundus which is going to rupture when the patient becomes pregnant. So it's very important to get your ultrasound machine in theatre, do a pre-operative ultrasound, do all calculations, do a septal resection, stop in between, take the fluid out, do a scan again. And if you feel that the septum is incompletely resected, then you can go inside and complete the job. So it's very important to know all these calculations when you are doing your septal resections. Thank you very much for your patient hearing. My idea of this talk was only to make your minds curious about what classification we should be using for septal resections and which septal uterus we should treat and which should we leave behind. Thank you.
Ma'am, your mic is mute actually.
Hello, very interesting. I just wanted to know from you, like whenever you have done the measurement of internal indentation and correlated it with the operative treatment, maybe with your surgical colleagues, and how it has actually given the outcome to the patient. Have you done study like that, or what are your views on that?
No.
Experience-wise.
Do you mean to say, can we do the septal resection in one sitting completely, or?
No. I mean to ask you, like, you are using the criteria of internal indentation, right? For your surgical resection.
Yes.
So, have you actually compared it with the outcome of the patient?
Yeah, if you stick to the CME classification, it gives you a near idea about completion of your septal resections. Normally what happens, like when you are doing your septal resections, because the uterus is also distended, you are able to see both the osteus simultaneously, and then you feel you have done a complete septal resection.
Again, there will be and body weight closed and some amount of septum will be there. That is the whole idea why we should be using ultrasound and doing all these calculations beforehand and intraoperatively and postoperatively. Definitely, if you do a complete septal resection, the outcome is much better. Traditionally, it was thought that if we have a longer septum, then we should offer septal resection in 2 sittings for this patient. Like you resect about a third or 1/2 of the septum, keep it behind, then go ahead and then do septal resection again. But today with good 3D ultrasound, it is possible to complete and do a complete job.
So you mean that we should include the intraoperative ultrasound? That is what you meant.
Yeah, that's my suggestion. That's my suggestion. It's not a what we say evidence-based recommendation or some research guideline, but it's my practical recommendation that probably using ultrasound during septal resection to make the job much better.
Thank you.
What did you mean by that? It is less fibrous and more vascular?
Yeah, traditionally, our traditional teaching is what it's. Yeah, the question is, the question is what Dr. Bawali wants to ask. What did I mean by the septum being fibrotic versus vascular? Like the traditional teaching is what? Because it is a vertical fusion defect, that part of the septum does not have blood supply or it's a fibrotic tissue. Therefore, we did not give it much importance. But after doing histological study, it comes to know that this is a vascular septum. That is in practice, therefore, majority of the patients will have normal pregnancies in spite of having a septic, because they will have pregnancy and they go to town. And when you are doing your C-sections, you realize that there is a septum. So septum is vascular. I just wanted to take that idea out of your minds that septum is not a fibrotic tissue. Septum is still a musculo-vascular tissue. Not fibrotic.
Does doctor help to?
Yes. Because these guidelines, these are what we can say, our own personal experiences, not have come into the textbook. But when we are doing your septal calculations, we do put in a Doppler there. Because if the Doppler tells me that this septum is vascular, I have to be prepared when I am doing hysteroscopic to split. Then I have to have something in my hand, like having a pediatric Foley catheter in the OT, putting that Foley catheter back, inflating the balloon back. So using Doppler is very important. You should do a Doppler vascular study of that septum using a pod.
Thank you very much, Dr. Ajit. Thank you. Thank you, Dr. Kadev, for being with us. You have been so busy here and there, but we are very fortunate today to have you here physically, and we are all we acknowledge your skills in endoscopic surgery and a special expertise, and you are giving a wonderful endoscopic services and operating on the various problems in gynecology. And virtually you are actually being international and national. I think I have no words to explain, what Dr. Kade is, a wonderful person as well as very well versed with his endoscopic skills, and we are very eager to listen to you now. Dr. Kade, please.
Thank you very much for those kind words. Good afternoon, everyone. At the outset, let me thank the society for giving me this wonderful opportunity to speak on a very, very controversial topic. Let me begin with one thing. These are not infertility patients. The biggest problem we find while we are treating the anatomical causes of recurrent pregnancy losses, we always compare it that what about fertility? These patients are conceiving. The only problem is they are not continuing. And so my topic relates to all those patients who have had miscarriage or failure. So the first thing is recurrent pregnancy loss means it's not a bad luck, it's some problem which is still there and it is continuing to be there. So we have to find out what exactly is that cause which is giving recurrent pregnancy loss. So what do? We do workup for the recurrent pregnancy loss, and that would be in my topic what exactly we do. Secondly, why do you need to do this recurrent pregnancy loss investigation or this whole workup which is so costly, is because these patients want to know why did this pregnancy fail. So to give an explanation and also for our preparation to give a better outcome next time, we need to investigate and work out these patients for better explanation of the cause of recurrent pregnancy loss. So the most important thing since morning, I am extremely sorry I could not participate since morning, but whatever you must have listened, if there is hyperprolactinemia, you have treatment. There is hyperglycemia, you have treatment. If there is immunocompromised state, you have treatment. You have for thrombophilias, aspirin is there and low molecular is there. Whatever you do, even if you change the embryos and take the best of the embryos, you have to concentrate on my topic, because if the uterus is at fault, nothing will work. So the recurrent pregnancy loss will still continue to be there. So it is the theory of soil versus seed.
whether the soil is at fault or the seed is at fault. So my topic belongs to the anatomical causes of pregnancy loss, and it is as big as 15%. And as we start understanding more causes which are unexplained at present, you will find more causes of anatomical problems. So what exactly are these anatomical problems we face is congenital developmental problems in the uterus, or these are acquired problems of the uterus that could be of the endometrium or the myometrium. So we have the commonest proven examples would be septate uterus, the bicorporous uterus, or the unicornuate uterus. These are very significantly related to the recurrent pregnancy loss. And in acquired causes where you have a damaged endometrial cavity or the uterus are submucous fibroids or polyps which are large, intrauterine adhesions, Asherman syndrome, and endometritis to some extent. So we have to find out exactly what is causing her recurrent pregnancy loss. And like everybody has told, these are the major bodies which give us these guidelines. So the first thing, when a patient comes to us in our clinic with recurrent pregnancy loss, the first chart which showed about the distribution, you take a marker and point whatever you feel significant, whether she has anatomical problems, whether you feel she has immunological problems. So that would be the first chart that would get marked. Next is the recommendation given is all females with recurrent pregnancy loss need the uterus to be evaluated, and the best modality we follow is the 2D ultrasound in our regular practice. But it has been shown and significantly proven by all three guiding bodies is that 3D is more significant in identifying the problem in every uterus. So we need to learn this Gynac 3D ultrasound estimation of the cavity. So the next thing goes is these patients go for a 3D. The radiologist will tell us about the T-shaped, the I-shaped, the Y-shaped, and that we document and keep it on the main paper that this patient could be a problem of T-shaped uterus, or a patient of Y-shaped uterus, or a patient of I-shaped uterus where the cavity is at fault. So then the second mark, and you can still go ahead by giving a spaced treatment that, okay, 3 months I am going to try for this. If it doesn't work, then we significantly cause that this could be your main cause of recurrent pregnancy loss. So it has been proven that all patients need to be investigated. 3D is the most preferred. Wherever 3D is not available, the 2D machine can be used for ultrasonography, where you distend the cavity and you find the intrauterine causes. If at all you don't have that facility, you can go with HSG. MRI is not the first line of treatment, but whenever you have adnexal pathologies, it could be more than one cause of her problem. So you need MRI in cases of adnexal, or if it is beyond the pelvis or the uterus is large and going beyond your tracing zone. So in those cases, MRI comes as the diagnostic modality. So the best classification which we follow is the Conuta classification, which is given by Eschrey and ESG together. So in this, now we are able to diagnose or classify these patients. The biggest problem was happening, okay, there is a round fundus and the indentation. Very good, it's a clear-cut septate uterus, cut it. The problem was happening, there is a septum inside and there is a indentation at the fundus as well. That was getting pulled maybe due to the severe fibrosis or maybe due to real septum. So the Conuta classification is the only one which can classify between a bicorporous and a septate uterus. So here you have a bicorporous, but here you have a septate along with a bicorporous. So these patients also need to be treated. Because they get labeled as bicornuate or bicorporous, nobody wants to touch them and they keep on having repeated miscarriages. So we need to classify them according to the Conuta classification. And then my topic of the surgical treatment. It's become very, very easy nowadays to treat septum. Can you play this? Okay. So the basic hysteroscopy which we have, the diagnostic and the operative sheath. You don't need to change your hysteroscope. The same operative sheath allows us to pass scissors, bipolar needles, and so if you are using, this is an example of a bipolar needle being used. You don't even need to go to glycine. There are no complications of fluid overload, electrolyte imbalance, no need for cervical dilatation. So these are very, very simple procedures, and the bipolar energy does not produce much of bubbles, so the vision is not hampered, and it's a very simple technique of performing. This was a residual septum where we have cut with the bipolar needle. Now the end point for me in surgery is when you see both the osteas together, when you move the hysteroscope from one ostia to the other with uninterruptedly, and when you release the pressure, it starts oozing. So those are the end points for me in a case of septum. Here is an example of a patient where the septum is cut with scissors. So now if it is a case of fertility problem itself, then very important is to not to use an electro energy source, and then simple scissors could be used. Scissors cut to a very small millimeter by millimeter. There is no chance of perforation if you exactly remain within the center of the septum. So this is the scissors being used. Here we actually, the scissors, the length being very, very small, you really need to give the thrust, and then it helps you to cut, and whenever you cut, it should form like a diamond. So we have had papers where we have done methylene blue dye test, and then when you cut exactly on that blue line, it goes into a diamond shaped area, so you know you are remaining exactly in the center and do not go into the anterior wall or into the posterior wall. So this is the example of scissors being used for septum resection. After the septum resection, the method we follow is we always give estrogen. Immediately after the surgery, we put anti-adhesion gel. So there are no clear-cut guidelines into what works best. So we try all the best things possible for the patient. And if it's a very, very severe, very large septum, we even go with Foley's catheter post-septolysis. This is an example of the resectoscope being used, and here this is a very old video where you will see the blue line which we used to do. Initially, whenever you have a dilemma where exactly or in a thick septum, then you put the methylene blue into the cavity and give a good wash. The methylene blue stains only the central part of the septum, and it goes exactly through the cornus and the lateral wall. So you know where to stop, because that gives you a diamond shaped area, and you can stop with your surgical cutting for the septal resection. This is a case of Y-shaped uterus where we, after repeated miscarriages and recurrent DNCs, these patients keep on going with more and more severe distortion of the endometrial cavities. And so we use, here you can see the ostia is not at all visible in spite of reaching the fundus. So this is the thick lateral wall which is seen, and this again is a bipolar resectoscope. So very, very safe, no transfer of electrosurgical energy. There is no need for glycine, no need for the life-threatening complications of fluid overload and electrolyte imbalance or the permanent neurological damage to the patient. So it's becoming very, very safe, and the surgeries are becoming very, very elegant with these modalities of treatment. So this is the bipolar resectoscope being used for the Y-shaped uterus, where you see both a septum as well as convergence of the lateral pelvic uterine walls. And this is a case of again redundant vaginal septum, where we do vaginoscopically. So you can distend the vaginal cavity, only the labias are being held with the Alice forceps, and this is the septum which was cut initially, and a part of septum which is remaining. So to answer the most of the queries that were being raised now was, how do we utilize the investigation tool for prognosis of a good recovery for the patient? So what we do is, you can decide about the residual volume of the uterine cavity. So draw the interosteal line, draw the indentation line, and from there go to the internal os. If the residual volume is less than the indentation, then the cavity is small, these patients need resection. Because lot of patients with septum have good pregnancy outcomes, the query comes is whether we should cut. So each patient is different. There are not going to be good guidelines in septum because the patient is the same marker for herself. You cannot have randomized control trials for septum because each septum is different. So the patient will only work as a control for herself. So you will have to go case by case in each patient. Secondly is the vascularity of the septum. Now very recently Betoki has done in true sense the septum resection. What we are doing is septum incision. We just cut in the wall in the center and the septum recedes. But in true sense Betoki has done the resection of the septum, and there they have found what is the level of muscular tissue, what is the level of fibrotic tissue, and then they have found that there is very high chance of vascularity. Now these vascular septums, they go into something, the new concept that is emerging is the trophotrophism. The placenta will try to find good blood supply in the uterine cavity. It will invade into these septums with muscular and vascular walls, and these patients are going to land up in placenta accreta, increta, and all that spectrum of adherence. So we need to identify beforehand the vascularity of these septums. And if it is an avascular septum, they are patients of infertility, the implantation failure. So if you have an implantation failure repeatedly, then you go for the septal resection. Those are mainly the thick avascular septa, and the problems of the vascular ones are the increased contractility of the uterus and the pregnancy failures. So we need to identify, and most important, what I think is going to remain finally is drawing the volume of the uterus. It has been proved volume less than 2 ml, these patients go in for repeated miscarriages. So if you have a good uterine volume, and if you are in that query or the gray zone to cut or not to cut, if the volume is good, don't cut. That would be the very simple answer to which patient needs surgical intervention or not. So next we go is the Conuta classification. Sometimes you have very odd, that is the bicorporis along with septate. And these patients you need to cut the septa. Sometimes you land up with very difficult patients, and this I do not recommend to perform these surgeries. But sometimes you find such patients who are seriously, they feel very hopeless, and we feel very helpless that we are not doing anything. They are on the verge of breaking their marriage. So in those cases, we do go ahead with these type of surgeries where we perform these are cases of second trimester miscarriages repeatedly, 4 or 5 times they have these carriages, and this is the case of metroplasty where we are uniting the two bicorporis uterine horns and performing but this is of course only in very, very few selected cases with lot of witnesses. We call the whole, almost all the major people in their family and the village to actually accept this, because these patients are at the risk of having uterine perforation or a rupture of the uterus in the antenatal period. So these are the cases of metroplasty, Strassman's or unification of the uterus in bicorporis uterus where they have repeated second trimester miscarriages. I don't know how to go ahead. Is there a याच व्हिडिओत जरा पुढे जा. ते नको, हे कर, सिंपल व्ह्यू कर, सिंपल व्ह्यू. इकडचं इकडचं नाही ठीक आहे, असू दे असू दे. So these are the cases where we do first the posterior wall of the uterus and then the anterior wall of the uterus, finally followed by helical stitches at the fundus. And if you feel that the fundus could have problems, then mesh metroplasty, these are the non-distensible meshes available, biological meshes can be placed on this and the uterus is sutured with these meshes. And surprisingly, we have videos of mesh plasties where you will see the uterus does not stretch at the part of the mesh, but the rest of the uterus, so it becomes something like our cards where you have Marathi matlab आपलं किलवर सारखं, that uterus grows accordingly and the pregnancy continues, and it gives very good release of tension at these suture lines with these biological meshes. So the final answer to all the queries would come very soon. The results are expected in 2022. That is the truss design multi-center trial that is happening, whether to cut or not to cut these borderline septums which go into the gray zone of being between arcuate and septate uterus. Next we come to the anatomical causes. In the unicornuate uterus, the problem is the uterine artery is present only on one side of a unicornuate uterus. The other side does not have uterine artery. So it is vascularly compromised uterus. Secondly, the postmortem reports on histopathology, they have seen the muscular wall is already deficient in a unicornuate uterus. Doing metroplasties, we are making it more deficient. So it's a very gray zone whether to do metroplasties or distending cavities in cases of unicornuate uterus. Now coming to the fibroids, we have to understand there are basically three types of fibroids. The intramural fibroid is the one which has myometrium on all sides. If this goes towards the cavity, one side will touch the endometrium. The very next time it becomes a submucous. So you have submucous fibroids touching or going into the cavity, or subserous. Subserous fibroids do not cause infertility. They are not related to recurrent pregnancy loss. Now intramural also are in a query where we take the size of the fibroid into deciding factor more than 5 centimeters. But submucous fibroids, it has been proved, are the cause for fertility, infertility or implantation failure, and removal improves fertility and pregnancy outcome. So submucous fibroids have to be treated. The classification we follow for submucous is not the FIGO, but what is called as step W, Lasmar's classification, where we see the size of the fibroid, the topography, where exactly is the fibroid, how much is the surface indentation, how much is the muscular wall penetration, and the wall of the fibroid, whether it is the anterior, posterior wall or lateral wall. Depending on this, immediately you get a score, and that gives us an idea whether this myomectomy is going to be a simple or a difficult one, whether I should go with a hysteroscopic or a laparoscopic one, or whether I should counsel the patient that I might need a operation in 2 sittings. So Lasmar's is the one which we follow for the submucous fibroids. And here I am showing you one example of my own nursing staff, the operation theatre. Play नाही होत रे. माऊस आहे ना इकडे येतो इकडे तो प्ले कर तो थांब जरा. Okay, so this is the case of repeated pregnancy losses, and her ultrasound had shown that she has always irregular uterine cavity with fluid retention, and she was a classic example of all 3 types of submucous fibroid in one case. So she had grade 0 where the fibroid was completely inside the uterine cavity. She was a case of grade 1 where 50% was into the uterine cavity, and she was a case of grade 2 fibroid where it was more into the myometrial wall. So here we are going into the uterine cavity. This is the intrauterine collected fluid that is escaping. Come here. पुढे जाण्यासाठी कुठे पुढे जाण्यासाठी पुढे 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 नाही पुढे ये त्याच्यात कुठं प्ले करायचं जा पुढे जा. Okay, so this is a case, the grade 0 fibroid which is inside the uterine cavity. This again is the loop resectoscope where we are using very safe, that is bipolar energy source, and again normal saline as the distension media. So this is the removal. We always cut it into the center. Do not cut the base of the grade 0 fibroid, otherwise it will be very difficult to remove this fibroid and to catch it again. So this is the fibroid that is grade 0 that is being removed. And then we have the next video, can you play? The second, always grade 2 fibroids, you need to operate on a very, very low intrauterine pressure. So this is the case of second, that is the grade 2. So here we are removing the grade 2, which is actually into the wall of the uterine cavity. Most of the fibroid, it gets missed, and if you are not aware with the preoperative diagnosis that there is a fibroid which is indenting the uterine cavity, then it is very likely that it is going to be missed with a pressure of 80 to 100 intrauterine distension pressure. So this patient now is very happy with her 1-year baby, and so a case of submucous fibroid with all 3 types together. Now this is a case of intrauterine adhesions and or the large submucous fibroid which caused the cavity distortion, and the fibroid was pressing on the uterine cavity, but it was very, very large to be managed by hysteroscopy. Okay. So this depends upon your Lasmar scoring, whether the fibroid is more than 7 to 8. In those cases, it is always better, even though it is a submucous fibroid, it is always better to approach it laparoscopic, because they are very huge, and hysteroscopic procedures could be really life-threatening, especially in reproductive age group. Because in reproductive age group, these women are under the influence of estrogen. Estrogen is very, very dangerous in hysteroscopy, and that is the reason, because when you have estrogen, the brain pump, that is sodium potassium, does not work. And if the patient goes into fluid and electrolyte imbalance, the sodium pump hyponatremia is worst, and that is the reason for fatal problems. So, and if you see all the complications all over the world, you will find young women dying in hysteroscopy is because of this estrogen. So if you have a very large fibroid submucous, always give GnRH injection, do a medical hypophycectomy, then perform a hysteroscopy. Then the sodium potassium pump is active, and these patients' lives could be saved. So here I think we are coming out with a large submucous fibroid with other multiple fibroids. Okay, next. Now, chronic endometritis, we all know that biopsy of the endometrium and understanding the staining patterns, we know whether these are infected, and they have also been shown to have the effect on recurrent pregnancy loss. So that could be treated with the antibiotic therapy and the probiotics, which have shown to have very good results in the treatment of recurrent pregnancy loss. Polyps, which are very, very common occurrence, polyps could be a cause or could be a just simple bystander. So we need to identify, and many polyps disappear by themselves. Give it a good chance to disappear. If it does not disappear, or if it is large, more than 1 centimeter, only in those cases we perform hysteroscopic polypectomy. That again can be easily performed with a loop resectoscope or with simple scissors and bipolars. And finally we come to Asherman's syndrome, where it is these patients repeatedly miscarry, they go in for check curettage, the problem increases, and finally they land up with very, very reduced intrauterine cavity, or later they go into, from recurrent pregnancy failures, they become infertile. So these are the patients where we need to treat them with hysteroscopy, and that helps us to perform the intrauterine adhesiolysis. So thank you very much for your patient listening. If there are any questions, I would be very happy to answer them.
Thank you.
Yes.
Hello.
Yes, ma'am.
Thank you very much.
Thank you.
And it was very interesting and very informative talk. Are there any questions? Short questions? Questions only, please.
See, I'm going to make one statement, which is a paradoxical one. The treatment of recurrent pregnancy loss is the cause of recurrent pregnancy loss. Because these patients, they come for dystrophy and a curettage is done. And repeated curettage, instead of using a medical method, causes either Asherman or endometritis and becomes a cause of recurrent pregnancy.
To answer that, it's a very important comment. Recently, we have started doing what is called as embryoscopy. So, lot of times when you send these products for checking, they say that this is contaminated or there is no actual fetal tissues. So what we do is now all miscarriage patients need to undergo a hysteroscopy. Then you will be astonished to find, and you will very soon have an atlas from Sergio Hamon from Egypt, where he has plenty and plenty of videos of miscarriage patients with embryoscopy, and there he has the photographs of all these miscarriages. Very soon they will correlate that which patient, and they could be very well picked up earlier. And you get exactly the fetal tissue or the placental tissue, just instead of doing a complete generalized cleaning of the uterine cavity blindly.
Now I request our chairpersons to felicitate our speakers. Dr. Rohini ma'am, please felicitate Dr. Dabrisa. Dr. Sharmila ma'am, please felicitate Dr. Ajit Patil sir. Dr. Kunthekar sir, please felicitate Dr. Sandesh sir. I request Anjali ma'am to felicitate our speakers, chairpersons, Dr. Rohini ma'am and Dr. Sharmila.
It is a double.
Everyone, after this relaxing and delicious lunch break, this session will awake you again. I like to invite our chairpersons for this session, Dr. Sulbha Zambre Madam and Vidya Tirankar Madam. Zambre Madam is most dynamic and ever-smiling person of our society. Age is just number for her. I welcome you, ma'am. Tirankar Madam, she is now HOD at OBGY Department, Civil Hospital. She is best teacher, best academician, ever enthusiastic person, always ready to help others. Thank you, ma'am. Over to you.
आपल्याला बायोडेटा दिलाय का ते किंचवाड करतो होते ना पण तसं त्याचा काय इंट्रोड्यूसच नाही करायचं ना आपण हां ते करते पण ते किंचवाड करतो हॅलो शुड वी स्टार्ट हॅलो एव्हरीबडी वी शुड I welcome you all I welcome you again for a post-lunch session. I'm very sure the speakers which are for post-lunch session will be make everybody awake and not allowed to sleep. Ajit is here, and we had just heard his lecture just now on septate uterus, and I'm very sure it will be a second interesting lecture by him. Already he has been introduced. Therefore, I request Dr. Ajit Patil to start his lecture.
A very good afternoon. I'm just going to take you through life of Jaya, Surekha, Swati, somebody staying in Sangola, somebody staying in Mangalveda, and facing same problems of recurrent pregnancy loss. So the talk given to me is managing current pregnancy in a woman with unexplained recurrent pregnancy loss, and this is more of a practical talk. ती खूप जवळ येते मला इथंच नाही काय विजनमध्ये येते मध्ये ठीक So this is going to be more of a practical talk with some practical tips and practical recommendations, not sticking to evidence-based medicine. I have my own reservations about evidence-based medicine, and of course I'll also touch on that when I'm ending my talk. If you look at pregnancy, how it is happening, and the endometrial receptivity, that is a tug of war between the endometrium, which is trying to reject the embryos, and something happening at the level of the endometrial receptivity, and two nice concepts there. What is the receptivity of that endometrium, and what is the selectivity of that endometrium? If the endometrium is too receptive, the woman is likely to land up in recurrent abortions, because that endometrium is accepting all embryos that is coming, and even it is accepting the aneuploidic embryos, and therefore this woman will present to you with a recurrent pregnancy loss. But if the endometrium is too selective in selecting a proper embryo, this patient will present with more as a case of infertility. So probably this is an endometrium which is trying to select too much, and it is waiting for that right embryo to come in and to get implanted into the endometrial cavity. Therefore, these patients will present with a long infertility period or long waiting for the pregnancy. So also, if you look at endometrial level, what is happening, it is a tug of war between the pro-inflammatory response that has to happen for that endometrial cells to open up and accept that embryo. But once that embryo is accepted by the endometrial prostaglandins and everything, all those inflammatory substances need to be suppressed. So the endometrium is caught between these two wars, a pro-inflammatory response which is very necessary for implantation and an anti-inflammatory response which is important for continuation of pregnancy. So this is a paradox, or this is the crux of all problems of our unexplained recurrent pregnancy loss. What it is that remains unexplained. And is it our limitation as a doctor? Is it our limitation of the clinical science? Or is it the limitation of the laboratory science? Because even after 3 losses, 50 to 60% of women are going to have a baby. So it is not that recurrent pregnancy loss means the patient's future is sealed. But the commonest clinical scenario that you and me face in our clinical practice is that the patient comes with a history of 3 repeated losses, and now she is having a pregnancy, and now our headache starts, how I am going to take this pregnancy further. So the UPT kit that she presents to us in OPD, and now UPT kits have become so common, is acting like a missile for us, because we are in doubt what we are going to do about this. So meet Jaya. She is a 32-year-old rural woman facing harsh nature as well as harsh in-laws, hostile husband, but battling on her own battle, 4 losses, 5th pregnancy, and she has been adequately investigated, whatever were the limitations, her financial limitations, she has been seen, and she had 1 medically managed abortion, 1 surgical DNC, 1 DNC where the POC karyotype turned out to be normal. This is her 5th pregnancy, and she was just overdue. What fight is back. She could not hold her back. She came to your clinic, and now she has got a positive UPT kit with her. The first question is what we should be doing as far as her ultrasound is concerned. Is ultrasound really indicated when the patient comes with just a 5 days overdue, and whether we should be doing an ultrasound or we should ask her to wait for 15 more days and then do an ultrasound. The scientific recommendation would be to wait for another 15 to 20 days because we are not able to see the fetal heart by that time. But for the patient's emotional support and patient's emotional connect with the pregnancy, probably ultrasound will be necessary. The normal milestones of early pregnancy are reassuring milestones, and therefore how frequently the ultrasound should be how frequently ultrasound should be done in a patient with an unexplained recurrent pregnancy loss, it is best left to an individual judgment, but every 2 weeks doing an ultrasound and showing her the positive build-up of that pregnancy, I think plays very important role in what we call it as the comforting care for this patient or the tender loving care. So she requested an ultrasound, and because she was about 5-6 days old, and today with a good resolution machines we know we can pick up ultrasound so early. So we did an ultrasound, the gestational sac is seen. The first question that comes to our mind, shall I start aspirin? And the second drug, shall I start progesterone? Now we have heard Dr. Mala Arora in the morning. Progesterones in unexplained recurrent pregnancy loss, all majority of the scientific evidences say that the progesterones are not at all indicated for recurrent pregnancy losses patient. Maybe like if you look at the bodies like ASRM and ACOG, they say maybe after 3 losses, you may put these patients on progesterone, but the blanket answer will be progesterones are not indicated. And most of us are used to putting these patients on aspirin and heparin. Let us see what the evidence says. This is a very recent paper, 2022, January 2022. And what does it say? Low molecular weight heparin and its combination of aspirin therapy cannot improve the pregnancy outcome with women with unexplained recurrent pregnancy loss. So the first drug that we often comes to our mind, aspirin and heparin in unexplained pregnancy losses probably is not a good drug of choice. Again, HT says no to heparin in unexplained pregnancy losses. HT guidelines do not recommend use of low molecular weight heparin for women with unexplained recurrent pregnancy loss because the evidence that the treatment does not increase live birth rate. But why this recommendation is coming into picture? Because the differences in study designs, the definitions of RPL, randomization, screening and treatment procedures make it very difficult to randomize the women into different types of groups and see whether the drugs are working or not working. And that's the reason probably most of us will end up in starting heparin for these patients. Is there any evidence for starting heparin? Answer is yes. If you look at this one more paper which says that low molecular weight heparin increases the T helper cell 1 concentration, the T helper cells, the TH1 and TH17 concentration is increased. So how low molecular weight heparin will work? Probably it could balance the pro-inflammatory responses implicated in the pathogenesis of recurrent pregnancy loss and thus regulate the processes at the feto-maternal interface. And thus thereby, by improving this pro-inflammatory response, probably these responses are very important for embryo survival and for the balance at trophoblastic invasion, heparin may have a role in even unexplained pregnancy loss. So even though the traditional or even though the scientific bodies say that the heparin is not indicated for unexplained pregnancy losses, there could be contradictory evidence which may prompt you to use heparin in these unexplained recurrent pregnancy losses. The third drug that often comes to our mind is steroids, and it will depend upon how you look at recurrent pregnancy loss. If you look at a recurrent pregnancy loss as a rejection phenomena, something like as a host versus graft reaction, that is a pregnancy is getting rejected, then probably steroids will work because then we know in any graft we are going to use steroids. So it will depend upon how are you looking at the definition of this recurrent pregnancy loss. If you feel that this recurrent pregnancy loss is a phenomena of rejection, probably the steroids may play a role. But if you feel that this is a deficiency of maternal pro-angiogenetic factors, then steroids are not going to play any role. So it will depend upon your outlook. If you look at association of prednisone, another good paper, association of prednisolone and antinuclear antibodies with pregnancy outcomes, it says prednisolone plus aspirin did not show any improved therapeutic effect over aspirin alone or in patients with unexplained pregnancy losses. So again the ball is coming back to our court whether we should be using this drug or not, but steroids definitely the answer is no. And of course, we have heard again Dr. Mala Arora in the morning speaking a lot about all these ancillary treatments. When we know in unexplained pregnancy losses, these are the women where there is no classical defined groups or subgroups. All these ancillary treatments do not work in cases of this recurrent pregnancy loss. So where it comes to managing the pregnancy, it is our best ultrasound, best friend in our OPD, that is ultrasound. So we should be concentrating more on ultrasound findings and look at some markers of early pregnancy failure. Today we know the RCOG definition of a pregnancy failure is gestational sac more than 25 millimeters or CRL of more than 7 millimeters without a fetal heart. The earlier definition was CRL of more than 5 millimeters without a cardiac activity, but now that has been extended. WHO has extended this to 6 millimeters. RCG now says an embryo of 7 millimeters without cardiac activity. Then only we should label this as a case of pregnancy failure. Always with transvaginal ultrasound, repeat after 1 week if the patient is asymptomatic. And a good practice point is it is always better to confirm this finding with another observer before making up a diagnosis of missed abortion or a failed pregnancy. Of course, there are some bookish findings which are the predictors of early pregnancy failure. If you look at the gestational sac, the CRL, yolk sac, cardiac activity, the shape of gestational sac, then we know some of these are the predictors of early pregnancy failure. We know the pendulum of ultrasound shifted from third trimester to second trimester, then from second trimester it came to 11 to 14 weeks. Now people are speaking a lot about third trimester ultrasound. Again the pendulum is coming back and now we are concentrating more on 9 to 10th week of gestation. And this is possible because of development of very high frequency ultrasound machines and improved understanding of the embryological pathophysiology, and we can do a good quality anatomical survey at even 10 weeks gestational sac, 10 weeks gestation to understand the normalcy of an embryo. So the role of an early anomaly scan, I am not calling this as anomaly scan, an early scan would be to establish normalcy over here. And again, there are a good number of papers which are coming in support of a good anomaly scan, which is possible even at 10th week of gestation. If you pick up anomalies like this, for example, here is a cystic hygroma, here there is again a mass over here again the raised NT with an omphalocele over here, and these are all 10 weeker fetuses, then we know probably we may not wait further and allow this pregnancy to continue further and push this woman into your first trimester screening programs or aneuploidy screening programs, because the aneuploidy markers are already seen over here. So there is definitely a role of doing a good quality ultrasound at 10th week. But it comes with a pinch of salt. There is a limited evidence regarding the detection rates. Many organs are still underdeveloped or they are still developing, and it could be too difficult to visualize at this gestational age. And a suspected anomaly diagnosis the woman will land up in more distress because you are going to declare a suspected anomaly and asking her to come back after 15 days, and those 15 days could be a period of lot of anxiety for this woman. So we should look at this recommendation with a pinch of salt, but if it is possible, of course, we should be doing an ultrasound at 10th week of gestation. One valid practical point would be to do ultrasounds at 10th week of gestation before sending these patients for aneuploidy screening. Aneuploidy screening could be by your FTS or could be by cell-free DNA. But before sending these patients for aneuploidy screening, if you do an ultrasound here, and that 1 in 10 woman where you find an anomaly at the 10th week of gestation, probably you are going to save a lot of headaches for that woman because she will be unnecessarily subjected for aneuploidy screening programs. But when the patient comes into 12th week of gestation, I think we have 4 different areas of concern for us. What is the problem of what is the risk about aneuploidy? What is the risk of this pregnancy developing into an anomaly? What about preeclampsia detection, and what about preterm birth? And so Jaya went for an ultrasound to an center, and this is an ultrasound parameters showing her risk. Her maternal risk, age-derived risk was 1 in 769. After the ultrasound was done, and this ultrasound was done by a good person, the risk diluted to 1 in 3,333. This was ultrasound-derived risk. But then she went for a associated FTS, and look at what is happening to after the FTS. This risk is increased from 1 in 1,000, she has become 1 in 724. So her risk is what has happened. The risk is not diluted. Though the ultrasound gave her a diagnosis of a dilution of risk, after doing in detail FTS, her risk has actually increased. Though she has not become high risk, but from a low risk category, she has gone into an intermediate risk category, and we need to do something for this woman. What we should be doing? That is a big problem. What we should be doing for an intermediate screen patient? Remember, I am talking about Jaya, who is coming from Mangalveda, and you just cannot tell her directly ki go for self-DNA or go for amniocentesis or go for CVS. Money is a big concern. So how can we address this issue? And this issue can be addressed by looking at your FTS reports in detail. What it is that which is causing an abnormal FTS report? Is it a fetal factor which is causing an abnormal FTS, or is it a maternal factor causing an abnormal FTS? Definitely, if it is a fetal factor which is contributing to an abnormal FTS, like a raised NT or abnormal ductus or abnormal tricuspid, these babies will require a definitive karyotypic diagnosis, and there is no way out here. These patients will require an invasive test. But if it is a maternal contribution, like a low PAPE or a high beta HCG, then we know we can escape out of this situation, because this is a maternal contribution which is coming to aneuploidy. And maybe if she is affordable, we can suggest her about selfie-DNA. Not Jaya, but some other lady, you can suggest her selfie-DNA. But even if the selfie-DNA is not possible, how can we choose a right pathway for this woman is to believe on our ultrasounds again. And remember, what we adopt in our practice is a continuous sequential screening using ultrasound markers. So what we do here, the first trimester ultrasound, we know the detection rates are about 91%. Call her back for another ultrasound at 16th week to look at 3 different factors: the nuchal translucency, the nasal bone, we don't call it as nuchal translucency, call it as nuchal fold, the nasal bone length, and the prenasal thickness. These are 3 important markers of aneuploidy that are possible at 16th week of gestation. Detection rates here will be 87%. And then call her back at around 20th week for looking at ultrasound parameters where the detection rates are fairly good. What we are doing over here is not going ahead with an expensive way of doing selfie-DNA or CF or amniocentesis, but using our ultrasound to our maximum and looking at all ultrasound parameters which are possible in our clinic and see what is happening to her risk. Now, these detection rates are only as far as these milestones are concerned. But if you do a sequential screen assessment, you know the risk is getting diluted further and further. Say for example, here the risk was 1 in 700. We know with these normal factors, this risk will become diluted further. This lady will have something like 1 in 1500. From 1 in 1500, when there are no soft markers, the risk will also go down again to something like 1 in 3000. So this is a sequential assessment of risk that we are going to do by depending upon ultrasound alone. Coming to anomalies, is the rule of 3 possible at 11 to 14 weeks? The answer is again yes. If you look at the fetal anatomy, divide the baby into 3 equal regions, 3 different planes, and presence or absence of 3 structures in that given plane, the mid-scan rule of 3. This rule of 3 today is possible with good quality ultrasounds available with us. Use your ultrasound judiciously, use the zoom buttons carefully, use the Sinello function properly, and use your transvaginal probes, because transvaginal probes give much better anatomical evaluation of the baby as compared to the transabdominal route. Is it possible actually? And this is a very large, this was again a paper from Pratima Radhakrishnan group, and always they are calling this as always detectable 9 always detectable anomalies. The detection rate of major anomalies at first trimester was 79%. So all 79 is a good number. You have capacity to detect almost 80% of lethal malformations by 11 to 14 weeks of gestation. And if we are able to detect such a large number of anomalies at 11 to 14 weeks, the answer is very simple. It is going to save a lot of headache for the women. The third question that comes to our mind is, what about risk of preeclampsia? And the question that we ask, are women suffering from unexplained recurrent pregnancy loss are at a higher risk of preeclampsia? And the answer is yes. These women who have unexplained pregnancy loss carry both the issues, the fetal growth restriction and the preeclampsia, both will be higher in this subset of women. So we should be directing our investigations into that area also. And that's what fondly I call this as preeclampsia clinic, your preeclampsia clinic. What is mean by your preeclampsia clinic? Preeclampsia clinic is nothing difficult. It is just training your staff how to conduct a preeclampsia clinic. This is your assistant doctor or a good nursing staff to whom you teach about history taking and measuring the blood pressures in both arms in a sitting position, and she will calculate what is the mean arterial blood pressure. With that information, the patient's biography, patient's demography and mean arterial blood pressure, patient comes to your clinic and you do your uterine artery Doppler. Again, it is my sincere request to you all, if you are having a Doppler machine with you, please try to do your Dopplers and ultrasounds on your own. These are the days where you will be sending the patients to your sonologist friends, no problem. You will be sending because we want to save on time, because a good anomaly scan takes about 30 to 40 minutes. But even if the patient goes to an sonologist, when the patient comes back, it is a good practice point to do again ultrasound on our own. Suppose your friend is doing a trans-abdominal cervical length measurement, we know it is wrong way of assessing the cervix, but he is not able to do a transvaginal scan because he is afraid, or because he is probably being a radiologist, he is not used to doing a transvaginal root scans. So when such a patient comes back to you, it is our duty to do your transvaginal scans and measure the cervix again. So you are measured you have done your uterine artery Doppler, you are measuring the uterine artery PI, taken the mean uterine artery PI. You are also collected the blood for beta hCG and PAPE, and the PAPE from this FTS is again we are going to use for your preeclampsia screening. And preeclampsia screening, we know it is a software based, it's a free software by FMF which is available on the net. You put in all numbers, it will tell you what is the preeclampsia risk. If the preeclampsia risk is more than 100, we put these patients on aspirin. If the preeclampsia risk is less than 100, we are just going to follow these patients at 20 weeks. So her risk came as 1 in 35 for early preeclampsia. The mean arterial blood pressure of 105, the uterine artery which is showing a diastolic notch and the raised PI. Is this an indication for putting these patients on aspirin? If you are not put her on aspirin, is this an right time to start aspirin? The answer is yes. This patient will require 150 milligrams of aspirin to be taken at bedtime. Remember, there is a lot of debate going upon the dose of aspirin, and people talk about 75 milligrams of aspirin, and in practice many of us are used to using 75 milligrams. The recommended dose is not 75, it is 150 milligrams aspirin to be given at bedtime and should be continued till 36 weeks of gestation. Should I take this abnormal preeclampsia risk as an indication for putting these patients on heparin? The answer is no, because the actions of heparin are very important. We have heard about actions of heparin. They are important in the early days of the pregnancy, because they are correcting an balance between the T1 and T17 helper cells. We know the heparin is going to act when the pregnancy is getting implanted and not later. So heparin after 12th week of gestation is not going to play any important role as far as reduction of a risk of preeclampsia is concerned. And that's what happened actually. If you look at her serum reports, PAPE 0.2 moms. So the PAPE was quite significantly less, and that's the reason her preeclampsia risk was coming higher. And then we take her into 16th week to look at these three important parameters. What is the nuchal fold thickness, what is the nasal bone, and prenasal thickness, and a ratio, the prenasal thickness divided by nasal bone length. And this is a cutoff of, with a cutoff of 0.98, a sensitivity of 88.5% and specificity of 100%. This is a very good marker for aneuploidy detections even at 16th week of gestation. So if you are not able to do the bloods at 11 to 14 weeks, or if the patient is not able to afford quadruple screening at 18 to 20 weeks, I think we have another good way of screening for aneuploidy is to look at the ultrasound markers and see what is happening. Of course, the checklist for a 16th week scan will be similar as compared to your 20th scan. The only advantage of pushing a 16th week scan is early detection. Establishing normals is very important part of a tender loving care. More targeted approach is possible if you look at subabnormality at 16th week of gestation, and obviously you can intervene if you intervene early if you have seen some abnormality. Of course, I am not going to speak about rule of T and 20-week scan, but this is a very methodical way of doing a good quality abnormal scan. And as a part of anomaly scan, we did her uterine artery Doppler, and look what has happened to the uterine artery Doppler. This uterine artery Doppler has now become normal, because we know that second trophoblastic wave, which is coming into picture at 18 to 20 weeks, will normalize majority of the uterine arteries. So this uterine artery has become normal. Shall I stop aspirin at this juncture, or should we continue with the aspirin? So this is not a reason to stop aspirin. We should continue aspirin till 36 weeks of gestation, because aspirin serves two purposes. Not only it reduces the risk of preeclampsia, it is also going to have a positive impact on fetal growth restriction. So it is also going to act away for that. So it is not a reason to stop aspirin. And remember, Jaya had 4 miscarriages. Is this an indication for encephalitis? Then how do we search for evidence for doing an encephalitis, or is a stitch for all a sound policy? And we have heard Dr. Dabade talking to us in detail about choosing a client for encephalitis. Is a patient with unexplained recurrent pregnancy loss a client for doing encephalitis? Though we shake our heads and say no in majority, in practice what happens? Majority of the women will undergo encephalitis. So we should be looking at a proper evidence here whether the woman is really having a short cervix or not. And then we remember one important thing, that we are carried away by a magic figure of 2.5 centimeters. We believe what happens to the gestational age at delivery and correlated the gestational age of delivery to the cervical decrease in the cervical length. This is an objective way of proving our hypothesis and what is seen. And this paper shows that if the cervical length decreases by more than 8 millimeters between the two readings, that is at first trimester and the second trimester, if the cervical length decreases by more than 8 millimeters, her chance of delivery by 34 weeks will be almost 66.6% and a specificity of 87%. To plot this into a simple things, we designed a small tool. This is called, I call this as dynamic cervical assessment tool, where we just enter the first trimester cervical length, the second trimester cervical length, and the software tells you what is the risk of this lady delivering by 34 weeks of gestation. For example, here the risk is about 30%. That means she's in low risk category of landing up in preterm birth. In this example, if you look at cervical is 43, it is become 35. This patient has got 84% chance of delivery by 34 weeks of gestation. So we are objectively trying to prove whether this cervix is behaving according to the expectations or this cervix is going to fall back. And there are good number of papers. The FMF model is single step cervical length measurement. It looks at the demographic characteristics, patient's age, the type of conception, and single cervical length at 11 to 14 weeks, and tries to tell you what is the risk of this lady delivering by delivering preterm. And look at the predictive accuracy of the FMF model, 38% for maternal factors, 55% for cervical length, and 69% for combined screening. But if you accept the two-step measurement model, Owen et al., they have shown a sensitivity of 69% and specificity of 80%, is almost similar numbers that we could prove in our study also. So what it tells us that we should be measuring the cervix transvaginally at two different stretches, at 11 to 14 weeks and at 20 weeks. Look what is happening to the cervical length and then act accordingly. So let us review Jaya's scan. And Jaya's scan tells us her cervical length was 34 millimeters at first trimester, 30 in second trimester. And it has become 25% or low risk. So at 20 weeks, this is Jaya, not Jaya, Jaya's husband. Smile on his face, because ultimately the doctors have declared that Jaya has low risk of aneuploidy. In Jaya's baby, no anomalies are seen. The cervical is normal, therefore doctor says no encephalitis for this patient. And the patient is on just routine drugs plus aspirin. Remember, she has low PAPE and high uterine RTPI, so aspirin we are going to continue. This is bringing some smiles on the face of the husband. But because this was rains and harvest time and Jaya was busy in harvesting and cutting the crop in her field, she came not at 24 weeks, but she came at 28 weeks. And look what is happening to the fetal growth. The abdominal circumference has come down to 5th percentile. So it was at 50th percentile and the AC has come down to at 5th percentile. Are we making a diagnosis of fetal growth restriction here? The answer is yes. Today, if you look at the diagnosis of fetal growth restriction, it is very important as an obstetrician to identify those babies which are trending towards fetal growth restriction and not diagnosing a baby suffering from fetal growth restriction. Both the things are different. We should identify a baby which is tending towards fetal growth restriction, because here we can intervene. But a baby which has already suffered from fetal growth restriction, there is nothing can be possible. So the simple definition of fetal growth restriction is inability of the baby to meet its own genetic potential or own genetic growth. So if the baby falls behind its predefined threshold for the given gestational age, I think we can safely make a diagnosis that this baby is suffering from fetal growth restriction. The moment you make, and how it is possible, this is possible only if you make a systemic ultrasound diagnosis, and that too, this ultrasound should be offered to all pregnant women and not only selective women, because if you do in mid-trimester, that's a good quality scan at around 20 to 30 weeks pregnancy. For all pregnant women, look at what is happening to the detection rates of fetal growth restriction. Another good paper from Lancet, and it tells us that the detection rates of, if you start universal screening for fetal growth restriction at 20 to 30 weeks, the detection rates of fetal growth restriction will triple as compared to screening only based on risk factors. So the point that should be taken is that this is a time to squeeze in another scan at around 30 weeks to look at fetal growth. Especially look back to your FTS levels, what is happening. If there is lag in CRL, if the uterine artery Dopplers are on the higher side, if the PAPI is low, or if there is a low alpha fetoprotein, all these are not only markers of aneuploidy, but these are also markers telling you that this baby is likely to suffer from fetal growth restriction. And there comes the role of Doppler. I'm not going to take you across the Doppler, but then we know Doppler is a systematic way of looking at how the fetoplacental circulation is happening and what is the way the babies are trying to adapt to these abnormal flows. And the Doppler timeline, we also know with the rising placental resistance, there will be a progressive fall in the end diastolic flow in the umbilical artery. And the moment the umbilical artery shows absent diastolic flow, that is a time to deliver this baby out. The Delphi consciousness today defines fetal growth restriction as an effective fetal weight of less than 3rd percentile or fetal weight of less than 10th percentile plus an abnormal Doppler. But to me, I am little skeptical about accepting this Delphi consciousness definitions of fetal growth restriction because this is too late for intervention. All these Western calculators wait till the baby's weight falls below 10th percentile and then only label these babies at fetal growth restricted babies. But that is not aim of a good quality antenatal care. A good quality antenatal care means we should be trying to help out all pregnancies and try to see that the babies are maintaining their growth at 50th percentile. So how do we identify babies tending towards fetal growth restriction? Because if we are able to identify babies tending towards fetal growth restriction, we can do a prompt intervention and that can lead to recovery. So the another practical tip is to squeeze in another 30-weeker scan, and this is an optimum time, optimum detection. And if you combine with Doppler, it gives an time, it also provides you time to assess the impact of your intervention. That's what I was trying to tell you. The problems of Western calculation is that all these calculators will wait till the fetal weight drops to less than 10th percentile. Here is the case again. This is a case, this is our case. This AC is touching the 5th percentile. We have fed this data into the calculator, and what it tells us, fetal weight is at 12th percentile, fetal growth is in the normal range. But this is not normal. We know this is not normal because this baby so long was growing on 50th percentile, suddenly is coming down to 5th percentile. This is like asking the student to wait till 9th term exam, and if you fail, then only I am going to help you. So the candidate had a 75% performance in the first trimester and second trimester, suddenly drops to 60%. The good teacher should be alarmed why this candidate is failing, why this candidate is falling behind. This fetus definitely requires a helping hand. Today we know sildenafil citrate is another good drug because all these PDE5 inhibitors improve placental circulation by doing decreasing the vascular resistance, causing a vasodilatation. And if you combine with argininic acid there, they also promote a neoangiogenesis, and a combination of sildenafil citrate with argininic acid definitely can reverse the abnormal uteroplacental circulation there. And so today a time has come to look at the growth velocity and not an isolated biometric parameter. What is happening to growth velocity? Again, a good paper which tells us that reduced growth velocity between 28 to 36 weeks of gestation is associated with abnormal CPR ratios and non-significantly with the acidotic umbilical cord pHs. So if these babies are showing a decreasing growth velocity in the 3rd trimester, these babies are more likely to suffer towards term. So it's again our duty to do a good quality scan and not only rely only on biometry, but look at what is happening to the growth velocity. And therefore this Jaya received the drugs, proper drugs, and with the same example, same graph you can see over here with stress. Today we know a lot of women are suffering from stress, and stress brings about cortisol. Cortisol is a vasoconstricting steroid, and if you counsel them properly, give them some good nutrition, good relaxation, and obviously good use of good drugs like sildenafil and argininic combinations, the growth is getting improved. Same Jaya after 3 weeks you see the AC is coming up. So it is never too late for any intervention to work because interventions will always work. When to deliver is a key question. If the patient is all right, we can wait till 37 to 38 weeks of gestation and then deliver these babies out. Of course, if you are going to take delivery decisions early, steroids, I did not emphasize the role of steroids. Only one point of concern over here is not to use steroids if the ductus venosus Dopplers are abnormal, because all those babies where the ductus venosus Doppler is abnormal have lost their adrenal, pituitary, ovarian, pituitary, hypothalamico-pituitary adrenal axis is already overworking there. And if you give steroids, this HPA axis will be suppressed and this baby will not do good in an ICU. So ductus venosus Doppler is a good marker or a good indicator to decide which baby should we give steroids and which baby we should not give steroids. But same is not true with magnesium sulfate. If you are contemplating a delivery, always use magnesium sulfate, because even giving a single bolus dose of 4 grams of magnesium sulfate before delivery stimulates the brain-derived neurotrophic factors production, neurotrophic factor production. So even if you are considering a delivery and delivery is say hardly 4 hours apart or 5 hours, give her a bolus dose of 4 grams magnesium sulfate, because by improving these brain derived neurotrophic factors, these babies will do good in an ICU. So 2 important drugs we remember, magnesium sulfate and steroids. Of course, Jaya was quite a high-risk woman by the time she developed preeclampsia and umbilical artery Dopplers became abnormal. So we delivered her out 2.1 kg girl child, a very short stay in NICU, and that's how the picture for Jaya was over. But then another lady, Sapna, was not so lucky, and she came to us with pregnancy again, 1 missed abortion, 1 ectopic pregnancy, another missed abortion, and the first time scan showed a nice beating embryo of 8 weeks. We did put her on, I really don't know why, but we did put her on injection B12 injections, and along with the rest of all support. But when she came for anti-scan, what we are seeing here some abnormality over there, acrania. So it was a point of distress, disbelief and mistrust in doctor's treatment, because we had already put this patient on B complex. The patient was quite intelligent. She asked, doctor, we have given B complex, and then instead of giving me taking all those B12 injections, why I have a baby with anencephaly? Then we need to sit with this patient. Of course, she is grieving. So she is grieving, she is sad. So sit with her, take your calculators and see the dates. For example, in this patient, this was her LMP. When she came for consultation, she was about 8 to 9 weeks. That's the time when we started B12. But what science tells us, the neural tube closes by 7th week of gestation. So even though we put her on B12, the neural tube closes by 7th week of gestation, the B12 did not act. And that's the reason she developed a baby having acrania. But this is also a point of solace for the patient to tell her, look, we can intervene. Next time probably you need to come in a pre-pregnant state and not with a pregnancy. So unexplained pregnancy losses, I think we should never lose our heart. Counsel beforehand about multiple factors and inability to reach to conclusions. Understand the limitations of current investigative medicine. Review our findings at each step, and consider pre-pregnancy consultations and planned conception. I think the challenges of evidence-based medicine are tested to the maximum when a case of unexplained recurrent pregnancy loss comes to us clinic. Does evidence-based practices introduce bias as far as patient's treatment is concerned? I strongly feel yes, because for the patient, your evidence doesn't play any role. For a doctor, I think this is a classical evidence-based model, with individual clinical expertise, the best external evidence and patient's values as expertise. It's a very idealistic model of evidence-based medicine. But what patient wants? Patient doesn't want your evidence-based guidelines, patient wants a baby. So your individual clinical expertise and patient's values and expectations will not match to what the evidence is saying. So this is what I'm saying. A case of unexplained pregnancy loss throws all your evidence to wind, and you have to take your balanced decision. Thank you so much for your patient hearing, and again I thank the office bearers of Solapur Society and my teachers who are here for calling me to interact with you. Thank you so much, and if you have questions, please feel free to ask. I know it was a little exhaustive, I'm sorry.
Hello. It was a very, very practical lecture. But I just want to say, are we really have a daring not to start any progesterone when we have 3 consecutive losses? because you are not, it's very difficult. In practically, I think everybody amongst us, we do start a progesterone when we have a consecutive, especially unexplained recurrent pregnancy loss. No?
So
Yeah.
that's what my last slide is a summary of what I was discussing, talking to you over last 25 minutes. The whole summary is in my last slide. The
Yes.
evidence-based medicine and the experience-based medicine are always at crossroads when it comes to giving results to the patient. The evidence tells us that the progesterones are not good drugs, they are not useful drugs as far as pregnancy losses are concerned. Unless and until you are able to classify your unexplained pregnancy loss into some type of subgroup category, giving blanket progesterones to all unexplained pregnancy losses is not good option, not good option.
Anyway, it was very, very interesting and very practical lecture. Thank you very much for
Thank you
that.
so
We are moving on the second lecture now.
I welcome Dr. Suchita Kinchwadekar, madam. She is a leading obstetrician in Mumbai. She is a Manyata assessor and Laksha mentor. I welcome madam.
Good afternoon, everyone. And I really appreciate and congratulate Dr. Ajit Patil for such a beautiful lecture. This was, I think, worth like a oration. You know, you have unfolded the journey of a common, what should I say, a patient of recurrent pregnancy loss very well. And this is a very day-to-day aspect that I think each one have experienced in our practice. And now, that is first part. Second part, I think he has covered most of my talk as well. So in my mind, I was really thinking how quickly I can rush through my slides. Nevertheless, thanks for giving me this opportunity. Thanks, Solapur Society, for inviting me. Thanks for agreeing to detour a little from your theme topic, because what doctor called me and said, Doctor, will you speak on infections in RPL? I said, no role of infections in RPL, my talk is over. Tell me something else. So then she said, okay, what do you want? I said, let me talk on how to prevent preventable pregnancy loss. And enough of pregnancy loss that we have heard in first half of today's topic, today's CME morning half. The second half, nevertheless, I think I should be more focusing on late pregnancy loss. I'm Dr. Sucheta Kinchwadekar. I'm from Navi Mumbai. And whenever it comes to facing a Jaya at Mangalveda or a Jen in Mumbai, it's all the same, believe me. I'm private practitioner like most of you and practicing for more than 30 years now in Navi Mumbai. I'm also now involved in Manyata program. A few of you are aware of it, and those who are not, I'm not leaving you. At the end, I'll talk about that as well. So friends, we are here, obstetricians. Can I get the other view, please? So we are here obstetricians to, deliver happiness and joy to patients. But many a times it doesn't happen, and a day comes which is of a big disappointment, not only for us and our nursing staff, but parents and, the new would-be parents and their entire family. Friends, looking at this burden of stillbirth, what I will like you to know that globally, every 4 minutes, every minute there are four stillbirths, okay? Secondly, amongst these 4, 3 are from developing world. India heads the list of 6 where there is maximum incidence of stillbirths. And when we are saying stillbirths, pregnancy losses, though the definition is from 22 weeks, I think we should consider more of a viable age pregnancy loss, that is from 28 weeks onwards, to early neonatal loss, because all these losses matter to patients a lot. Why babies die? Variety of reasons. And we don't want baby to die, at least for these reasons, for few reasons where we can do something and prevent these losses. We know baby survives because of glucose and oxygen that baby is receiving from mother through placenta. This silsila continues even in first stage of labor, even in second stage of labor. Though during labor, whenever there is uterine contraction, the placental bed is not filled up with blood. I mean, there is a cutoff of blood supply to the baby, and still baby manages to survive through this. But babies who have already depleted their reserves sometimes cannot make this during labor. As I said earlier, be it a developed nation, developing nation, different causes of pregnancy loss or IUDs or stillbirths, we in our practice sometimes are like developed nations when we have resources. Sometimes we are like developing countries, third world countries typically when we don't have many things or patients are not affording, not understanding. Variety of causes of ante and intrapartum, but what WHO says that basically most of the stillbirths, more than 40% of the stillbirths are preventable, and preventing stillbirths is some kind of standard of care, and hence we need to improve on that. When there are variety of reasons because of which stillbirths can happen, I think we need to at least catch on low-hanging fruits, right? We don't want stillbirth to happen, we don't want IUFD to happen, but why it happens? Because we fail to detect certain cases, and how to avoid these causes is basically, I'm going to focus out of these multiple reasons, only two causes. One is diabetes and second one is FGR. Now diabetes we may come across whenever patient comes. If she is a type 1 diabetes, at times we know that she is type 1 diabetes, poorly controlled, better controlled, ill controlled, whatever. Sometimes type 2 diabetes is detected for the first time in pregnancy when even the random sugar is pretty high, or whenever you are doing HbA1c pre-diabetic state, she is already 7 or 8 or 9. Many times when we are doing thalassemia testing, hemoglobin electrophoresis is a routine screening test. As a side product, we come to know that HbA1c is pretty high and she is type 2 diabetic, I mean pre-pregnancy diabetes. GDM, unless you check for it, it is never revealed. Unless a mishap happens, if it's not your routine practice, GDM is not diagnosed, and day in and out we see obese patients in our practice which probably belong to the same group. We know Indians are more prone for diabetes and GDM. We all small people who are born small, normal smalls or FGR smalls to our parents are getting genetically programmed to have GDM in future life, to have PCOD, to have syndrome X. So Indians are at risk of GDM. Now risk of IUFD increases double and triple in type 2 diabetes if baby is outgrowing, I mean it's LGA baby, and it triples if it's the FGR in type 2 diabetes. Similarly, pre-pregnancy HbA1c tells us the risk of stillbirth in diabetes. Now, having said all that, if we want to avoid any mishap because of GDM, I think we need to make a routine practice to do HbA1c ideally pre-pregnancy, provided patient comes to you for pre-pregnancy counseling. Nevertheless, at first point of interaction, it's a good practice to do HbA1c and sugar, though it has its own pitfalls. If not, fasting sugar, if it's done and if it's more than 90 in pregnancy, consider that this is a kind of diabetes, probably pre-pregnancy diabetes. Always make it a habit to do at least one step 75 gram DIPSI test once in first trimester, and if negative, again to repeat it after 28 weeks. And with this, probably you are not going to miss GDM. And still, even if these tests are normal, keep keep a special eye on patients who are obese with BMI more than 35, PCOD conceptions, family history of diabetes in mother, previous big babies or previous stillbirths or previous unexplained IUDs, 90 centile growth, polyhydramnios, AC more than 50th centile in third trimester. So all these things, like, keep your antennas open and keep looking for diabetes or hyperglycemias in pregnancy. Now the mainstay of management or preventing IUD because of diabetes is pre-pregnancy weight should be controlled, HbA1c should be normal, offer universal screening, DIPSI test twice in a pregnancy. Don't hesitate to start treatment if it's not getting controlled with measured nutritional therapy trial for say 15 days. Don't hesitate to start insulin if it is required. And last but not the least, SMBG, it's very, very important. SMBG is self-monitoring of blood glucose. I always tell patients, तुम्हाला ताप आला तर डोक्याला हात लावून समजेल, पण शुगर वाढली आहे हे कोणालाही समजणार नाही जोपर्यंत तुम्ही चेक करत नाही. So self-monitoring is very, very important, and we need to emphasize this to our patients of GDM. How this is self? They need to buy a glucometer, do a self-check, do at least 4 times in a day to begin with, fasting, post-breakfast, post-lunch and post-dinner. Call patients more frequently and they can WhatsApp you the report. If more than 50% of the reports are abnormal, that is high, keep a low threshold for that. Start medication. Daily exercise, it's very, very important. Be it a spot walking at in the house itself, even if it's a lockdown. And take help of dietitian and diabetologist. But best surveillance method is blood sugar level and not scans and BPP. Scans and biophysical profile are going to tell us that probably this is not properly managed, but her chart is going to tell us more precise status. Timely delivery is very, very important. If she is a GDM and there is a good control which is evidenced by SMBG and ultrasound, then she can wait till 40 weeks, but don't allow her to go beyond 40 weeks. If she's a type 2 diabetes, or if she's a GDM who needed metformin or insulin, then she should be delivered by 39 weeks. And if she's a type 1 diabetes, even though it's a good control, she should be delivered at 38 weeks, because 39 weeks more chance of pregnancy loss if she is having hyperglycemias. Second important cause of pregnancy loss, near term or full term IUFD, is FGR. Now why why babies die of FGR? Here I want to tell you one interesting story. This is Dr. Jason Gadosi from UK. Till 2005, we used to classify stillbirths by Wigglesworth's classification, standard classification, and look at the classification of stillbirths. It says more than 66% stillbirths are unclassified or unknown because of unknown etiology. What he did in that area, in that region of province of UK, he studied more than 2,600 stillbirths out of so many, I think 4.5 lakhs of live births in this period of 6 months, and he actually they analyzed sex, birth weight, result of post-mortem examination, pregnancy details, and he analyzed these 2 causes, relevant condition at the time of death, recode, and he classified all these all stillbirths again, first by Wigglesworth's classification and then by recode system. And what in Wigglesworth's classification said 66% stillbirth, his analysis said that 43% are there is associated condition of FGR. Now why FGR babies die? Early onset FGR, probably we tend to catch them, we tend to monitor them and deliver them appropriately, but it's the late onset FGRs which actually we miss. We miss in clinical examination, we miss in ultrasound diagnosis, and as what Dr. Ajit Patil has very rightly said, nobody takes into account the growth velocity. We see and evaluate at point scans and say this is normal, but the velocity, the slope we tend to forget. So in his perinatal institute, what he did was customization of growth chart. It's not Western population, but the customization is done as per the ethnicity, as per the height, weight, BMI and parity of mother, and every mother gets her own customized growth chart. So if 2.6 kg baby is a normal for me, 2.6 kg will be IUGR for another very tall African woman. So customization is very important. This is Gardosi. We had invited him at Navi Mumbai Society, and Dr. Rohini also was one of the faculty at that time. So FGR is associated with stillbirth and perinatal morbidity, and most stillbirths with FGR are avoidable and associated with suboptimal care, and hence he took that as a mission in UK to reduce stillbirths. Now we know fetal growth is directly proportional to growth potential and substrate availability. What is substrate? Whatever blood that placenta is getting from maternal circulation is substrate, and growth potential is derived from genetic material of both father and mother of a baby. And customized chart will identify more FGR baby, so it will not underestimate, it will not overestimate. So the logic behind customized growth chart, because growth charts usually of two types, population based means one population for Indian, one population based chart for European, but even amongst Indian we have diversity, we have diverse ethnicity, we have each two individual, I mean in this present hall itself, one is 5 feet, the other is 6 feet tall. So there is a diversity, and hence a growth chart needs to be customized. SGA and FGR, while differentiating between these two, size should not, if we consider size as the only criteria, then often we may mislead. See this group of chickens, if we separate these babies, you know these are small babies but normal, but only these two babies, only these two babies are FGR babies. Rest these babies are all small babies. So size should not be the criteria. What happens in FGR? If, as baby gets less substrate, baby is not growing to its desired growth potential. As a result of this reduced blood supply or reduced nutrition, there is chemoreceptor stimulation, there is CNS dysfunction, and which is reflected or translated into non-reactive CTG, reduced fetal breathing movement, hypoxemia, absent movements, acidemia, and IUD. This sequential event may occur in early onset FGR, whereas in late onset FGR, when the FGR is after 34 weeks, often baby doesn't get time to adapt itself, and suddenly at one fine day baby was moving and the other day there is a IUFD or stillbirth. So if we want to prevent loss because of FGR, we need to suspect, we need to detect, we need to monitor, and then we need to deliver at appropriate time. How we are going to suspect? Either by clinical evaluation or serial growth scans. Now serial growth scans, performing growth scans in each patient may not be practical, logistically feasible. So clinical examination, if you are doing, do clinical examination and measure symphysiofundal height by a tape measure. Get used to measuring this, put it on paper measurement, because at one day when you are saying 28 weeks and 32 weeks, when patient comes after 15 days, you also tend to forget how much was her abdomen at that time. But if you have written 30 centimeters and 31 centimeters and 32 centimeters, it's the objective evidence. So if you are going by clinical examination, please do measure symphysiofundal height, and this is to be done every 2 to 3 weeks in third trimester. As it is, we call patients after 28 weeks, every 2 to 3 weeks. Now, advice scan if there is a growth lag or if there is same symphysiofundal height. Okay, so at this point of time, you are going to advise scan. Now, you need to suspect in these patients more, I mean, you have to be more vigilant in all these patients who are likely to have FGR. So, age more than 35, nulliparous patient, I mean almost all primaries, low BMI, high BMI, multifetal pregnancies, IVF pregnancy, pregnancy with a very short span interval between two pregnancy or pregnancy happening after 5 to 6 years of previous pregnancy. Then in previous pregnancy, if there was a stillbirth, FGR, preeclampsia, maternal SGA, mother herself was a small child, maternal medical history. See, all these are things which gives you a possibility of FGR in present pregnancy, and possibility of FGR means stillbirth risk. So if there is a stillbirth risk, all these patients, it's worth subjecting these patients to serial growth scans right from 26 to 28 weeks till delivery. After 34 week scan in this patient, if it's normal, it doesn't mean that you are going to do only clinical checkup after that. So after 34, she needs a repeat scan at 37 weeks again, because the growth velocity, you know. And if you start plotting these on customized growth chart, I think you'll get to know what I want to say. Let me see if that slide is there. So then, whom to monitor when you are doing scans or clinical examination, and after that doing a scan? The patients who are touching or nearing 10th centile, if interval growth is flat or if there is a static growth. These are the patients whom you need to monitor by repeated ultrasounds and Dopplers. What are your monitoring modalities? Dopplers, biophysical profile and CTG. This is the customized growth chart, what I wanted to tell you. Now, since this is a customized chart, you can see her weight, though on Western graph, this says that this is a smaller centile. On Barcelona calculator, it was suggesting us to deliver. But since for this, because this was a customized growth chart, for patient's own height and weight and BMI and age and all that stuff, this is not a FGR baby, this is a SGA baby. We need not do anything for this case. Now, to differentiate between SGA and FGR, we know that SGA, that is small for gestational age, these are normal smalls. And whereas FGR, they are starved smalls. So both are smalls, but the metabolic adaptations are different in these both. But remember, SGA becomes a retrospective diagnosis. When at the end everything turns out to be normal, then you say that this is a SGA baby. Early onset and late onset FGR, I think all of us know, and I need not again deliberate more in detail, but what I want to always say is late onset FGR is a diagnostic challenge. People tend to miss the diagnosis, and hence all well and patient still goes in stillbirth or IUFD. Actually, it is not all well, it is probably you have missed this late onset FGR. Now, for those who are not doing their own scans and reading people's scan and they want to actually know what is the centile, this is a WHO calculator, and you can actually, let me see, video nahi chalu hota hai. Okay, at the end I can show you. I have already put this particular thing in the Google. This is the website srhr.org fetal growth calculator. Now if you put your head circumference, AC and everywhere, everything comes, like you come to know that AC is less than 2 centile. You put your patient's parameters in this and you'll come to know. So even if that graph is beyond your understanding, you can put patient's weight and patient's AC or directly patient's estimated weight what sonologist has given, and you will get to know what is centile at that particular gestational age, not only on the graph but even by the figure written. Now remember, this is not a customized one, this is by WHO. But nevertheless, it gives us some idea about the centile, because figure, absolute figure carries no meaning unless you put it in centile chart. So monitoring these babies by growth and weekly Doppler and fortnightly EFW. Whom to monitor? Those who we have already we are suspecting FGR in these babies, and whenever you are doing Doppler, it's not just umbilical, but it should be umbilical MCA and CPR, especially for late onset FGRs. I think MCA and CPR, because umbilical artery still may Doppler be normal in late onset FGR, but what you need to pay attention to, MCA, dilatation of MCA and lowering PI of MCA, and hence changing CPR. So this is the flow chart what Perinatal Institute and I think even the RCOG recommends. I have broken this into 2 parts for you all. Now this is these are low risk patients. In low risk patients, just serial fundal height measurements, and if in these measurements you suspect that there is abnormality, that is there is growth lag, then do a scan. If its scan is normal, return back to clinical examination and continue your management. If scan is abnormal, that means there is actually a small baby, I mean the growth centiles are fallen below, then do 2 weekly EFW, do uterine umbilical artery Doppler and Leica volume as required. If she is more than 34 weeks, add on MCA from then. If everything is normal, go for expected management. If she falls into this category, then consider delivery at earliest. So this is one part of low risk patients, and this is another part of high risk patients. All those criteria which I had enumerated in my previous slide, in whom you are going to suspect FGR, other, oh my God. I thought some missile came in. So am I shouting? No. So if these are high risk patients, then serial growth scans right from the beginning, and the pathway is almost the same. How to deliver? Of course, each and every baby doesn't need LSCS. There are criteria. If absent reversed umbilical artery, then yes, LSCS. If it's stage 1 to FGR, then induction of labor can be done. A word of caution. If you are putting Cerviprime gel, it's a chemical mode of initiating labor, and there is a possibility of hyperstimulation. I practically use Foley's catheter for each and every FGR patient induction, and it's a very good way of initiating labor, and we can deliver patient. Now this is one example of customized growth chart, and cross are symphysiofundal heights, and dots are actually weights. So this is the weight. Baby's weight falling below 5th centile. This is the Doppler, and then we delivered. See, you can take help of either Barcelona calculator or FMF calculator in case you are in doubt whether to deliver or whether to wait with all these Doppler evaluation, because these calculators step by step ask you each reading, each PI of umbilical artery, MCA and ductus and things like that, and guide you whether consider delivery, and you can wait. And I actually show this to patients and say that yes, we are taking opinion, and see they are seeing that consider delivery. So I am also suggesting like delivery is indicated. Now at the end, one small case. This is a Krupali patient. She came last week. She was a primey. Her pape mom was 0.4. She was ovulation, induction, conception actually. Pape mom was 0.4. Anything less than 0.4, high risk of FGR. On serial growth scans, which we did, every time Leica was normal, baby weight was fine, Dopplers were okay. So at 37 weeks, this was the thing. She didn't agree for IOL, induction of labor, at that point of time, Why I advised? Though umbilical artery Doppler was normal, MCA 1.1 is on the higher side. This was a precious pregnancy conceived after ovulation induction. Her papillom was 0.4. So compiling all 2-3 data at 37 weeks with this Doppler, we suggested induction of labor. She said, Amavasya hai, techa nantar I'll come. And immediately after 5 days, she came with one fine day with reduced fetal movements. And this is her CTG. She was not in labor. Os was closed 1 centimeter. So no question of, augmenting or hurrying the labor. And continuously, these were the decelerations shown. We sectioned her. Baby was hypotonic. Baby did require bag and mask for as a resuscitative measures. Ultimately, baby and mother went home together. So this is a kind of protocol for reduced fetal movement. When patient comes with reduced fetal movement and you don't know what she is, whether she belongs to SGA, FGR category or not, at the time of reporting reduced fetal movement, CTG. If CTG is not good, then you need to take certain action and deliver her. If CTG is absolutely normal, then arrange for a scan within 24 hours, and this is the time when you should actually categorize this patient. If she belongs to that small group, then it's wiser to deliver even with 1 episode of reduced fetal movement. That's all. So let's prevent what is preventable, and thank you very much for patient hearing. I don't think there are any questions. Everybody is agreeing on delivering all small babies in time. Thank you.
Thank you very much for a very deliberate lecture and very, very practical. Everybody amongst us come with such a situation when to deliver. I think your lecture is going to guide us for managing such cases. Thank you very much, madam.
Now we shall have a very interesting and most awaited event of the day, debate. Debate is always enjoyed by both the audience as well as the speakers. So I request Dr. Kumtekar sir to join our chairpersons as a judge for debate.
Let us start the fight amongst ourselves. And the first debate will be on micronized progesterone and dydrogesterone. And I call the panelist, opponent parties, one Manikurram. Yes. Manik, you will be talking on micronized progesterone. Dydrogesterone. You will be talking on dydrogesterone. Manik is from our own society, doesn't need any instruction. He is one of the most dynamic member of our society. I am not going into his credentials, it consumes unnecessary times. You can see them on the screen. But Manik is a very versatile personality with his tentacles spread in all fields of management, administration, clinics, clinical, operative and everything. And today he is here to debate, participate in the debate on dydrogesterone versus micronized progesterone, and we will be talking on dydrogesterone. Mani, please start your side of story.
Thank you, Girish. मला वाटतं डिबेट सुरू करताना गिरीशला तिथं बसवलं एकमेकाशी लढवायला काय संत. And the other thing is he backed up because initially he was the person who was starting the debate. Okay. So सकाळपासून since morning we have learned so many things about the recurrent pregnancy loss, but whenever there is a recurrent pregnancy loss, this is the scenario from any कुठल्याही धर्माचा असो and काहीही करायला तयार असतात. There are different ways of blessings they are taking, and the main thing that needed is from this we have to go up to that level, and for that I am here debating for dihydrogesterone. So regarding the etiology we have seen since morning, but the thing is 40 to 50% is unexplained causes, and in these cases there are a lot of things which I have given, that is progesterone. The treatment options in recurrent miscarriages, here comes the progesterone. So which progesterone one should give? ISCHR recommends these various things, recognition of the patient as an individual, time of questions, good listening, tender loving care, but nowhere it is given, progesterone should be given. Even in FOXY recommendation, no intervention other than tender loving care. But still, there are so many preparations of progesterone in the market, and that's why we should know which should be given. So adding progesterone in a pregnancy, I feel like this, water everywhere. Still, 1 drop of water is required for that thirsty person. And which drop we should give? Yes, it's me at Andaman Nicobar. So choosing the right progesterone for management of miscarriage, what does the actual evidence say? Progesterone deficiency and recurrent miscarriages, in luteal phase defect, definitely it is needed. It is seen that several studies reported lower than the normal serum progesterone, and there are chances of recurrent pregnancy loss. So finding from a study supported the existence of the condition of luteal phase defect as an entity that is clinical significant, and here requires the progesterone. So I will not go through the detail, but the effect of progesterone on in recurrent pregnancy loss when you give. Most important thing is there is a immunomodulation. And now comes the why we should give the dihydroprogesterone. The formulation, and there are various routes of administration. One is injectable, the other is vaginal, and the third is oral progesterone. So oral administration is the easiest route of administration and generally the most acceptable route for the patient. Patients prefer oral administration over injectable or vaginal route. In the morning, Dr. Dabde told he did not want to do the transvaginal examination in a recurrent pregnancy loss in an early pregnancy and do a transperineal sonography. So we doctors are so much unsecure, then that patient will be also having the same feeling. She will not use the vaginal progesterone. So the oral progesterone, one is oral micronized progesterone and the other is the dihydrogesterone. So we will see what are the various things. So there are multiple formulations of oral progesterone. Patient convenience and compliance offered by the oral route has encouraged the manufacturers in India to come up with multiple formulation. And one such formulation is oral micronized progesterone. But what is the reality? Oral microprogesterone, look at this. This is not approved in pregnancy indication. There are not so much trials. And is it available globally? No. It is available only in India. Oral dihydrogesterone, backed by the evidence, available in approximately 100 countries across the world. Almost 1600 trials and approved in threatened and recurrent miscarriages and other progesterone deficiencies. Oral micronized progesterone, what does the evidence say? Poor bioavailability, higher doses are required. Adverse effect, when you give higher doses, high dose increases the risk of intrahepatic cholestasis and associated with drowsiness to marked sleepiness. Then what about the dihydrogesterone? It is a better option. It is having a greater availability, effective at lower dose. The dose is 10 to 20 times lower than the micronized progesterone and negligible adverse effects. Then oral micronized progesterone, the metabolite interfere with pregnancy outcome. There is a lower implantation rate and detrimental effect on the metabolites. Yes, in a nutshell, the dihydrogesterone and oral micronized progesterone. It is seen that definitely the dihydrogesterone having a greater role in recurrent pregnancy loss than the oral micronized progesterone. So benefits of oral dihydrogesterone in recurrent pregnancy loss. Dihydrogesterone has a good safety and tolerability profile. It is structurally and pharmacologically similar to natural progesterone, has good oral availability and few side effects. Dihydrogesterone has no androgenic effects on the fetus and does not inhibit the formation of progesterone in the placenta. Oral dydrogesterone is an effective as vaginal progesterone capsule for luteal phase supplementation in ART cycles. Oral dydrogesterone might be a good option in clinical practice since oral administration is more patient friendly than the vaginal route. Oral dydrogesterone is associated with improved clinical pregnancy rate when compared with vaginal progesterone capsules and does not affect the ongoing pregnancy rate. So dydrogesterone in the reduction of recurrent pregnancy, you can see here dydrogesterone used HCG and the control group. Definitely the miscarriage rate percentage rate is less in the dydrogesterone. Significant miscarriage with use of progesterone, it is already there, but global guideline recommendation favor dydrogesterone in RPL. European Progesterone Club guidelines for women who are presenting with clinical diagnosis of recurrent miscarriage 3 or more, there is a reduction in the rate of miscarriage with the use of dydrogesterone. Foxy position statement on the use of progesterone. Dydrogesterone should be used. Escher guidelines, vaginal progesterone during early pregnancy has no beneficial effect in the woman with unexplained RPL. There is some evidence that oral dydrogesterone initiated when the fetal heart action can be confirmed, may be effective. So, this is the thing. And other thing is, whenever a micronized progesterone is come in the market, lot of people are bringing the generic products. So duplication is very easy with micronized progesterone, but with dihydrogesterone, attempts to make generic dihydrogesterone, it is difficult, and that's why this molecule should be used. So the take-home message is the use of dihydrogesterone 40 mg stat followed by 10 mg BID has been shown to reduce the incidence of pregnancy loss in a threatened abortion. So, the last two slides, we are having a micronized progesterone and we are having a dihydrogesterone. The thing is, why to choose this type of, just there is a simple way, oral way, no direct transvaginal ultrasonography. This is the morning picture. This is from the horse's mouth. So, use dihydrogesterone. And the another thing is, Mala Aloras in the morning, she told dihydrogesterone was associated with a decrease in the miscarriage. Natural micronized progesterone is not used up for the recurrent pregnancy loss. So, I am not saying, these stalwarts, they are saying to use the dihydrogesterone. So, this simple, a small drop, this may be drop, but this drop is a complete ocean for that patient. Thank you.
That was a good beginning, Manik. And there is another point of view from Dr. Sudesh Doshi. I will call upon him. And if Sudesh really contradicts you a lot, I will give you a chance for rebuttal, but I don't think it will be necessary. Let me introduce Dr. Sudesh Doshi. He is from Pandharpur, working in a now urban semi-rural area, previously rural area for 25 years now. I have seen his obstetric work, he is phenomenal obstetrician, and he belongs to my own creed, that is he is also a medical legal consultant, and now he is giving medical legal lectures, and I am happy to see him talking on a clinical topic today. So Sudesh, go ahead and contradict your opponent.
Namaskar. आदरणीय माणिक गुरम सर, आपण जे काही मुद्दे मांडलेत त्याच्यामध्ये बऱ्याच त्रुटी आहेत. सगळ्यात पहिली गोष्ट, तुम्ही आजचा जो आपला वादविवाद होता त्याचं टायटलच नीट वाचलेलं नाही आहे. त्याचं टायटल डायड्रोजेस्ट्रॉन वर्सेस ओरल नॅचरल मायक्रोनाइज प्रोजेस्ट्रॉन असं नसून डायड्रोजेस्ट्रॉन वर्सेस नॅचरल मायक्रोनाइज प्रोजेस्ट्रॉन असं आहे. त्यामुळे वजायनल रूट अलाउड आहे. ओरलविषयी मी बोलणारच नाही आहे. तुम्ही स्वतः वजायनल सर्जन सोसायटी ऑफ इंडियाचे एवढे मोठे मेंबर आहात. एव्हरीवन, ॲटलिस्ट ऑल मेल्स आर फॅसिनेटेड ऑफ वजायना फॉर सर्जरी ऑब्वियसली. मग इथंच अडचण का? काहीच कारण नाही. दुसरी गोष्ट, तुमचा अतिशय आदर राखून मी सांगू इच्छितो की तुम्ही डायड्रोजेस्ट्रॉनचा उल्लेख डिहायड्रोजेस्ट्रॉन असं करत होता, तो चुकीचा आहे. डायड्रोजेस्ट्रॉन हा उल्लेख बरोबर आहे. तर ह्या 2-3 गोष्टी आत्ता तुमच्या मुद्द्यांविषयी. पुढचं तर माझा पक्ष मांडायचा की दोन गोष्टी कम्पेअर करत असताना एखादा ड्रग ज्यावेळेस आपण कम्पेअर करतो, आता मी काय MDचा विद्यार्थी नव्हतो, मी DGOचा विद्यार्थी होतो, म्हणून मी काय थिसिस तयार केला नाही, तरी पण थोडंफार रिसर्चबद्दल जे काय माहिती आहे सर्वसामान्य ज्ञानाप्रमाणे दोन ड्रग्स कम्पेअर करताना आपल्याला या गोष्टी बघायच्या आहेत. मगाशी आपण पाहिलं सकाळी मला अरोरा मॅडमने सांगितलं, दबडे सरांनी पण सांगितलं की डायड्रोजेस्ट्रॉन, आणि तुम्ही पण सांगितलं की डायड्रोजेस्ट्रॉन असो अथवा नॅचरल मायक्रोनाइज प्रोजेस्ट्रॉन असो, हे दोन्हीही रामदेव बाबाच्या आशीर्वादांसारखं आहे. बऱ्याच लोकांनी सांगितलं की रिपीटेड प्रेग्नन्सी लॉसमध्ये नॅचरल मायक्रोनाइज प्रोजेस्ट्रॉनचा उपयोग होत नाही आणि डायड्रोजेस्ट्रॉनचा उपयोग होऊ शकतो. सगळे हे दोन्ही रामदेव बाबाच्या आशीर्वादांसारखंच आहे. मग फक्त आशीर्वादच घ्यायचा आहे तर मग तो कमी पैशात जवळ स्वस्त मिळत असेल तर तो घेतलेला जास्त चांगला. सो दीज ड्रग्स बोथ वजाइनल प्रोजेस्ट्रॉन अँड डायड्रोजेस्ट्रॉन बोथ आर नॉट व्हेरी इफिशियंट, तरी पण आपण सगळे वापरतो. जसं आपल्या पेशंटला सांगितलं तरीसुद्धा ते नवस बोलतात. आपली ट्रीटमेंट चालू असते इन्फर्टिलिटीची आणि त्याच्यावर मग दबडे सरांचा आशीर्वाद, दबडे मॅडमचा आशीर्वाद, सगळ्यांनी मिळून मग त्याला बाळ होतं. तर तो आशीर्वाद आपल्याला द्यायचा. मग तो जवळ आणि चांगला उपलब्ध असेल तर तो घेतलेला चांगला. सो टू ड्रग्स वुड बी कम्पेअर्ड अकॉर्डिंग टू देअर इफिकसी, adverse reactions, availability, acceptability, cost to the patient and profit for the pharma and doctors. हा शेवटचा मुद्दा कदाचित लोकांना वाईट वाटेल, पण कालच सुप्रीम कोर्टाने निर्णय दिलेला आहे की डॉक्टर्स हे कन्झ्युमर प्रोटेक्शन ॲक्ट खाली येतात. मग पेशंट आपल्याकडे कन्झ्युमर म्हणून येतो तर आपण त्याशी व्यापारी म्हणून बघितलेलं काहीच चुकीचं नाही असं मला वाटतं. त्यातनं पैसे मिळवणं अजिबात चुकीचं नाही आहे. डॉक्टरने पैसे मिळवणं हा गुन्हा नाही आहे. आपली मानसिकता बदलली पाहिजे. आपण पेशंटला लुटायचं नाही आहे, पण त्याच्यातनं नफा जर योग्य मिळत असेल तर घ्यायला काहीच हरकत नाही. तर पहिला मुद्दा इफिकसीविषयी सरांनी सांगितलं की डायड्रोजेस्ट्रॉन, नॅचरल मायक्रोनाइज प्रोजेस्ट्रॉन, आपला टॉपिक फक्त रिपीटेड प्रेग्नन्सी लॉससाठी आहे, बाकीसाठी नाही, IUGRसाठी नाही आहे. तर बोथ आर इक्वली इनइफिशियंट असं मगाशी सरांनी पण दाखवलेलं आहे. सो कम्पॅरेटिव्ह स्टडी या लोकांच्या तर बरेच सरांनी रेफरन्सेस केले ते, मला फारसे रेफरन्स जर्नल वाचायची सवय नाही आहे. तर आता बोथ आर इक्वल. मग ॲडव्हान्टेजेस काय काय आहेत? आता ॲडवर्स रिॲक्शन्स. आता हा पेपर आहे, इन कम्पॅरिझन विथ नॅचरल मायक्रोनाइज प्रोजेस्ट्रॉन डायड्रोजेस्ट्रॉन वॉज फाउंड टू कॉज सिग्निफिकंटली फ्युअर केसेस ऑफ ड्राउझिनेस. मग नॅचरल मायक्रोनाइज प्रोजेस्ट्रॉनमध्ये त्या पेशंटला थोडासा ड्राउझिनेस असेल तर अशी ती बाई पेकाळलेली असते, तिला तेवढी झोप आली, झोप मिळाली तर बरं वाटेल. तिच्या सासूला सांगता येईल ह्या औषधामुळे झोप येते बाबा, ती झोपली तर तुझ्या पोटात दुखायला नको, ती झोपली तर तिच्या बाळाला चांगली वाढ होईल, त्यामुळे ती झोप आली तर त्या पेशंटसाठी फायदेशीर आहे. दुसरी गोष्ट, सो पेशंट्स विल गेट मोर रेस्ट, रिलेटिव्स अँड इन-लॉज कॅन बी एक्सप्लेन द इम्पॉर्टन्स ऑफ रेस्ट अँड दॅट विल हेल्प इन मेंटेनिंग द प्रेग्नन्सी. आता वजाइनल ॲडमिनिस्ट्रेशन, ॲक्सेप्टन्स अँड कंप्लायन्स. मान्य आहे वजाइनल इन्सर्शन पेशंटसाठी थोडंसं डिफिकल्ट असतं, पण एखादी अवघड गोष्ट असेल तर ती माणूस आठवणीने करतो. ओरल गोळी, आता मी नुकतंच मागच्या 2-3 महिन्याखाली BP तपासलं, हायपरटेन्शन सुरू झालं, 50 संपली, 51 लागलं, तर अजूनही मी ती गोळी खायची विसरतो. ज्यावेळेस बायकोसमोर आणून देते त्याच वेळेस ती गोळी खातो. पण हे जर वजाइनल ॲडमिनिस्ट्रेशन असतं तर नक्की आठवणीने ते केलं असतं. त्यामुळे वजाइनल ॲडमिनिस्ट्रेशन पेशंट लक्षात ठेवून करतो. जरी ॲक्सेप्टन्स कमी असला तर ते केलं पाहिजे. ते रोज करत नाही आपण, त्यामुळे ते आठवणीने केलं जातं. जे रोज करतो ते रोजची गोष्ट विसरून जातो. So patient is more likely to comply with vaginal administration than oral administration. So I go for vaginal route. Availability. Costlier drugs are less available. सर मगाशी म्हणाले की डायड्रोजेस्ट्रॉन प्रिपेअर करणं अवघड आहे, त्यामुळे डुप्लिकेशन होत नाही. अगदी मान्य आहे सर. त्यामुळे डायड्रोजेस्ट्रॉन खूप कमी अवेलेबल आहे. आपण बघतो की 1970 सालापासून का 80 सालापासून डायड्रोजेस्ट्रॉन मार्केटमध्ये, पण भारतात आत्ताशी आलं. जर अवेलेबल असेल तर वापरणार, अवेलेबल असेल तर वापरून उपयोगच होत नाही. त्यामुळे त्याच्या विरुद्ध नॅचरल मायक्रोनाइज प्रोजेस्ट्रॉन वजाइनल टॅब्लेट्स रेडीली अवेलेबल आहेत. 100 फार्मा कंपनी आहेत ज्या मिळतात. मार्केटमध्ये कॉम्पिटिशन आलं की क्वालिटी वाढते, प्राइजेस पण कमी येतात आणि त्याचा फायदा अल्टिमेटली ग्राहकाला होतो. जर आपण बघतो लेस दॅन 10 कंपनीज आर कमिंग विथ डायड्रोजेस्ट्रॉन, देयर आर ॲटलीस्ट 15 कंपनीज विथ नॅचरल मायक्रोनाइज प्रोजेस्ट्रॉन. सो डिमांड सप्लाय कॉस्ट इक्वेशन ऑफ इकॉनॉमिक्स. डिमांड आहे, सप्लाय भरपूर आहे, आपोआप त्याची किंमत कमी येणार आहे आणि जास्त ऑफर्स मिळणार आहेत. कॉस्ट टू द पेशंट. आता आपण जर कॉस्टचा विचार केला तर प्रोजेस्ट्रॉन हे नेहमीच महाग आलेले आहेत. अगदी 1960 साली हायड्रॉक्सीप्रोजेस्ट्रॉन कॅप्रोट आलं, त्यावेळेस त्यांनी वंडर ड्रग म्हणून मार्केट केलं होतं. त्यानंतर मध्यंतरी काही दिवस आय थिंक इट वॉज ॲलेस्टेरॉल विच वॉज सपोज टू बी मॅजिक पिल, ते नंतर गेले निघून. मग जसं प्रोजेस्ट्रॉन जुनं होतं तसं ते स्वस्त होतं आणि नवीन आलेलं प्रोजेस्ट्रॉन हे चांगलं असतंच असं नाही, हे आपण गेल्या 50 वर्षाच्या अनुभवातून शिकलो आहे. की सरांनी आज सांगितलं की इंजेक्टेबल हायड्रॉक्सी प्रोजेस्ट्रॉन कॅप्रोएट अजूनही चांगलं आहे. त्यानंतर कमीत कमी 10 प्रकारचे प्रोजेस्ट्रॉन आले, जेल आलं, काय आलं तरी इंजेक्टेबल प्रोजेस्ट्रॉन अजूनही वापरलं जाते. त्यामुळे नवीन आलं म्हणजे ते चांगलं असेलच असं नाही. फार्मा कंपनीज त्यांचे रिव्ह्यूज, त्यांचे स्टडीज कसे मॅन्युप्युलेट करतात आपल्या सगळ्यांना माहिती. बाजारात नवीन विकायचं म्हटल्यावर आपला तो बाळ्यान दुसऱ्याचं तर कार्ट असतं. तशा पद्धतीने कॉस्ट जर बघायला गेलं तर डायड्रोजेस्ट्रॉनची कॉस्ट आज जवळजवळ 70, 80, 90 रुपये. एका दिवसात 30 मिलीग्राम 40 मिलीग्राम दिलं तर जवळजवळ 180 रुपये पर डे एवढी कॉस्ट असते. आपण थोड्याशा ॲफ्लुएंट सोसायटीमध्ये आहोत तरीसुद्धा रोज 180 रुपये औषधाला खर्च येणं जरा थोडं जडत जातं. तर दिवसभरात नॅचरल मायक्रोनाइट प्रोजेस्ट्रॉन वापरलं तर 40 रुपयात साधारणपणे मिळून जातं. तर एका दिवसासाठी 40 रुपयाचा फरक पडला तर एका महिन्यात साधारण 4,200 रुपयाचा फरक पडेल. 3 महिने द्यावं लागते 12,600 रुपये. हे खूप मोठी गोष्ट आहे. अगदी माझी बायको जरी डीमार्टमध्ये गेली तरी याच्यामध्ये तिला बऱ्याच कितीतरी गोष्टी मिळतील. 2-3 महिने तिचं सामान घेऊन होईल तर ती तिकडेच गेली आहे. सो दुसरी गोष्ट, इफ यू प्रिस्क्राईब कॉस्टली मेडिसिन्स, पेशंट्स आर लायकली टू चेंज द डॉक्टर और पेशंट्स आर लायकली नॉट टू गो फॉर ट्रीटमेंट. So if you don't want to lose the patient, prescribe cheaper medicines. You will, the patient will stick to you, and patient will definitely get benefits from you. You being champion doctors, if the patient sticks to you, patient will definitely be benefited. Profit in prescribing. Natural micronized progesterone is more profitable than dydrogesterone to doctors and pharma retailers. We are generally not directly related to the pharma company, but we ourselves as the medical stores nearby, जनरली ते आपल्या मेहण्याचं दुकान असतं किंवा भावाचं असतं. सो वी आर अ फॅमिली मेंबर. मग त्याला जर 4 पैसे जास्त मिळत असतील औषध कंपनीपेक्षा तर ते निश्चित स्वागतार्ह आहे. ते काय पेशंटला फुकट जाणार नाही आहे, पेशंटला तेवढेच पैसे द्यावे लागणार. मग त्यातला जर जास्त हिस्सा मला किंवा माझ्या भावाला मिळत असेल औषध दुकानदाराला तर काहीच हरकत नाही. त्यात वाईट काय, इट इज नॉट अनइथिकल और इट इज नॉट इमॉरल. पैसे तर पेशंटचे जाणार आहेत. मग ते कंपनीच्या खिशात गेले म्हणजे मॉरल आहे आणि माझ्या खिशात गेले म्हणजे इमॉरल आहे, असं अजिबात नाही. So at present, very few pharma companies in the market are in competition for dydrogesterone, and it is more profit to the pharmaceutical company. But almost all pharma companies are offering you 1+1, 1+2 or 50% scheme for natural micronized progesterone. This is a fact. A natural micronized progesterone which strip costs 300 rupees, तुम्ही जर त्याच्याशी मागामागी केली तर तो तुम्हाला 90 रुपयाला सुद्धा स्ट्रिप देतो. ना हा प्रॉफिट तुम्ही तुमच्याकडे घ्यायचा, दुकानदाराकडे ठेवायचा, आणि इफ यू आर बेनेवलंट, तुम्ही जर अगदी उपकारक वृत्तीचे असताल तर तुम्ही पेशंटला डिस्पेन्ससुद्धा करू शकता कमी पैशात, काहीच हरकत नाही. तुमच्याकडे पैसे भरपूर झाले असतील, आता पैसे कमवायची इच्छा मरून गेली असेल तर पेशंटला तो फायदा द्या. फार्मास्युटिकल कंपनीकडे देण्यापेक्षा नक्की पेशंटला स्वस्त मिळेल. देर इज नो स्कीम फॉर डायड्रोजेस्ट्रॉन. आत्ताशी 3-4 कंपनी आल्यात, अजून एक 5 वर्षात डायड्रोजेस्ट्रॉनला कुठलीही स्कीम येणार नाही. सो यू कॅन आयदर रिटेन दॅट प्रॉफिट और पास इन डायरेक्टली टू द पेशंट. तर मग या सगळ्या मुद्द्यांचा विचार केला. एफिशियन्सी दोघांची सारखीच आहे. ॲक्सेप्टेबिलिटी नॅचरल मायक्रोनाइज प्रोजेस्ट्रॉनची जास्त आहे कारण वजनल डोसेस आर लेस लाईकली टू बी मिस्ड. ॲडवर्स रिॲक्शन नॅचरल मायक्रोनाइज प्रोजेस्ट्रॉनची झोपेची आहे, ती आपल्यासाठी फायद्याची आहे. कॉस्ट नॅचरल मायक्रोनाइज प्रोजेस्ट्रॉनची चीप आहे आणि प्रॉफिटेबिलिटी नॅचरल मायक्रोनाइज प्रोजेस्ट्रॉनची आपल्यासाठी, आपल्या शेजारी दुकानदारासाठी जास्त आहे, औषध कंपनीसाठी कमी. त्याची काळजी आपण करायचं काम नाही. सो आय स्ट्रॉंगली रेकमेंड नॅचरल मायक्रोनाइज प्रोजेस्ट्रॉन वजानली फॉर ऑल दिस पॉईंट्स. थँक्यू.
Yes, I think after the very humorous pro side of natural micronized progesterone by Dr. Sudesh, I think Manik deserves a 1-minute rebuttal. 1-minute rebuttal.
सगळ्यात पहिल्यांदा सुदेश, मी तुला पहिल्यांदा एक सांगतो की तू थोडंसं डिबेट करायला बंद कर, त्यामुळे तुझं BP वाढलंय. कारण अलीकडे फार वेळेला डिबेट म्हटलं की सुदेश जोशीचं नाव येतं. मला वाटतं ते एक कारण असेल. बाकी माझी अवस्था अशी झाली आहे की या टीममधला मेंबर आहे आणि ऐन वेळेला त्याला उचलून त्या टीममध्ये घालून याच्याविरुद्ध खेळा म्हणाले की काय होतं, तशी परिस्थिती होती माझी. कारण आता आहे का कोणी स्पेक्ट्राचा? नाही ना, ठीक आहे. मला काल स्पेक्ट्राचा MR माझ्याकडे आला होता. सर तुम्ही असं असं बोलणार आहे म्हणे उद्या. हो म्हटलं मी डायड्रोजेस्ट्रॉन बोलणार आहे. हो सर तुम्ही तर सस्टेन लिहिता, मग कसं काय बोलणार म्हटलं. मी म्हटलं मला माहीत नाही, म्हटलं मला टॉपिक दिलं मी बोलणार आहे. तर whatever it may be, I agree with you on some points. Definitely प्रोजेस्ट्रॉन ज्या वेळेला आहे ते द्यायला पाहिजे आणि पेशंट्स बघून अगदी शक्य असेल ह्या गोष्टी चांगल्या असतील तर पैशाचा विचार न करता त्या पेशंटला परवडत असेल तर द्यायला पाहिजे. अदरवाईज काही नाही देत असेल तर जे शक्य आहे कमी पैशाचं आहे ते द्यायला पाहिजे. एवढं याबद्दल मी ॲग्री, नथिंग एल्स.
Thank you, Manik, for the small rebuttal. Well, friends, the debate is over. Now we have to come to some conclusion. If you see the positive side of both the debaters, both the who argued against one another, if you see the positive or the silver lining of the debate, progesterone is a wonder drug. Either it is dydrogesterone or it is a micronized progesterone, appears to be a wonder drug. But if you look at the evidence and what today from morning we have learned, we can see that it's a useless drug. Not useless, but it has a very limited, very limited application. Now, dear friends, the take-home message from this, and since Sudesh brought in a commercial point of view of this drug, unfortunately, this is my personal opinion, and it may not be binding upon it, it might hurt somebody. But what comes out of this debate is that both, whether you can use it or not, it doesn't make a difference. But today, these days, when I see prescriptions for primary gravida with both dydrogesterone BD and micronized progesterone 300 mg TID, I really felt ashamed of our field. When the drug is not indicated and when it is indicated only in cases of RPL, why the drug is being prescribed like chana putana to primary gravidas? That's what really puzzles me. So dear friends, the message from this will be you use it judiciously. It's an expensive drug. If the patient has to spend 12,000 rupees per month for a drug, she can better have a better diet, better lifestyle, and go ahead with the pregnancy in a better fashion, in a relaxed mind, rather than spending so much on drugs. And believe me, when you prescribe the drugs like chana putana, there are followers outside who are general practitioners who say this and this famous personality is prescribing this drug, why not me? And of course he gets incentives for that. So the blatant misuse of progesterone should be stopped. It should be judiciously used. What we are learning today is a judicious use of progesterone, whether it be dydrogesterone or micronized. Both have their benefits, they both have their disadvantages. The thing is, the take-home message should be, the drug should be used judiciously. That's it. Thank you.
We move on to the next debate. I invite Dr. Pratibha Baldava to speak on injectable HCG. This slide आहे, introduce करायचं. Dr. Pratibha Baldava, she is a gold medalist. She has fellowship in infertility, a laparoscopic surgeon. She has been trained in high-risk pregnancy, and she is a fellow of American College of Obstetrics and Gynecology.
A very good evening to one and all. Since morning we have been listening about progesterone. Enough is enough. Now I bring something new to you. The role of injection HCG in RPL. Back. Yeah. Use of HCG in RPL. Warning. This is for Dr. Manisha Patil. Can I see you, ma'am? Yes. My worthy opponent, all comments, statements and remarks made here are for the debate purpose only and should not be taken personally. But at the same time, they should be considered seriously and later on accepted by you and respective amendments made in your treatment protocol. It's child play to understand the efficacy of injection HCG in RPL because let me go to the production of HCG. HCG is produced by a cytotrophoblast and syncytotrophoblast. It has two subunits, an alpha subunit and a beta subunit. The structure and the pathophysiology of HCG is such that the alpha subunit is common with LH, FSH and TSH and it is a building block, whereas the beta subunit is responsible for its stability and rapid secretion. Structurally, though HCG is similar to LH, They bind to the same receptor, and though the half-life of LH is just 25 to 30 minutes, the half-life of HCG is 37 hours. This HCG is long-acting when we compare it to LH. I'm just putting an insight into you. Just let us look at the levels of HCG throughout pregnancy. We never go to see this. Can you see that levels of HCG are rapidly increasing throughout pregnancy? When we see at around 24 to 25 weeks, the levels are as high as 1,65,400, and in the third trimester also, the levels go as high as 1,17,000. So thus, it clearly indicates that HCG is secreted throughout the pregnancy, and therefore HCG is the hormone for pregnancy maintenance. HCG has numerous functions. HCG promotes progesterone production by the corpus luteal cells. So HCG is like father to the progesterone. So I would not be wrong if I say, रिश्ते में तो हम तुम्हारे बाप लगते हैं, पर नाम है HCG. So biological functions of HCG. There are HCG receptors which have been found in the sperm and also on the fallopian tube. Therefore, HCG is actually acting even before the pregnancy is conceived. So probably LH acts on this receptor in the pre-implantation phase and relaxes the tube for fertilization to occur. Thus, HCG has a direct role in cytotrophoblast melanoproteinase production, and therefore it favors implantation. This is a very busy slide and an important paper which shows the different biological functions of HCG and HCG-related molecules. I will just simplify it for you. Madam, the next slide summarizes all the benefits of HCG which progesterone does not, and thus will put an end to this debate. So it will be better if you don't even present your side. Just look at this. What are the causes of RPL? All of us since morning are saying it is luteal phase defects or implantation failure. Just as I said, HCG, it promotes the corpus luteal cells, it helps it in production of progesterone. So it takes care of this luteal phase defects. The other cause for RPL is implantation failures. HCG causes growth and differentiation of the umbilical cord. It signals the endometrium about forthcoming implantation and therefore seemingly promotes growth of the fetal organs during pregnancy, and therefore it helps implantation. It is acting at the pre-implantation phase and is helping implantation. The other cause for RPL is immunological and autoimmune disorders. HCG, by causing blockage of any immune or macrophage action by the mother on foreign invading placental cells, it helps the uterine growth parallel to the fetal growth, and therefore it prevents these immunological and autoimmune disorders which are causing RPL. Also, RPL is sometimes caused because of anatomic uterine abnormalities, which might cause uterine contractions and therefore lead to inevitable abortions. HCG maintains uterine quiescence. It suppresses any myometrial contractions during the course of pregnancy and therefore maintains uterine quiescence and prevents these inevitable abortions. Also, we know that HCG promotes angiogenesis in the uterine vasculature, and it promotes the fusion of cytotrophoblast cells and differentiation to make syncytrophoblast cells, and therefore helps in maintenance, implantation and maintenance of pregnancy. This is a gist showing that HCG acts at all levels. Just as I said, it acts at the fallopian tube, relaxes the fallopian tube, helps, it is also present on the sperm receptors, helps ovulation, helps fertilization, and further helps during implantation, also increases vasculogenesis in the uterine musculature and helps placentation. So it is something which is acting at all levels. So it is an all-rounder. So it is acting at corpus luteal cells, and it causes induction of progesterone production, it acts at myometrial smooth muscle cells, and it promotes myometrial quiescence, it acts on the endothelial cells, and it causes induction of uterine or placental angiogenesis, it acts on decidual cells, and it inhibits tissue inhibitor or metalloproteinases, and it prevents autocrine signaling and therefore helps implantation. This is again a very important paper by Morley from Cochrane Database Systemic Review. He studied whether HCG is vital for maintaining the corpus luteum, but has additional roles during implantation which will support its use as a therapeutic agent for RM. His conclusion was that the evidence supports that HCG supplementation to prevent recurrent miscarriages is high. A well-designed randomized controlled trial of adequate power and methodological quality is required to determine whether it is recombinant HCG or urinary HCG which is useful. But he definitely proved that HCG is useful, but you need additional studies to know whether it is the recombinant one or the urinary one which will be more beneficial. Again, H.J. Karp in 2010 did a review and meta-analysis which showed that a Cochrane Database Systematic Review indicated that HCG seems to prevent further miscarriages by an odds ratio of 0.26. Thus, madam, you are already standing on the wrong side of the debate. What your brain doesn't know, your eyes cannot see. HCG levels are very high during pregnancy. They peak up during the second trimester and slowly taper down during the third trimester, because of which when the labor starts, the baby delivers. Whereas it is the other way around for progesterone. Progesterone is low in the initial phases and later on picks up. It is HCG which is causing or increasing the production, which is initiating the increase in production of progesterone, and therefore HCG is the initiator. HCG comes before progesterone. HCG works on the placenta and the root trophoblast, and it helps in the development of umbilical cord and the establishment of fetal circulation. So it is involved in multiple steps of placentation as well as fetal development. Progesterone acts nowhere on the fetus. Progesterone has no role in fetal development, whereas HCG acts and helps fetal development as well. Also, it has been found that HCG, because it causes proper placental formation, proper cytotrophoblastic invasion, it prevents PIH or it prevents preeclampsia, whereas there is no such role found with progesterone. So this is what happens. It allows proper cytotrophoblastic invasion, and therefore the root cause of PIH or hypertensive disorders in pregnancy is also avoided. Thus we see the multiple roles of HCG at the level of myometrial smooth muscle cells, corpus luteal cells, endothelial cells, endometrium decidual cells, and acting at all levels throughout the pregnancy. Is injection progesterone pain-free? And is it comfortable to the patient, ma'am? What the eyes doesn't see and what the mind doesn't know doesn't exist. So that injection progesterone is pain-free it does not happen. It is very painful and uncomfortable to the patient. Whereas nowadays we know injection HCG 5000 is also available as a PFS or a pre-filled syringe, which is a very small needle and can be taken self-induction by the patient, and it is very easy to take. Whereas the dose is also once a week or maybe twice a week as needed by the patient. Definitely compliance is better when we compare it to progesterone vaginally in rural setting, and it is better than dihydrogesterone when compared with the cost factor. This solves all our queries and gives us the ideal choice of treatment in RPL. The stories that end badly are sad, but sadder are the ones that never began. So thus, HCG is useful in causing a secure beginning and then maintaining. So HCG is before progesterone. Thus, let us generate evidence, evaluate evidence, and apply it, and gift the RPL couples their bundle of joy. Thus, I would say HCG is superior to progesterone, and these were my slides to convey the same. Thank you.
Thank you, Pratibha. You have discussed at length about injectable HCG. Now I call upon Dr. Manisha Patil to speak on progesterone. She is a certified yoga teacher and a consultant at Shobha Nursing Home.
First of all, thank you President Dr. Jamma Madam and SOGS team for giving me this opportunity to present injection progesterone in RPL. ॲक्च्युली जेव्हा मगई मॅडमनी मला फोन केला या टॉपिकसाठी तेव्हा मी त्यांना पटकन हो म्हणाले, कारण एकतर त्यांना मी नाही म्हणू शकले नाही आणि दुसरं असं की माझा थिसिस टॉपिक होता इंजेक्शन प्रोजेस्टेरॉन इन थ्रेटन्ड ॲबॉर्शन. आता प्रतिभासारखी वॉर्निंग स्लाईड मी नाही PPTमध्ये टाकली, बट आय वूड लाईक टू से सेम वर्ड्स फॉर प्रतिभा. आणि प्रतिभाच्या शब्दात सांगायचं तर SCG जर बाप असेल तर प्रोजेस्टेरॉन आई आहे. So, to start with, injection progesterones are available in market since 1954. Even with advent of new modalities like SCG, vaginal or oral progestogens, still they have maintained their place in the treatment panel of recurrent pregnancy losses, especially in luteal phase defects, unexplained RPL, or immunological causes of RPL. They are also used in threatened abortion. They have proved their efficacy to decrease the risk of preterm labor in cases with previous history of preterm labor, short cervix, or after cervical encerclage, or in multiple pregnancies. Nowadays, they are widely used in ART cycles or post-IUI cycles as luteal phase support. For sake of convenience, I have divided the topic between two sections. First, roles of progesterone and SCG. So why progesterone is so important in pregnancy? It can be easily explained by this slide. As we can see here, luteal phase progesterone levels are 20 to 30 nanogram per ml. But at term, the progesterone levels are 100 to 200 nanogram per ml. In Pratibha's slide, we saw that though the SCG levels are high, but they are up to around 18 to 19 weeks. Beyond 18-19 weeks, they drop. And definition of RPL includes abortions up to 20 weeks. So we should take in consideration this point also. Low levels of progesterones have been seen significantly associated with pregnancy failure. And the levels need to be maintained throughout the pregnancy for good outcome. The predictor value for miscarriages is below 35 nanomole per liter up to 16 weeks of gestation. We all know that progesterone comes into play even before conception. With LS surge, there is luteinization of granulosa cells leading to synthesis of progesterone, and this luteal phase is very, very important for implantation. If there is luteal phase defect, that there is low progesterone, it leads to implantation failure, subsequently to subclinical abortions. So, there is role of progesterone in this luteal phase. The patients with LPD in RPL group, they are benefited most with injectable progesterones. So, cases which have chance of LPD like PCOS, obese patients, hyperstimulated patients like IVF or post-IVF patients, hypothyroidism, hyperprolactinemia, the patients where there are chances of LPD, injection progesterone works here. And there is no role of SCG here as it has not yet come into picture. SCG comes into picture post-implantation. It acts on corpus luteum, maintains it till 10 weeks of gestation, and after that placenta takes over function of synthesis of progesterone. आपण म्हणतो ना की जमिनीची मशागत जर चांगली केली गेली असेल तर मध्यम क्वालिटीचं बीज सुद्धा तग धरू शकते. Progesterone does the same action for endometrium. It prepares the endometrial soil for incoming embryo with variety of actions. Just to maintain the most important one, the important action is pre-decidual change. The crucial period for implantation is implantation window, and under the effect of progesterone, the surface epithelial cells of endometrium, they lose their microvilli and cilia, and they form the cells with smooth protrusions called as pinopods, and these are very essential for blastocyst implantation. Decidualization is also important for blastocyst implantation as well as nourishment, and thus it decreases the implantation failure or early pregnancy losses. Studies have been conducted to see the effect of injectable progesterone, progesterone with SCG and only SCG for luteal phase support, and it is seen that with only progesterone group, there is statistically increased implantation rate and decreased rate of miscarriages. While with progesterone plus SCG or with only SCG, there are chances of OHSS leading to increased estradiol, so luteolytic effect on corpus luteum, ultimately leading to decreased progesterone and failure. So, SCG should not be used in LPD support, especially in ART cycles. On myometrium, under the effect of progesterone, the decidual cell synthesis, decreases synthesis of PGF2 alpha, so decrease in myometrial contractility, and thus it reduces risk of miscarriages and preterm labors. Regarding immunomodulatory property of placenta progesterone, we all know about this, which is very, very important for successful implantation, which naturally reduces the risk for RPL. So, for maintenance of pregnancy, role of SCG is like supporting actor, needed up to 10 weeks of gestation, while role of progesterone is like actor in a lead role who carries the play on its shoulders and needed up to the end of the play. The second section regarding pharmacokinetics of the drugs. The market preparations available are hydroxyprogesterone caproate. As this progesterone is esterified, it is more potent than natural progesterone. Available as 250 or 500 mg per ml. Can be given weekly, bi-weekly or every 10 to 15 days, especially used in cases of threatened abortion, preterm labor, after encerclage or in multiple pregnancies. Second molecule is injection progesterone. 50 mg or 100 mg ampoules are there, can be given daily, alternate day or twice a week. This drug is commonly used in ART cycles after the day of womb pickup and continue till 12 to 14 weeks of gestation. This molecule has statistically proved its efficacy by increasing implantation rate, increasing clinical pregnancy rate, and decreasing miscarriages. Aqueous progesterones are also available as 25-50 mg. They are given subcutaneously, and they are used as 25 to 50 mg per day for luteal phase support post-ART or post-IUI. And unlike oil preparations of progesterone, ज्या एका पॉईंटवर मी प्रतिभा बरोबर ॲग्री करते, here subcutaneous are also available. Unlike oily preparations, this aqueous dose needs daily dose is required. Drug is metabolized in liver, excreted in feces and urine. Commonest side effect is injection site pain, swelling, tenderness, sometimes abscess can occur. As these are oil depots, should be given deep intramuscular gluteal region. Contraindications include previous or recent thromboembolism, liver dysfunction, cholestatic jaundice of pregnancy, and uncontrolled hypertension. So regarding the comparison of pharmacokinetics of both the drugs, bioavailability of both the drugs is 100%, but it is lesser in obese patients for SCG. Elimination half-life. There is large difference in elimination half-life. In progesterone group, with single dose of 500 mg progesterone, in singleton pregnancy it lasts for 15 days and in twin pregnancy for 10 days. Whereas with SCG it is about 70 hours. So needs to be given every 3 to 4 days. Drug can be stored at room temperature, ready-made solutions are available, while with SCG, it needs to be refrigerated and reconstituted, which is again cumbersome. And last but not the least, prices of the drugs. So in summary, progesterone plays crucial role in implantation and luteal phase. There is no role of SCG for luteal support, especially in ART cycles. Once implantation and luteal phase are proper, further journey is smooth with reduced chances of recurrent pregnancy losses naturally. Here, injection progesterone does have a role to play, especially in LPD patients. Definition of RPL includes abortions up to 20 weeks, and there is no role of SCG beyond 12 weeks, but injection progesterone does have. आणि जसं दोषी सर म्हणाले, सकाळी अजित पाटील सर म्हणाले की prices should be considered. So here, consider the price. These are few slides from my thesis. This is normal pregnancy vaginal smear showing good progesterone effect with abundant intermediate cells. Threatened abortion slide with poor progesterone effect with decreased number in intermediate cells. And this is after treatment with progesterone in threatened abortion, where we can see that intermediate cells have increased, showing good progesterone effect. So, this is our choice, whether to have direct effect of progesterone by giving direct injection progesterone or have indirect effect of progesterone by giving SCG. Ultimately, what we need is sustained levels of progesterone throughout the pregnancy, which will decrease the risk of recurrent pregnancy losses. So, in my opinion, both progesterone and SCG are important in the play of pregnancy. But in my opinion, best actor in supporting role should be given to injection SCG, and best actor in lead role should be given to injection progesterone. Thank you for your patient hearing.
Hello. Nice presentation by both the parties. Well, the arguments from both sides made us all to sit in time machine, go back to the physiology and pharmacology. Thanks for the revision of the pharmacology and physiology. But I don't know whether today's scientific committee missed the point and put this debate, because since all morning deliberations, none of the speaker, except for injectable micronized natural progesterone, none of the speaker has said about injectable progesterones and HCG. I wonder where the drugs have gone. So whether it was a debatable point or not, I am not sure. It is up to you to decide whether SCGs or injectable progesterones other than injectable micronized natural progesterone, which is to be used. But definitely progesterone has a direct progesterone has definitely upper hand in managing threatened abortions, premature, possible premature labor, or maybe RPL also. RPL, it has very small role, but it has definite role in threatened abortion and prevention of premature deliveries. So those who agree with HCG, please raise your hands. Those who agree with that progesterone wins, please raise your hands. With HCG, how many people are with HCG? Only Pratibha. Oh, because she has to. She has to.
With progesterone to initially get on.
So I will ask only one question here. You are going 5,000 units every week, or maybe 2,000 units bi-weekly. Now, if you do some mathematics, the maternal blood volume is nearly 5 liters, and 5,000 liters is 1 unit per ml of blood. How much HCG does it increase in the body? Can you really count? Hardly 100 milliunits international, which is not sufficient anyway. You have to raise it with thousands, so it will be helpful. So it's a homeopathic dose. I don't know whether homeopathy works or not.
We must congratulate all speakers with the very, very beautiful discussion, and congratulate all 4 of them. And I think everybody should take home the message, what they feel better to use this drug. Whether you use natural progesterone, use progesterone, whether you use SCG and all that. Because everybody is using all drugs. That is true. It's for a debate purpose we are giving this. Okay, thank you. Thank you. Thank you very much. Thank you, society, for giving us opportunity to chair this session. Thanks.
Thank you, ma'am. I request our chairpersons to felicitate Dr. Sucheta, ma'am. I request Dr. Jamma ma'am to felicitate our chairpersons, Zamre madam and Tirankar madam. I request Kumthekar sir to felicitate. Sorry. I request Kumthekar sir to felicitate Gurram sir, Sudesh Doshi sir, Dr. Pratibha Baldava and Dr. Manisha Patil ma'am. Today we have an interesting panel, that is the adverse perinatal outcome. For this I invite Dr. Sucheta ma'am for the panel. I think after her talk there is no any need for formal introduction of her. Welcome ma'am.
गुड इव्हनिंग. तुमच्या सोलापूर सोसायटीत फारच मजा आली. एक मी बघितलं तुमचा छान ग्रुप आहे छोटा, सगळेजण खूप एन्थुझियास्टिक आहेत, सगळ्यांकडे काहीतरी नवीन नवीन आयडियाज आहेत. म्हणजे एंटायर प्रोग्रॅममध्ये शिकायला टेक होम मेसेजेस पण भरपूर मिळाले आणि मजा आली एकंदरीत. सो लास्ट पॅनल डिस्कशन ॲक्च्युली हे मी सेल्फ इन्व्हाइट केल्यासारखं झालं. मी म्हटलं मॅडमना आपण असं नाही तर पॅनेल करूया. मग मॅडम म्हणाल्या मग तुम्ही टॉक पण करा आणि पॅनेल पण करा, सगळंच करा. सो मी म्हटलं काहीतरी आता आपण थोडंसं वेगळं आणि इंटरेस्टिंग करूया. सो लास्ट केस आपण लास्ट पॅनल डिस्कशन व्हॉट वी आर गोइंग टू डिस्कस इट जस्ट वन केस और मे बी सेकंड शॉर्ट केस विथ सम टेक होम मेसेजेस. आणि त्या केसमध्ये पेशंट काही आपलं टेक्स्टबुक वाचून येत नाहीत की आपण RPLची केस म्हणून जातो आहे. सो एव्हरी टाईम यू टेंड टू फेस अ न्यू चॅलेंज आणि हाऊ टू डील विथ some sudden intrauterine fetal demise or death, especially nearing term. So ते आपण बघूया. तर आपल्याकडे आहेत डॉक्टर अर्चना. आत्ता एक आपण अशी त्यांना क्लिनिकल सिच्युएशन देऊया की पेशंट रोज म्हणजे सांगितल्याप्रमाणे फॉलोअपला येत होती आणि मग 30 to 34 वीक्सला सडनली एका चेकअपनंतर कळलं की इट इज IUFD. सो फुल टर्म IUFDची पेशंट आहे. पेशंट कोण आहे आणि डॉक्टर कोण आहे सांगा.
डॉक्टर इज अर्चना, पेशंट इज निशा, पेशंट सासू प्राजक्ता, नर्स इज श्रुती अँड हजबंड इज सुदेश दोशी सर.
दोशी सर तुम्ही खूपच डिमांडमध्ये आज. म्हणून BP वाढत आहे. तुम्हाला आज फ्रीमध्ये डायग्नोसिस पण करून मिळाला. फ्रीमध्ये डायग्नोसिस पण करून मिळाला. BP का वाढत आहे. सो चला नेक्स्ट.
चला पेशंट कोण आहे सिस्टर. चला पुढचं पेशंट घ्या. या चला तुम्ही थांबून घ्या. बरं सिस्टर सोनोग्राफीला घ्या पेशंटला. हा याचा फॉर्म भरलेला मॅडम. सोनोग्राफीचा रिपोर्ट द्यायचा.
एवढे पैसे भरले तरी सगळ्यांना आत बोलत नाही, पेशंटला आत बोलत, आम्हाला बोलवायला काय होतं?
हो. बरं निशा, बरी आहेस तू?
हो मॅडम, बरी आहे.
बरं सिस्टर, तर निशासोबत कोण आहेत त्यांना बोलवा. बसा.
कसा आहे मॅडम रिपोर्ट?
मी आत्ताच तपासलं. रिपोर्ट फारसा काही बरा नाही आहे. बाळ गेलंय पोटात, मेलंय बाळ.
काय मॅडम, कळतंय का तुम्हाला काय बोलताय?
हो
मॅडम, कळतंय का तुम्हाला काय बोलताय ते?
दुसऱ्या पेशंटचं. हां अगं थांब जरा, 1-2 मिनटं फक्त. हां बाळ गेला आहे पोटात, मी आत्ताच सोनोग्राफी केली, मेलेलं आहे बाळ.
म्हणजे आता डिलिव्हरी होऊन आपल्याला बाळाच्या दवाखान्यात बाळ चांगलं होईल ना?
असं कसं? हां तुम्ही कधी मेलेला माणूस जिवंत झालेला पाहिला आहे का?
नाही, आपण आम्ही ते 9 महिने झाले एवढं दाखवतो तुमच्याकडं, एवढ्या लांबून तुमच्या गावातले साधे डॉक्टर सोडून मोठे डॉक्टर तुमच्याकडे आलो की आम्ही.
मान्य आहे मला, तुम्ही मोठे डॉक्टर म्हणून आले माझ्याकडे, पण आता मी काही करू शकत नाही. गेलंय बाळ पोटात, आता आपल्याला पुढे काय करायचं हे जास्ती महत्त्वाचं आहे.
नाही काही करू शकत नाही. मग 8 महिने 9 महिने काय केलं?
नाही तुम्ही म्हणतात ते बरोबर आहे, पण कसं आहे, हे बघ निशा, तू रडू नकोस आत्ता. बरं प्लीज तुम्ही हे करू नका.
अहो काय हो मॅडम, काय काय सांगताय तुम्ही?
बरं 1 मिनिट हा, थांबा, मला एक फोन आहे. हां नक्की.
आहो ती बायको रडते माझे, तुम्ही काहीतरी बाळ, ते फोन नंतर घ्या ना, ते काय महत्वाचं का?
1 मिनिट थांबा जरा.
अहो थांबा, तुमच्या तपासणीचे पैसे भरले, तुम्ही बोललं पाहिजे आमच्याशी.
1 मिनिट थांबा जरा, माझा फोन.
नाही मी शांतच आहे, पण आम्ही पैसे भरले दाखवू बाहेर काउंटरला, आधी आम्हाला अटेंड केलं पाहिजे. ते फोन त्यांना सांगा ना, ते काय काय बाहेर मग त्यांना बोलतील ना फोनवर. एवढं अर्जंट काय आहे त्याच्यात?
हो ते महत्वाचंच आहे. काय मी आता तुम्हाला
असं बोलू नका, हे पण महत्वाचं आहे माझ्या दृष्टीने. तुम्ही सांगता बाळ गेलं, ते फोन फेकून द्या, मी दुसरा फोन आणून देतो तुम्हाला, ते नंतर बोलतील की बाळ गेलं, ते महत्वाचं कसं?
बरं ऐकलं मी, कळलं मला, ठेवते मी फोन. पण आता आपल्याला पुढे काय करायचं ते बघावं लागेल. आता मी तुम्हाला सांगितलंय त्या पद्धतीने बाळ नाहीये पोटात, आता आपल्याला डिलिव्हरी करावी लागणार आहे. तुम्ही फक्त आता ॲडमिशनसाठी तयार व्हा. बाहेर तुमच्या कुठल्या नातेवाईकांना बोलवायचं असेल तर आता सांगा, आपण ॲडमिट करूया पेशंटला आणि डिलिव्हरीचा प्रयत्न करूया.
प्रयत्न करूया, मग ते तरी करणार का? ते पण नाही जमणार.
हॅलो अण्णा, अहो लवकर या की हो हॉस्पिटलला. ही बाई बघा काय सांगायला लागली आहे.
अहो ताई फोन ठेवा, तुमच्या सोबतचे मला फोन ठेवायला होते, तुम्ही काय फोनवर बोलताय? ठेवा फोन आधी.
अहो आमच्या दृष्टीने
कळवायला नको का? तुम्ही काय सांगताय काहीच कळेना आम्हाला. आम्ही गावाकडची लोक, आम्हाला कसं कळावं?
नाही मान्य आहे गावाकडची आहे, पण आता हे बघा मी सांगितलंय, मी तर सोनोग्राफी केली, त्याच्यावरूनच तुम्हाला सांगते की बाळ गेला आहे पोटामध्ये.
कशाने गेलं?
आता हे मला माहित राहिलं असतं तर मी आता सांगितलं असतं ना तुम्हाला.
मग तुम्ही आता नॉर्मल करणार का डिलिव्हरी?
हे बघा आपण प्रयत्न तर नॉर्मलचाच करणार, पण सिझरही होऊ शकता. नाही लागू शकतं, मला माहित नाही आता. कशी सांगणार?
मॅडम तुम्ही तुमच्या बोलण्याचा टोन बदला. आम्ही तुम्हाला पैसे दिलेत, तुमच्या सर्व्हिसेस घेतलेल्या आहेत, विकत घेतलेल्या आहेत. कोर्टाने कालच सांगितलंय कन्झ्युमर प्रोटेक्शन ॲक्टमध्ये तुम्ही येता, आम्ही तुमच्याकडनं काहीही फुकट घेतलेलं नाही. गावगुंडासारखं आमच्यावर दमदाटीची भाषा करू नका. एखादी गोष्ट झाली असेल तर
हो जरा तुम्ही ठरवा एकमेकांमध्ये आणि मग हे करा.
ठरवा एकमेकांमध्ये काय ठरवू नक्की? तुम्ही आम्हाला आता हे महत्वाचं आहे, तुम्ही जाऊ शकत नाही इथून, तुम्ही थांबलं पाहिजे इथं. काय झालं काय ते काय म्हणते बघा की, काय एवढं दाखवते 9 महिने, काय झोपा काढले काय? एवढं आपण कोर्टात केस करायची आत्ता. ते नगरसेवकाला बोलवू ना, आपले त्या भाऊंना बोलवू ना, दादांना बोलवू ना. असं कुठं असतं काय? 9 महिने दाखवले, एवढे पैसे घालवले आणि ते बाळ पोटात गेलं, असं जातच कसं? तुम्ही काय झोपा काढलं का?
बरं शेवटी सगळ्यात इन्फ्लुएन्शियल पर्सनचा माईक काढून घेणं हाच उपाय आहे.
बरं तुम्ही आता ठरवा आणि ऍडमिट व्हा, आपण पुढचं पुढे बोलूया.
आपण मग परत सोनोग्राफी करूया का?
काही गरज नाही त्याची.
कळत नसेल तर
नाही काही गरज नाहीये त्याची. मी केलेली आहे ऑलरेडी सोनोग्राफी. तुम्हाला परत परत करायची असेल तर
पण आम्हाला करून घ्यायची ना दुसऱ्या आमच्या डॉक्टरांकडून.
नाही, मी दाखवते तुम्हाला सोनोग्राफीचा रिपोर्ट, चांगली सही करून देते, फोटो देते, सगळं देते. आणि काय तुम्ही मला पोलिसांची धमकी देऊ नका.
पोलिसांची कुठं दिली आम्ही
मग आता मला पॉलिटिशियन, पोलीस सगळ्याच धमकी द्यायला लागलेले आहेत. मी सांगते तुम्हाला, ऐका माझं जरा. चला सिस्टर यांना ऍडमिट करा.
सो आता या प्रकरणावर सध्या आपण एक तात्पुरता पडदा पाडूया. जोरदार टाळ्या होऊन जाऊ द्यात आजच्या कलाकारांसाठी. काय मंडळी, हसताय ना? पण मुळीच हसायला नाही पाहिजे. हा सिरियस प्रसंग आहे आणि आत्तापर्यंत येत असलेल्या, आपल्याकडे तपासायला येत असलेल्या लॉयल पेशंटचं सडनली एका बॅड न्यूजमध्ये रूपांतर झालं, बॅड इव्हेंट किंवा इन्सिडेंटमध्ये रूपांतर झालं. आणि ह्याला तोंड कसं द्यायचं? जितकं पेशंटसाठी ही कसोटीची किंवा कठीण वेळ आहे, बिलीव्ह मी, तितकीच कठीण वेळ ही डॉक्टरांसाठी सुद्धा आहे. ही न्यूज कशी सांगायची? सो न्यूज सांगताना काही काही इम्पॉर्टंट गोष्टी असतात, जसं की आपलं सेटिंग कसं पाहिजे, आपण बोलताना प्रायव्हसी कशी मेंटेन केली पाहिजे, डिस्टर्बन्स अलाऊ नाही केला पाहिजे. सो ज्या पद्धतीने यांनी सांगितलं, आपल्याला आत्ता जरी मजा आली तरी तुमच्या एक लक्षात आलं असेल की एक गोष्ट किती वेगळ्या अंगावर गेली. ऑल टुगेदर म्हणजे पेशंट, पॉलिटिक्स, धमकी, आणि हे कुठेही डायरेक्शन जाऊ शकते. सो कसं असायला पाहिजे ब्रेकिंग बॅड न्यूज, बघूया आता. हेच सगळे डॉक्टर्स आणि हीच सगळी टीम कसं आपल्यासमोर प्रेझेंट करतायत. डॉक्टर या.
सिस्टर घेतलं झालं, निशाची सोनोग्राफी झाली ना, घे तिला, घे आतमध्ये घे. हां ठेवते. बरं, निशासोबत कोण कोण आहे सगळ्यांना बोलव. हां,
कशी आहे मॅडम सोनोग्राफी?
बरं, मी सांगते सगळं. तुम्ही बसा ना आधी. तुम्ही निशाच्या सासूबाई ना? बसा ना. आणि तुम्ही यजमान ना? हां, बसा बसा आधी, व्यवस्थित बसा, मी सांगते तुम्हाला सगळं. बरं सिस्टर, वरचे पेशंट तू बघ, एक 10 मिनटं इथे थांब. एक 10 मिनटं थांब तू इथे, आणि कुणाला आत येऊ देऊ नको. हां, कुठला फोन पण घेऊ नको. माझा फोन ठेवतो त्याच्यावर.
सो पहिला मुद्दा, डॉक्टरांनी स्वतःचा फोन पण बाजूला दिला. सिस्टरना सांगितलं की आत्ता आपण इम्पॉर्टंट डिस्कशन करणार आहे आणि प्लीज कोणाला आतमध्ये सोडू नका किंवा डिस्टर्ब करू नका. सो हे कम्प्लीट सेटिंगसुद्धा खूप महत्त्वाचं आहे या सगळ्या सिरियसनेस या इश्यूकडे बघता. पुढे.
बरं, कसं झालं आहे, मी आज सोनोग्राफी केली निशाची, पण गोष्टी फार काही छान नाही आहेत. गोष्टी छान नाही आहेत. बाळ बघितलं मी, बाळाचे ठोके जाणवत नाही आहेत, दिसत नाही आहेत.
म्हणजे
याचा अर्थ असा आहे, मला पण सांगताना तेवढंच वाईट वाटतंय सासूबाई, पण काय होतंय की बाळ गेलंय पोटात.
जोरात.
काय काय म्हणताय मॅडम?
हो, खरंच वाईट गोष्ट आहे, पण कसं आहे, आता मला सांगणं माझं काम आहे. बाळ नाही आहे.
अगं निशा, तुला तर बाळ हालचाल होताना जाणवतंय ना?
होते आई, अजून होते.
थांबा थांबा, डॉक्टर काय सांगतात ते नीट ऐकून घ्या. आपल्यापेक्षा ते
अहो मॅडम,
या विषयातले तज्ज्ञ आहेत, ते काय सांगतात ते नीट ऐकून घ्या आपण.
अरे गप रे जरा. अहो मॅडम, अहो मॅडम, पण ती म्हणती ना बाळ फिरतंय आणि तुम्ही म्हणताय बाळ गेलंय.
नाही, मी समजू शकते, कारण तुम्हाला आता मी अचानक ही न्यूज सांगितली, त्यामुळे तुम्ही पण जरा धक्का बसलाय तुम्हाला. पण कधी कधी कसं असतं, बाळाच्या पोटात म्हणजे बाळाभोवती जे पाणी असतं त्याच्या हालचालीमुळे पण कधीतरी हालचाल जाणवते. मी तपासलं आहे, सोनोग्राफी केली आहे, अगदी 2दा बघितलं पण नाही. आणि निशा मला सोनोग्राफी करताना मी तिला विचारलं, ती मला म्हटली की जरा 2 दिवस झाले बाळाची हालचाल जाणवत नाही आहे, थोडी कमी जाणवते. म्हणून मी पटकन आधी बाळाचे ठोकेच बघितले, पण नाही, जे मलाच वाईट वाटते पण आहे, जी गोष्ट आहे ती आता आपल्याला ॲक्सेप्ट करावी.
सो यामध्ये सुद्धा डॉक्टरांची बॉडी लँग्वेज कशी असावी, ही न्यूज सांगताना आपण दुसरं काहीतरी काम एकीकडे कॉम्प्युटरवर बसलोय, दुसरीकडे बघतोय, पेशंटकडे नजर भिडवत नाही आहे, ह्या सगळ्या निगेटिव्ह गोष्टी आहेत. सो समोर बसणं, समोरासमोर बसायला लावणं, त्यांना डिग्निफाईड आणि त्या पद्धतीने बसायला देणं, त्यांना त्यांच्या इमोशन्स एक्सप्रेस करू देणं, कारण केव्हा पण डिनायल हे असूच शकतं. पेशंटनी जरी म्हटलं की मला अजून दुसरीकडे सोनोग्राफी करायची आहे, हरकत नाही, आपल्याला परत करता येईल. म्हणजे ज्या पद्धतीने डॉक्टर आता त्यांना रिॲक्ट करतायत, सो त्या पद्धतीने त्यांना रिॲक्ट करायला देणं, तेवढा वेळ डायजेस्ट व्हायला देणं, हे सुद्धा महत्त्वाचं आहे. डॉक्टर पुढे.
हां निशा, तू काळजी करू नकोस बाळा, रडू नकोस, आहोत आम्ही सगळे इथे. तुम्हाला काही प्रश्न आहेत का?
का झालं हे मॅडम? काय प्रॉब्लेम आहे असं वाटतं तुम्हाला?
हे बघा कसं असतं, आपण फारशा केसेसमध्ये आपण नाही सांगू शकत का झालं. हो, पण तुम्ही म्हणताय त्या पद्धतीने हे का झालं हे शोधणं पण एक काम आहे. आपले आता 2 महत्त्वाचे मुद्दे आहेत. एक तर हे का झालं हे बघणं, म्हणजे जेणेकरून पुढच्या प्रेग्नन्सीमध्ये होणार नाही याची आत्तापासूनच काळजी घेणं. आणि दुसरी गोष्ट आता डिलिव्हरी करणं. कारण काय होतं की बाळ जेव्हा पोटात जातं तेव्हा ते नंतर आईसाठी पण त्रासदायक असू शकतो. म्हणून मला असं वाटतं की आपण आता दोघी गोष्टींचा विचार करूया. पण मी आधी सांगेल की निशाला थोडं सेटल्ड होऊ दे, तिचा BP वगैरे मी बघायला लावते सिस्टरांना. म्हणजे कसं होईल, ती जरा तिची थोडी मनाची तयारी झाली की आपण ॲडमिट करूया, आपण तिच्या काही ब्लड टेस्ट करून घेऊया आणि आपल्याला जर शक्य असेल तर आपण कारण शोधण्याचा नक्कीच प्रयत्न करूया. इवन पुढच्या काय तपासण्या कराव्या लागतील काय नाही याचं आपण सविस्तर बोलूया. पण मला असं वाटतं आधी तिला थोडा वेळ देऊया ह्या सगळ्या गोष्टींसाठी. तुम्हाला काही प्रश्न असतील तर विचारा, मी इथे आहे, तुम्ही केव्हाही मला प्रश्न विचारू शकतात. अगदी तिची डिलिव्हरी होस तोपर्यंत मी आहे सोबत, त्यामुळे तुम्ही काळजी करू नका.
मॅडम ती म्हणते अजून एक सोनोग्राफी करूया.
काही हरकत नाही आहे, मला चालेल. तुम्ही तुमच्या ओळखीचे कोणी डॉक्टर असतील तर सुचवा, मी अगदी त्यांचा पत्ता देते.
आमच्या गावाकडचे डॉक्टर आहेत, डॉक्टर दोशी म्हणून, त्यांच्याकडे करून घेऊ का?
चालतं, अगदी तुम्ही त्यांच्याकडे जाऊन सोनोग्राफी करून आले तरी चालेल. काय होतं की बरोबर आहे तुमचं की एक शेवटी कधी कधी आपल्याला वाटतं की तुम्ही फार उत्सुकतेने वाट बघतायत बाळाची आणि अचानक मी तुम्हाला अशी बातमी सांगितली, पण एक सेकंड ओपिनियन घेणं कधीही योग्य
नाही.
आहे.
आमचा तुमच्यावर अविश्वास आहे असं अजिबात नाही, पण एखादी गोष्ट मनाविरुद्ध झाली तर 2दा कन्फर्म केलेली बरी पडते.
मी तेच म्हणते, प्रश्न विश्वासाचा किंवा अविश्वासाचा नाहीच आहे. आपण करूया, तुम्ही म्हणत असाल तर दुसरी सोनोग्राफी करून घेऊया, माझी त्यासाठी काही हरकत नाही. आणि जेवढं तुम्हाला वाईट वाटतंय तेवढंच मला आज वाईट वाटतंय. पण मी सांगते की आपण निशासाठी पूर्ण प्रयत्न करूया, ती नॉर्मल डिलिव्हरी होते की नाही तेही बघूया. आणि पुढची गोष्ट की तिचं पुढचं काय होईल त्याच्यासाठी आपण आत्तापासूनच तयारी करूया, जेणेकरून पुढच्या प्रेग्नन्सीमध्ये होणार नाही. काही गोष्टी आपल्याला सापडल्या तर आपण त्या आत्तापासूनच तयारी घेऊया की त्या पुढच्या प्रेग्नन्सीमध्ये होणार नाही. तुम्हाला अजूनही प्रश्न असतील तर मला विचारा. आणि मी सांगते सिस्टरांना ॲडमिट करून घ्या, तिला झोपू द्या हवं थोडा वेळ, तिच्या ब्लड टेस्ट करून घेऊया, तिचे रिपोर्ट्स येऊ देऊया, मग आपण बोलूया. अगदी कुणी गावाकडून बोलवायचं असेल तर बोलवून घ्या, माझी काही हरकत नाही.
नाही झालं हे दुर्दैव आहे, परंतु तिला आता काही होऊ नये या दृष्टीने तुम्ही प्रयत्न करा. तिच्यासाठी लागेल ते औषध गोळ्या काही लागतील ते सांगा. ब्लड वगैरे लागणार असेल तर माझी ब्लड बँकेत ओळख आहे, मी तिथं सांगतो आणि औषधं काही लागतील तर सांगा. परंतु आता दुर्दैवाने आपण मूल गमावलंय, पण आईला काय होऊ नये एवढी काळजी घ्या आणि पुढच्या वेळेसाठी काय करू यासाठी आम्हाला मार्गदर्शन करा.
खरंच मी बरोबर सांगता तुम्ही. आपण आता ॲडमिट करून घेऊया, तिच्या टेस्ट करून घेऊया आणि पुढच्या वेळेसाठी प्रयत्न करूया. ब्लड आपल्याला अरेंज करावंच लागेल, कारण डिलिव्हरीत काय कॉम्प्लिकेशन होतील मी आत्ता सांगू शकत नाही. आणि तुम्हाला प्रश्न असतील की डिलिव्हरी कशी करायची काय, त्याबद्दलही आपण सविस्तर बोलूया. पण आधी सेटल्ड होऊ दे, तिला रूममध्ये कम्फर्टेबली ॲडमिट होऊ दे, आपण तिच्या टेस्टचे रिपोर्ट्स येऊ दे, मग निवांत बोलूया हवं तर. तोपर्यंत कुणी नातेवाईक असतील, तुम्हाला काही कुणाशी डिस्कस करायचं असेल तर करा, मी इथेच आहे.
थँक्यू व्हेरी मच. आता या कलाकारांसाठी परत एकदा जोरदार टाळ्या.
आणि ते बाळासाठी ते दातार डॉक्टर काहीतरी करतात, तसं पण काय असेल तर करून घेऊयात.
मॅडम थोडा खर्च पण कमी करा.
हो, आपण काळजी करू नका, आपण सगळं करूया. आणि त्या दातार सरांनाही मी इन्व्हॉल्व करते तुमच्या केअरमध्ये, बोलवून घेऊया दातार सरांनाही.
थँक्यू व्हेरी मच. एक्सलंट. सो आता मी आपल्या खऱ्या पॅनलिस्टना बोलवते स्टेजवर. हे सगळे आर्टिस्ट झाले. कोण कोण आहेत आपले पॅनलिस्ट? मगई मॅडम, अजित पाटील सर गेले की काय? गेले. दबडे सर, त्याच्यानंतर दुसरे पीडियाट्रिशियन दबडे सर आणि दातार सर. सो कुठल्या पण काउन्सिलिंग सेशनमध्ये स्पेशली काही बॅड न्यूज म्हणजे एक फिटल ॲनामोली असेल किंवा फिटल डिमाईस असेल, तरी पण या सगळ्या काउन्सिलिंगमध्ये त्याला म्हणतात स्पाईक प्रोटोकॉल. ओके, आहे अटेन्शन? सगळेजण बसले आहेत? सेट बसतायत? मग समोरचे बसताना बघतायत का? बरं. सो स्पाईक प्रोटोकॉलमध्ये पहिला S इज सेटिंग अप इंटरव्ह्यू, म्हणजे पूर्ण आपलं सेटिंग कसं असलं पाहिजे, मध्ये डिस्टर्बन्स नको वगैरे, हे सगळं झालं. दुसरं आहे पेशंटचं परसेप्शन काय आहे त्या गोष्टीबद्दल. बरेचदा तो रिपोर्ट घेऊन पेशंट आपल्याकडे आलेले असतात. जरी पेशंट म्हणते बाळ हलत नाही आहे, हलतं आहे, तरी पेशंटच्या डोक्यात एक थोडी आयडिया असते. रिपोर्ट येता येता त्यांनी वाचलेला असतो. सो आणि बॅड न्यूज कॅन बी इवन फिटल ॲनामोली, लिथल ॲनामोली, नॉन लिथल ॲनामोली. सो ह्याच्याबद्दल त्यांना काय माहिती आहे, तुला काय वाटतं आहे, तुम्हाला काय माहिती आहे. सो परसेप्शनचं त्यांच्या आधी असेसमेंट करायचं, तुम्हाला काय म्हणायचं आहे. त्याच्यानंतर पेशंटनी आपल्याला पुढे ऑब्टेनिंग फॉर पेशंट्स इन्व्हिटेशन, की आम्ही तुमच्याकडे का आलो आहे, हे थोडंसं इन्फॉर्मल वाटतं आहे आपल्याला, पण दिस इज वन पॉईंट. त्याच्यानंतर K इज गिविंग नॉलेज अँड इन्फॉर्मेशन टू पेशंट, जे आत्तापर्यंत आहे त्याची इन्फॉर्मेशन आणि त्यांना समजेल अशा भाषेमध्ये ती समजावून सांगणं, विदाऊट मच ऑफ मेडिकल जार्गनिंग. तुमचं बेबी IUGR आहे, त्याचा आत्ता MCA PI वाढला आहे, हे सगळे शब्द म्हणजे त्यांच्या डोक्यावरून जाणारे असतात. सो मेडिकल टर्म्स कमीत कमी वापरून समजेल असं सांगणं. B अंडरस्टँडिंग पेशंट्स इमोशन्स आणि एम्पॅथेटिक रिस्पॉन्स असला पाहिजे, की त्यांना काय वाटतं आहे त्याला शब्दरूप द्या. तुम्हाला वाईट वाटतं आहे, तुम्हाला राग आला आहे, तुम्हाला निराश वाटतं आहे, जे पण काही आहे तो शब्द बरोबर सांगा. आणि त्याच्यानंतर पुढची स्ट्रॅटेजी आणि पूर्ण आपण काय बोललो आणि आता काय करणार आहे याची समरी. सो हा इन जनरल स्पाईक प्रोटोकॉल. पॉझिटिव्ह आणि निगेटिव्ह फॅक्टर्स आपण बघितलेच. कसं क्लिअर आणि रिस्पेक्टफुल कम्युनिकेशन, सिम्पल लँग्वेज, डायरेक्ट आय कॉन्टॅक्ट, स्ट्रेट फॉरवर्ड एक्सप्रेशन ऑफ एम्पॅथी, फिजिकल प्रेझेन्स ऑफ स्टाफ, स्लो ड्रिप फीड ऑफ इन्फॉर्मेशन. एकदम बसाबसा खूप माहिती वर्गातल्या मुलांनासुद्धा लक्षात राहत नाही, तर इथे पेशंट जे ऑलरेडी काहीतरी डोक्यात गोंधळ घेऊन आलेले आहेत त्यांना एकदम सगळं समजणार नाही. सो थोडं थोडं त्यांना समजवा. टाईम टू कन्सिडर देअर ऑप्शन्स. आणि ट्रीटिंग स्टिलबर्थ इज अन इमर्जन्सी त्यांच्यासाठी, म्हणजे पेशंटसाठी. आपल्याला जरी वाटलं की आत्ता ही दुसरी इमर्जन्सी आहे तरी. सो ह्या सगळ्या गोष्टींकडे लक्ष देऊन आपण बॅड न्यूज ब्रेक केली पाहिजे. सांगताना आपल्याला काय सांगायचं आहे की IUFD म्हणजे काही अशी अपेक्षा धरू नका की मूल डिलिव्हर झाल्यानंतर ते जिवंत असणार आहे, पण हे चांगल्या शब्दामध्ये वेन अँड हाऊ टू डिलिव्हर अँड कलेक्ट एव्हिडन्स टू अ सर्टन कॉज ऑफ फिटल डिमाईज. दिस इज व्हेरी इम्पॉर्टंट. का असं झालं मलाही आत्ता माहीत नाही आहे, पण जसं जसं अनफोल्ड होतील गोष्टी आणि सिच्युएशन, विल ट्राय टू कलेक्ट एव्हिडन्स सो दॅट आपल्या प्रश्नांना कितपत उत्तरं मिळतील ते आपल्याला कळेल. सो आता या सिनारिओमध्ये याच्या पहिल्यांदा मी हे सांगितलं नाही. दिस इज ट्रू केस. 2015मध्ये ही पेशंट होती, 30 इयर्स त्यावेळेला, प्रायमी ग्रॅविडा. तिचा डेटिंग स्कॅन झाला होता आणि EDD वॉज 12/10/2015. क्वाड्रुपल मार्कर तेव्हा केलं होतं तिने आणि दॅट वॉज नॉर्मल. टिफा स्कॅन नॉर्मल रूटीन ANC प्रोफाईल. आणि 30 वीक्सला ती पेशंट आली. आल्यावर नो FHS ऑन ऑस्कल्टेशन. 30 वीक्स होती. बॅड न्यूज ब्रेक केली. आणि आता काय करायला पाहिजे आपल्याला? व्हॉट ऑल टेस्ट यू विल डन? डॉक्टर गायनेकोलॉजिस्ट दबडे सर सांगा. 30 वीक्सला IUFDची पेशंट आली तर युजली 2015च्या कॉन्टेक्स्टमध्ये, म्हणजे अजून 5-7 वर्षापूर्वी आपली स्थिती जशी होती, तर तुम्ही काय सांगाल पेशंटला? प्रॅक्टिकल सांगा. असे पेशंट आल्यावर काय करता तुम्ही?
I would like to go to her previous records basically.
तुमच्याचकडे येतील, तुमच्या प्रोटोकॉल प्रमाणेच ट्रीटमेंट सुरू आहे.
You mean to say it's an unexplained IUD?
अनएक्सप्लेन 30 वीक्सला ती आली. एकदम 28 वीक्सला गेली होती, नॉर्मल होतं. 30 वीक्सला IUFD झाली.
And I would like to have additional information as to what was her body mass index, because obese patients are prone to have unexplained IUDs, because as the routine teaching goes that whenever we are recording the blood pressure of a pregnant woman, we should be recording that in sitting position so as to avoid supine hypotension syndrome, so that we may miss the hypertensive patients in antenatal checkup. So these obese patients, when they lie down supine, it is a known fact
that they suddenly land into supine
Yes sir, but
hypertension.
now patient has come to you, she is known to you, BMI जास्त असेल तरी आपण आधीपासून तिला सांगणार की सुपाईन झोपू नको. मला म्हणायचं आहे की आयुडीची पेशंट आल्यानंतर आपण आता काय करणार आहे त्या पेशंटमध्ये इमिजिएट? काय काय इन्व्हेस्टिगेशन्स तुम्ही आता या मध्ये सांगाल?
CBC, routine investigation, renal function test, liver function test, and DIC profile.
येस, सो DIC प्रोफाईल आत्ताच्या कॉन्टेक्स्टमध्ये इम्पॉर्टंट आहे बिकॉज वी डोंट नो सिन्स वेन दॅट IUFD हॅज हॅपन्ड. रेस्ट ऑल रूटीन HIV वगैरे आपलं ऑलरेडी झालेलं आहे, शुगर ऑलरेडी झालेली आहे. मे बी आत्ता न्यू ह्याच्यामध्ये लिव्हर फंक्शन टेस्ट अँड किडनी फंक्शन टेस्ट. का बरं किडनी आणि लिव्हर फंक्शन टेस्ट?
To see before you induce, you should know whether the
general
general
status.
status like creatinine and all is normal or not.
ओके, वन थिंग. आणि सेकंड थिंग बरेचदा प्री इक्लॅम्शिया कॅन बी द कॉज असं म्हणून ब्लड प्रेशर. आणि IUFD स्पेसिफिक कोॲग्युलेशन प्रोफाईल. तुम्ही प्रॅक्टिसमध्ये कोॲग्युलेशन प्रोफाईलमध्ये काय करता या अशा IUD पेशंटचं?
PTINR.
आणि PTINR.
PTCT and PTT or PTP.
PTINR युजली बरोबर आहे. आपल्या सगळ्यांच्या प्रॅक्टिस सिनॅरिओमध्ये आपण इतपतच कोॲग्युलेशन प्रोफाईल करतो. FDP फिब्रिनोजन लेवल्स हे कोणी करतात का?
FDP we do, but even in slight PH patients also it is above normal. So it doesn't indicate whether she's in DIC or not.
या आणि युजली IUFD झाल्यानंतर हाऊ मच टाइम इट टेक्स फॉर कोॲग्युलेशन प्रोफाईल टू डिरेंज?
It takes at least 8 days for the coagulation profile to derange.
It's said that more than up to 4 weeks time also coagulation profile doesn't change, it changes after that. 15 दिवसापूर्वी पेशंट नॉर्मल होती, so unlikely to have deranged coagulation profile. Nevertheless, you can see. But what is important and many of us they don't do because it is not available is Kleehor-Betke count. So KB count, it is usually typically done only in RH negative patients to see feto-maternal hemorrhage. But feto-maternal hemorrhage is one of the cause of sudden IUD. आणि आफ्टर IUD you cannot diagnose it by MCA, PI or anything, but it can be only diagnosed by KB test. And this is the test which should be done before delivery as early as possible. कारण feto-maternal hemorrhage मधल्या fetal RBCs are very rapidly cleared off from circulation. So just in case that is the cause and that is the case, then definitely this was not avoidable IUFD. You know the cause या level. So this one test probably is one extra point. Then there are number of tests which we'll see later. So या पेशंटच्या ह्या सगळ्या टेस्ट तेव्हा झालेल्या होत्या. This patient was actually belonged to Mumbai, and so then they transferred to her to Wadia Hospital. वाडिया हॉस्पिटलमध्ये तिचं खूप APTT नॉर्मल होतं, हिमोग्लोबिन कमी, सीरम फिब्रिनोजिन वॉज लेस अँड FDP वॉज टू हाय. सो दे फ्रॉम वाडिया दे ट्रान्सफर्ड हर टू KEM हॉस्पिटल. ओके, आता अशा पेशंटला आपल्याकडे आहे, आपण FDP फिब्रिनोजन केलं पण नाही, PTINR नॉर्मल आहे. व्हॉट यू आर गोइंग टू डू नेक्स्ट टू दिस पेशंट?
I'll take her for induction of labor.
फॉर इंडक्शन ऑफ लेबर. तर तुमची प्रॅक्टिस काय आहे सर? हाऊ डू यू इंड्यूस सच पेशंट?
Either with dinoprostone gel or extra-amniotic saline instillation with the Foley's catheter.
Especially if she's a previous LACS extra amniotic
She's
saline.
primary gravida.
She's primary, then we can go in for misoprostol, 25 mg every 4th or 6th hourly.
Yes. So ओव्हरऑल याच्यामध्ये असं आहे की राईट नाव फिगो एव्हरीबडी इज रेकमेंडिंग ऑल IUFDs इरिस्पेक्टिव्ह ऑफ ट्रायमेस्टर. आपण त्यांना मिफिप्रिस्टोन वी कॅन गिव्ह 200 milligram. People give 200 in first trimester, 400 in second and 600 in third trimester because mifepristone nicely primes everything, and then abortion or delivery induction becomes very easy, and followed by 24 hours later induction by misoprostol. But whatever method suits everyone, do you recommend induction immediately आजच्या आज की she can go home, come back?
Not go home because patient is already psychologically stressed up. I would admit her, investigator wait for the reports to come, arrange blood and then proceed with the induction, because patient and the relatives they also want to start the procedure as early as possible.
इफ पेशंट्स इन्सिस्ट ऑन C-section बिकॉज लोकांची अशी समजूत असते की पॉयझन होतं आणि त्यामुळे आता लवकरात लवकर म्हणजे मेनी टाइम्स वेन पेशंट्स डिनाय LSCS वेन बेबी इज लिव्हिंग पण IUD झाल्यानंतर ते म्हणतात लवकरात लवकर सीझर करा.
Counseling plays a role in this. We have to counsel them that she can deliver normally. If at all she doesn't, then we can go in for cesarean section.
Very good. Now, especially during labor, आपल्याला काय काय बोलायला पाहिजे. पेन मॅनेजमेंट युजली आपण लक्ष पेशंट व्हॉइस करत नाही पण तिच्या डोक्यात ते कन्सर्न असतो की पेनबद्दल काय करायचं. सो पेन कंपॅनियन काउन्सिलिंग आणि नंतर लॅक्टेशन मॅनेजमेंट अँड ग्रीफ मॅनेजमेंट ऑल दीज थिंग्स नीड टू बी लुक्ड इन टू. आता बऱ्याच वेळेला काय होतं अशी पेशंट समजा ही फुल टर्म पेशंट आहे आणि सडन 9व्या महिन्यात IUFD झाला आहे. या पेशंटच्या मोठ्या बाळाचे पिडियाट्रिशियन आहेत तर नॅचरली सगळे लोक एक फाईल आणि सगळा फापट पसारा घेऊन दुसऱ्या डॉक्टरांकडे जातात. पेशंट समोर नसतोच आणि डॉक्टरांना विचारतात डॉक्टर काय झालं हो का असं झालं असेल. पहिली तर डिलिव्हरी त्या डॉक्टरांकडे व्यवस्थित झाली आणि आता हे सडनली असं झालं. डॉक्टरांनी सीझर करायला पाहिजे होतं का आधीच. तर पिडियाट्रिशियन डॉक्टर तुम्ही काय सांगाल.
Firstly, if possible, if such patient comes to me and if I see the file, I'll just tell them to wait for a while. If possible, I'd like to talk to the concerned obstetrician, what words that obstetrician has used in this mishap, so that my words and that obstetrician words should not differ. That number one point I would like to make. And secondly, what I would say is when the patient asks me whether LSCS was indicated, I would say that it's completely obstetrician's domain and that's not a pediatrician to comment about it, or nobody can decide about cesarean section other than your concerned obstetrician. That's point number 2. Point number 3 is sometimes patient asks whether this could have been seen in previous ultrasound we have been following for last 9 months. So at that time, what usually, I would like to also elaborate that sometimes patients with birth asphyxia also ask us the same question. So at that time, as a pediatrician, our answer would be, labor is a dynamic process. It's absolutely a dynamic process. And nobody can anticipate the probable complications during labor. So it is not preventable anywhere in the world, in fact. So that is what the answer I would give.
व्हेरी नाईस. देव करो आणि असाच पिडियाट्रिशियन सगळ्यांना मिळो. पण आय थिंक हे सगळ्यांनी आपण पण लक्षात ठेवणं गरजेचं आहे. आपण आपल्या आउट ऑफ फ्रॅटर्निटी कधीही ओपिनियन द्यायला जाऊ नये. किंवा आपण आता in case of IUFD, immediate delivery, is indicated if already membranes are ruptured or if it's abruption or sepsis. Otherwise, आपण पेशंटला ब्रीदिंग टाईम देऊच शकतो. जस्ट इन केस पेशंट वॉन्ट्स की गावाकडनं कोणी लोक येऊ दे, मला 2 दिवस थांबू दे, मिफिप्रिस्टोनची ॲक्शन होऊ दे, or anything. So if mother is stable, we can wait. Now this particular patient delivered at KEM hospital and look at the discharge paper. Is this information enough? 30 weeks, IUFD, first page and second page. And one more thing. Can you read this?
AP is sutured under all AAP.
Episiotomy was given.
1 kg baby episiotomy was given. आता आपण पण आपल्याच कलिगबद्दल बोलतो आहे. But then we need to remember certain things. की स्पेशली IUFD, preterm IUFD, vertex presentation, why there was episiotomy. So we need to pay attention to all these things. आणि मेथड ऑफ इंडक्शन त्यांनी तेच लिहिलं आहे की इट वॉज डन डेलिवर्ड. या सगळ्यामध्ये आवर नोट्स, clinical photographs are very, very important because at that point of time, we don't realize it's important. Patient rather doesn't realize the importance. And everything is just what you understand from discharge card is 1 kg baby weight, 1033 gram, male child, 30 weeks. याच्या पलीकडे काही information नाही. So, Dr. Datta, do you think with this old IUFD we should do and advise certain tests or at least take some sample?
Yes. So as we discussed in the morning, it was an unexplained IUD. So in these cases, we would document it properly. So usually if the pediatrician is available, they should be writing any dysmorphic features or any other features as such which are noted in the baby, the weight, etc. But if it is not, then at least some photographs of the baby help in documentation. Usually for such big babies, autopsy becomes a little difficult for two reasons. Because there's an emotional attachment, so disposal of the fetus is a big question. So in some of the cases, we can discuss this option, whether the couple wants an autopsy to be done on the fetus or not. Some of them would agree, some may not. Usually if they agree, the problem with disposal is there with large fetuses. So in such cases, we always get the fetus, do the necessary evaluations and give it back to the relatives for the further disposal. So that it's feasible if it is there in the same city where the autopsy is done. Otherwise, we have to do on photographs. The other thing is, in such cases, it's always a good idea to store some DNA sample.
Do we need to take consent for DNA storage?
So consent for both. So if it's autopsy also or it's DNA, we need to take a proper consent. DNA storage, it's like a paid test. So patient is agreeing to, he has paid the payment, so he is agreeing to do that sample storage. In case they want to do the further tests at that point, it's fine. Otherwise, we can defer it for later, but we should have some sample available for which at least a small piece, store it in saline gentamicin solution.
Okay, thank you, sir. As I was discussing earlier, mifepristone priming followed by misoprostol. If there is previous C-section, then probably misoprostol with caution or other PGD2 gel.
Now this particular patient, that was 2015, patient went home with that discharge paper. In between 2-3 years, she was trying to become pregnant. In between, she was studying and giving some exam also. So in July 2018, she came to us with 2 months of amenorrhea, all this history and record which I had shown, and LMP 25-2. And at that time, then she asked, doctor, why this happened in that pregnancy with that much evidence? आणि कसं पण करा, पण यावर्षी तरी मला मूल चांगलं माझं होऊ दे. So त्या evidence-वरनं I just put this thing in FMF chart and saw this baby was 2.5 centile. म्हणजे obviously ते FGR baby होतं. Early onset FGR, probably it was not detected. पण हे सगळं आपण काहीच म्हणू शकत नाही FGR baby. So आपण म्हणू शकतो की तिचं पोषण बाळाचं झालं नाही आणि FGR. So now I know that in this pregnancy FGR ची possibility आहे. Already ती आली आहे, 8 weeks झाली होती. हा मी मगाशी जो कॅल्क्युलेटर दाखवला त्याच्यामध्ये also it says बऱ्यापैकी या लाईनच्या खाली आहे. If you can see the dot. So it is less than 2.5 centile. एवढंच फक्त इन्फॉर्मेशन आहे आपल्याकडे. So mostly I thought that this was early onset IUGR. Same day dating scan was done, routine ANC profile was done. तिला परत NT scan साठी आणि डबल मार्कर टेस्ट साठी 12 weeks ला यायला सांगितलं. पण तिने सांगितलं मला हे काहीही करायचं नाही. मी पहिल्या वेळेला डाऊन सिंड्रोमसाठी क्वाड्रुपल मार्कर टेस्ट केली होती. काय झालं, टेस्ट नॉर्मल असून सुद्धा मला बेबी माझं असंच झालं. सो मला यावेळेला ते काहीही टेस्ट करायचं नाही. अँड शी डिडंट टर्न अप अँड शी कम स्ट्रेट अवे ॲट टीफा स्कॅन. सो टीफा स्कॅनच्या वेळेला एव्हरीथिंग वॉज नॉर्मल 19 weeks. एक्झॅक्टली 1 month later 24 weeksलाच शी केम की बाळ हलत नाही आहे. आणि पहिल्यांदा असं वाटलं 24 weeksला काय बाळ हलत नाही आहे. But then it was true. This was again second IUFD for this patient. Now at that point of time, HbA1c was normal, sugars were normal, TSH, VDRL. Part of ANC protocol जे आहे ते सगळं झालं. आता काय काय आपण टेस्ट करायच्या तर शुड वी डू बिफोर डिस्चार्ज, आफ्टर 6 weeks, आणि कॉस्ट खूप असते या सगळ्या टेस्टची. सो टप्प्याटप्प्याने करायच्या की एकदम करायच्या. ऑटोप्सीचा आपण दातार सरांना विचारला प्रश्न. ह्या पर्टिक्युलर प्रेग्नन्सीमध्ये आम्ही त्या पेशंटचं फक्त DNA सॅम्पल स्टोअर केलं. ऑफकोर्स पेशंटला ते पण समजलं नाही की काय आणि कशासाठी, कारण थर्ड प्रेग्नन्सीला ती माझ्याकडे आलीच नाही, परत भलतीकडेच दुसरीकडे होती. सो कंटिन्युटी ऑफ केअर नावाचा प्रकार नव्हता याच्यामध्ये. So which all test, doctor, you will suggest?
We can do homocysteine so that next pregnancy we can at least start folic acid and
So
B12.
तुम्ही कोणत्या टेस्ट काय सिक्वेन्सनी ॲडवाइस कराल? होमोसिस्टीन, ॲप्ला टेस्ट,
because torch is not at all going to
टॉर्च नाही केली.
We can do the protein C S antithrombin 3 after about 12 weeks. That is after 3 months from the
After delivery.
After delivery, that can be done.
Protein C and protein S.
Protein C, protein S, antithrombin 3, because that can, the non-APA thrombophilias are more likely to cause late trimester.
Very
diabetes.
true.
So, but the levels are distorted because of the pregnancy, so it has to be done in a post-pregnancy, in a non-pregnant state. So at least 3 months need to be given. APLA profile can be done immediately. Along with that, homocysteine levels is what we would go ahead.
Perfect, sir. So same thing, I mean, we usually do टप्प्याटप्प्याने टेस्ट एकदम सगळ्या केल्या तर 15-20 हजार असे एकदम होतात आणि पेशंट्सना वाटतं एवढ्या सगळ्या ब्लड टेस्ट. सो वन बाय वन, टॉर्च ऑफकोर्स आउट ऑफ क्वेश्चन. सो इम्युनॉलॉजिकल ANA और DS-DNA जी काही आहे इम्युनॉलॉजिकल टेस्ट. ॲप्लासाठी बीटा अँटी बीटा टू ग्लायकोप्रोटीन, IgG, IgM अँड व्हॉट एल्स, अँटीकार्डिओलिपिन, ल्युपस अँटीकोॲग्युलेंट. So these 3 tests. Now these tests came negative. So तुमचं सॅम्पल आहे. सो हा रिपोर्ट निगेटिव्ह आल्यानंतर नेक्स्ट प्रोटीन C, प्रोटीन S अँड अँटीथ्रोम्बिन हे तिन्ही थ्रॉम्बोफिलियासाठी. Amongst this, protein S is pretty common in Indian population. Rest 2 are quite less. So आमची प्रॅक्टिस होती आधी, we used to do only protein C and protein S. And that too there are 2 things, protein C level and protein C activity. Similarly, protein S level and protein S activity. What is important is activity. So दोन्हीच्या activities केल्या, they came negative म्हणजे normal. Then we told them to do antithrombin 3 आणि या पेशंटमध्ये इट केम पॉझिटिव्ह. सो हा सगळा पूर्ण लिस्ट आहे ब्लड टेस्टची, काय काय आपण करू शकतो. दिस इज अ व्हेरी नाईस आर्टिकल आपल्या याच्यामध्ये सडन IUFDचं विच ऑल टेस्ट अँड वाय अँड व्हॉट इन्फॉर्मेशन दे आर गोइंग टू गिव्ह. आणि हे सगळं झाल्यानंतर IUFD दिस पेशंट वॉज डिस्चार्ज, बट ॲट द टाईम ऑफ डिस्चार्ज इट इज व्हेरी इम्पॉर्टंट टू डू अँड डीब्रीफिंग मीटिंग. म्हणजे त्यावेळेला पहिल्यांदा जेव्हा घाईमध्ये सगळ्या काही गोष्टी बोलायच्या राहिल्या असतात किंवा आपण बोललो असतो पण पेशंटनी रजिस्टर केलेल्या नसतात, त्यामुळे ह्या सगळ्या गोष्टी डिस्चार्जच्या वेळेला किंवा फॉलोअप विजिटच्या वेळेला एक डीब्रीफिंग मीटिंग इज रिअली अ मस्ट. अँड ॲट दॅट टाईम इफ पॉसिबल गायनेकोलॉजिस्ट, पेशंटचा नवरा किंवा जे इमिजिएट केअर टेकर्स आहेत ते लोक, पीडियाट्रिशियन जर रेलेवंट काही पॉईंट असेल तर, एखादी बर्थ इंजुरी असेल पीडियाट्रिशियन, त्याच्यानंतर जेनेसिस्ट काही आपण त्याच्यामध्ये आपल्याला रेलेवंट फॅक्टर सापडला असेल. सो ह्या सगळ्या स्पेशलिस्टनी मिळून एक मीटिंग घेणं इम्पॉर्टंट आहे. अँड डॉक्युमेंट व्हॉट ऑल यू हॅव डिस्कस्ड, व्हॉट इज युअर प्लॅन ऑफ ॲक्शन, अँड हे सगळं सांगितल्यानंतर मेन्शन ऑल दॅट टू द पेशंट, कीप अ कॉपी विथ यू, सो दॅट सिम्पल आपला व्हॉट्सॲप फोटोग्राफ इज ऑल्सो मोर दॅन इनफ, बिकॉज यू नो की आपण ह्या सगळ्या गोष्टी पेशंट्सना सांगितलेल्या आहेत. Now same patient after delivery, her homocysteine was 38.6, anticardiolipin was normal, protein C and S activity normal. मग त्याच्यानंतर नेक्स्ट विजिटला ती आली, त्यावेळेला we did that antithrombin 3, HbA1c was normal. सो हे सगळे रिपोर्ट्स तुम्ही बघितले. आणि वाडियामध्ये दे वेंट अगेन बिकॉज आमच्या इकडनं गेल्यानंतर, अँड देन दे सॉट अन ओपिनियन फ्रॉम रुमॅटॉलॉजिस्ट ॲज वेल ॲज हेमॅटॉलॉजिस्ट. Rheumatologist said ANA, DS-DNA, everything is normal, there is no immunological cause, nothing doing, go to hematologist. Hematologist very clearly said that start anticoagulant after conception, from next pregnancy, from viability plus ecosprin, which ways I think our protocol, म्हणजे आता हे एवढं झाल्यानंतर every one of us will agree to that we are going to start anticoagulation. Now this was March 2019, थर्ड प्रेग्नन्सी. यावेळेला पेशंट माहेरी गेली, विरारला, आईकडे का मामाकडे कोणाकडे तरी. आणि प्री प्रेग्नन्सी फॉलिक ॲसिड तिला स्टार्ट केलं होतं ऑलरेडी. पोस्ट वायबिलिटी क्लेक्सन चालू केलं डॉक्टरांनी, इकोस्प्रिन ऑल्सो वॉज स्टार्टेड. पण तिला मध्ये मध्ये स्पॉटिंग, ब्लिडिंग असं सगळं होत होतं आणि त्याच्यामुळे ते इंजेक्टेबल, अर्ध गुगल, अर्धी इन्फॉर्मेशन असं सगळं करून पेशंटला वाटत होतं की दिस इंजेक्शन इज द प्रॉब्लेम, इफ माय ब्लिडिंग कंटिन्यूज आय एम गोइंग टू अबॉट. सो ती बरोबर घेत नव्हती. व्हॉट इज युअर एक्सपिरियन्स इन प्रॅक्टिस ऑफ हेपॅरिन इफ पेशंट हॅज अ ब्लिडिंग स्पॉटिंग हू इज ऑलरेडी ऑन हेपॅरिन, I mean low molecular weight heparin? What do you suggest? Will you stop ecosprin, aspirin?
I first look at the reason I started ecosprin and heparin, and if it was justifiable I would continue it. in spite of.
Now, in this patient, it is justifiable. She is
It is
antithrombin
justifiable.
3.
Yeah, I would continue that.
You would still continue.
I would continue.
You will. Opinion of the house? Everybody will continue in spite of the bleeding. She also continued, but like in between probably she had missed. But what happened? Despite that, जेव्हा ती 12th वीकच्या स्कॅनला गेली, NT scan, can you read? NT was 7.2 millimeters. So this was abnormal. Nasal bone not seen, ductus venosus abnormal wave pattern, and she aborted. तिला नशीब तेवढं कळलं की she has not aborted because of Clexane, but then she aborted. They sent the POC for analysis, and it turned out to be trisomy 18. Now with this trisomy 18, is there any role of parental karyotyping, sir?
Generally, trisomies it's not required, but with a bad obstetric history, it's always better to do a parental karyotype. Since she has come with 2 previous losses.
3 now.
3 now. And so it is better to do a parental karyotype in this particular case.
And only karyotyping?
Karyotype, not microresonance.
So Dr. Hema has done her, she has suggested, they have done, and both karyotyping was normal. So now this is 4th pregnancy. In 2021, she comes again back to us, and this time 6.2 weeks, heartbeat दिसल्याबरोबर we started her on heparin. आणि looking at her की ती कधी धर सोड करून जाऊ शकते. So I just wrote one plan, if you can read it on the left side, that what we should be doing. 12 to 14 weeks NT scan, then double marker, then ANC profile, पुढे 16 to 18 early anomaly scan and Doppler, 20 weeks anomaly, आणि late gestation मध्ये every 15 days she will be undergoing scan आणि growth analysis. So त्याप्रमाणे everything was okay. Now the new player came into picture. See her GCT. We do a glucose challenge test at 1 hour, at 2 hours, both. It's like extended OGTT. So that was high. That means in this pregnancy, she had GDM also. So that is one added thing. आणि या वेळेला तिला लक्ष न देण्यासाठी एक कारण होतं ते GDM. म्हणजे she was pretty sure that she is going to take injection Clexane or heparin, sorry, ecosprin and lonopin, but GDM she was quite dilly-dally. Then from 32 weeks onward she started taking metformin, and then looking at that with previous history, we suggested her delivery at 36 weeks itself. Is it justified? Dr. Gynecologist दोन्ही सांगा.
If her glucose was well controlled.
Her glucose was poor control. I mean not checked.
And she reported what gestation?
She is SGA, smaller baby, but like her on the higher side, which I used to think maybe because of her sugar.
A poorly controlled GDM at 36 weeks, I would deliver. I would not wait for her to cross 37, 38 weeks. Because already the sugar.
And if there was no GDM, then in this case, you would have delivered at what time?
At 37 complete weeks.
37 complete, madam.
37.
Opinion of the house? 36.
It depends upon the doctor.
Even if there is GDM or no GDM. No GDM and Doppler's normal, 37 weeks, right? Okay. So, because last week, after 35, 36 weeks, anxiety piles up like anything. If this patient in this pregnancy comes with abruption, you had it, you know. So delivery at 36 weeks. Delivered normal delivery, as again Foley's induction, 2.4 kg, 2nd degree perineal tear, baby cried immediately, good Apgar. Only thing is baby had fracture clavicle. Imagine 2.4 kg and fracture clavicle. There is no reason, there was no shoulder dystocia. As baby delivered, we heard a click and then something काहीतरी wrong आहे असं वाटलं म्हणून एक्सरे केला तर एक clavicle fracture आहे. डॉक्टर तुम्ही काय सांगाल fracture clavicle?
Firstly, I will examine baby thoroughly for any other injury there, and secondly, this being a very high-risk pregnancy and mother's glucose levels were not well controlled, I will closely monitor blood sugars of this baby. And secondly, with this being a very high-risk baby, I will certainly plan for newborn screening of this child. A
correct.
few words on newborn screening. Such high-risk baby, if they're affordable, you can go straight all out. That 7 routine newborn screening like congenital hypothyroidism, congenital adrenal hypoplasia, then G6PD deficiency, phenylketonuria, galactosemia, cystic fibrosis, and apart from that, we can go for 30 to 40 other, that is TMS screening also, if the family is affording. If family is not affording, at least these 7.
So extended newborn screening.
And I would like to take this opportunity to say that National Neonatology Forum, NNF, strongly recommends newborn screening of all newborns, even though there is no risk. First, primary, full-term, healthy newborn, still please go ahead, start doing newborn screening, at least for congenital hypothyroidism, congenital adrenal hypoplasia, and G6PD deficiency, along with hearing assessment of that child and simple pulse oximetry, just to check any cardiac anomaly.
Very good, sir. I think what you are suggesting is very true, and whether it's high risk or low risk, basic newborn screening should be offered to all. Like how now we are doing aneuploidy screening offering to all. So newborn screening, and one can make a strategy of including newborn screening in your hospital package so that it doesn't come to the cost and patient
in fact,
will not deny that just for the sake of cost.
In front of all obstetricians, that it is many times obstetricians think that pediatricians should do it. But unfortunately, patients listen to obstetrician rather than pediatrician. So unless obstetricians take interest in newborn screening, it's not going to work. It's not going to work. Because they think that madam ni तर सांगितलं सगळं नॉर्मल आहे काय हा बाबा काय सांगतोय.
म्हणून आज कान टोचायला सोनाराला इकडे बोलवलंय आपण. So, sir, बरोबर आहे, पण anything about fracture clavicle, I don't have personal experience. They used to say unfractionated heparin causes osteoporosis in mother. Baby मध्ये असं काही आहे relation? Anyone knows?
You can do a skeletal survey in general just to look for any osteopenia, as OGI like 15
Okay.
Just do a general skeletal survey.
Okay.
If it is normal, then just.
Right now, our pediatrician just counseled patient that it is always better to have a fracture clavicle than a Erb's paralysis. Of course, 2.4 kg you won't expect, but during process of induction, maybe liquor has drained completely, baby was, kind of jammed, and hence the fracture. But then, as you correctly said, and overall...
Even in case of accidental, if there is Erb's palsy also, reassurance is the only thing. There is nothing to get panic about it. And we can reassure the patient that it's completely treatable illness.
Good. And then small baby, 36 weeks and 2.4 kg. Sir, as you correctly said earlier, we have to keep a watch on sugar. How frequently should we monitor sugar? Can we do it by glucometer in the ward itself?
Yeah, we can do it in...
and how frequently?
Yeah, we can keep...
GDM mother.
Yeah, if mother is well motivated and giving breastfeeding, we can keep baby with mother, but strict close monitoring of blood sugar every 2 hourly initially for first 6 hours, and then 6 hourly after that is a must.
Any other challenges which we may expect during her first week of life, baby's first week of life, apart from sugar? Next day, this baby was very jittery.
Yeah, hypocalcemia can be there.
Hypocalcemia, right. Hypocalcemia, polycythemia, hyperbilirubinemia. So all those 3 hypos and 2 hypers, we need to look at it. So this is...
Usually we recommend to shift this baby. Baby IDM should be ideally kept in NICU for first 24 hours because...
If it is IDDM, yeah. This was GDM.
Because hypoglycemia in a newborn is a very, very bad scenario. I mean, babies have very bad neurological outcome.
Very true, but that is the thing that if patient GDM, we need to keep a watch on baby. We should be knowing, our staff can do sugar monitoring, sugar levels. They should be knowing की किती sugar बाळामध्ये असेल तर त्याला कमी म्हणायचं. Early breastfeeding आणि हे सगळे आपले protocols आपल्या labor roomचे should be in place and they should be followed by all nurses. Dr. Doshi, agreed? Who has taught this to our nurses? By the way, लक्ष्य मान्यता teaches our facilities, our hospital nurses, या गोष्टींकडे बघायला लागत नाही आणि या सगळ्या गोष्टी बरोबर वेळच्या वेळेला होत राहतात. आता ही लास्ट केस आय थिंक जस्ट अन आय ओपनर फॉर एव्हरी वन. इट्स 2 केसेस आहेत. एका दिवशी बॅक टू बॅक दोन्ही मुस्लिम पेशंट्स, पेशंट ए अँड पेशंट बी, दोन्ही पण कॉन्सॅग्विनस मॅरेज, दोघांची पण आपल्या मामाच्या मुलाबरोबरचं लग्न झालेलं. दोघी जणी 7 वीक्स अर्ली प्रेग्नन्सी, एक 7 वीक्स एक 8 वीक्सला आली, दोघांचे पण L0. नाउ दिस फर्स्ट पेशंट, शी इज सेकंड ग्रॅव्हिडा P1 L1 but died at 6 weeks. She had her records, uneventful antenatal period, 39 weeks early laborमध्ये LSCS was done for meconium stained amniotic fluid, 3.4 kg baby weight, so perfectly normal. 4 दिवस baby was in NICU, discharged normally with mother, breastfeeding continued, readmitted again. जेव्हा 6 weeksला baby went to the pediatrician, pediatrician said that this is a sick baby, we need to admit, and they realized that baby is really in bad shape and cannot be helped, आणि म्हणून they took discharge against medical advice and baby died 2 days after Lama. Second patient, similar history, first 39 weeks normal delivery, fresh stillborn from history. जाईपर्यंत बाळ चांगलं होतं, बाळाचे ठोके ऐकले होते, पण बेबीनी क्राय नाही केलं, मला बेबी दाखवलं नाही, मला माहीत नाही, पण चांगलं होतं म्हणतात. अंदाजे 3-3.25 किलो असेल. प्रेसिपिटेड डिलिव्हरी होती का? नाही. ॲडमिट झाल्यानंतर 11 वाजता ॲडमिट झाले, 4 वाजता डिलिव्हरी झाली. सो नॉर्मल डिलिव्हरी, नथिंग यू कॅन एक्स्ट्रॅक्ट फ्रॉम हिस्ट्री. सेकंड बेबी, शी हॅड 2.5 kg मेल, दोन्ही पण मेल बेबीज, क्राईड आफ्टर बर्थ. 5व्या दिवशी डॉक्टरांनी सांगितलं बाळाचं पोट फुगलं आहे, ऑपरेशन केलं, डिस्टेन्शन आहे म्हणून सर्जरी, बेबी डाईड. बोथ ऑफ देम केम टू अस. आता हे दोन्हीसुद्धा, दिस इज नॉट RPL पर से, पण ॲडवर्स पेरिनेटल आउटकम, अँड वी डोंट नो वेअर टू स्टार्ट. पण पेशंट एची ही डिस्चार्ज समरी आहे, अँड आय सजेस्ट की तुम्हाला वाचता ती यावी, पण नाही येणार. सो इम्पॉर्टन्स या डॉक्युमेंटेशनमध्ये त्यांनी काय लिहिलं आहे, बेबीला काय काय आहे, चाइल्ड हॅज हायपोटोनिया, मॅक्रोग्लासिया, हेपॅटोमेगॅली, लॅब पॅरामीटर्स, transaminase increase, elevated LDH and CK. With these findings and history of consanguinity, they made a diagnosis of Pompe's disease. So with this diagnosis, now we know where to start. आत्ता प्रेग्नन्सीत आल्यानंतर सुद्धा what should we do, doctor?
This patient has come with a 7 weeks pregnancy. This is the second patient or first?
This is first patient, 7 weeks pregnancy, first loss, Pompe's disease.
Now, Pompe will have many other differentials also. So, Pompe is more of a neuromuscular, so it can be a spinal muscular atrophy or any other neuromuscular disorder can be differentials. So, one is sometimes we ask for a dry cord sample if they have stored. So, many parents, there is a custom to keep the dry cord sample with them. So, we can investigate that dry cord directly by exome sequencing for the mutation.
This baby's blood is stored.
Then best that will be, we can do it on the blood sample directly, but most of the times even if it is a blood spot which is available for TMS, you can get it, can get the spot and do it from that. Otherwise we ask for dry cord, isolate the DNA, and we'll need to do an exome sequencing along with the SMA MLPA separately. So once that is done, we can do it either as a single or as a trio to save time, because if they have come with the next pregnancy, we should get a diagnosis first and then discuss the risk of recurrence, which could be around 25% based on the overall presentation that would be there.
True. And second patient, we don't have any clue. History वरून काहीही आपण अंदाज बांधू शकत नाही की काय झालं असेल. आणि दोन्ही बेबीजमध्ये डेफिनेटली बोथ मेल बेबीज, बोथ डाईड. Apparently there was no labor complication. So या थर्ड प्रेग्नन्सीमध्ये अगेन वी डोंट नो, वी आर स्टार्टिंग, म्हणजे इंडेक्स चाइल्डचं काहीच नाही आहे सेफ. So I think it is very, very important. I just wanted to give this as a take-home message for us. Whenever we face to any adverse situation, try to document as much as possible. Keep a copy with patient, with PDF copy with you, which any time can be retrieved and can be given to the patient during her next pregnancy. Debriefing meeting is very, very important to avoid such recurrence. even for pediatricians, I mean, this patient goes and lands up with pediatricians, and at the end it is just written patient came, infection, died, khatam. There is nothing stored. I mean, it's the last possibility they think of any metabolic or any genetic disease, unfortunately. So at that point of time, even we don't know anything, at least keep some evidence, some thread, so that it can be investigated further. In today's scenario, I think after getting to that level of years of practice or getting old, साध्या शब्दात बोलायचं झालं तर, you are going to face more and more patients, and असं झालं, डिलिव्हरीत असं झालं, ॲडव्हर्स आउटकम. सो जसं वय वाढत जातं तसं ॲडव्हर्स आउटकमचे पेशंट्स आपल्याकडे जास्त येतात, प्रिव्हियस ॲडव्हर्स आउटकम. अँड इफ वी वॉन्ट टू इन्व्हेस्टिगेट, it's better that we all should document all these things possible, all possible things document properly and appropriately, so that at least further investigating becomes a bit
and also
easy.
Store samples wherever feasible, store DNA.
Correct. And काही doubt असेल तर at least DNA storage. And what is the cost, sir, for DNA storage?
It costs around 2,000 to 3,000 max.
So it is not that bad, DNA sample can be stored for few years, आणि नंतर त्यांची monetary स्थिती आल्यानंतर, or you can arrange for some charity or something, and then further investigation is possible. Thank you very much, remaining people, for your patient hearing and presence. Thank you.
I request Anjali ma'am to please felicitate ma'am. I request Suchita ma'am to please felicitate our panelist, Dr. Vikram Dabde sir. Dr. Nanda ma'am. Dr. Chaitanya Datar sir. Dr. Rajiv Dabde sir, please. Rajiv Dabde sir.
I thank OBGY Society for inviting me. Thank you.
I request Jamma madam to felicitate Dr. Archana, Dr. Nisha, Dr. Prajakta, Dr. Shruti, Dr. Doshi sir.
एक फोटो घेऊन सगळ्यांचा मिळून एक सर आपल्या स्किटचा एक फोटो